One, two. Group ya Kindiki. Wana vokali.
This is Hendrix Sound.
Moyo wangu ina viraka juu wengi walinimess, ila tangu kukupata I swear nasikia best. Na wakitukazia njo turuke fence, penzi letu telemundo, nobody can contest. Kidogo ukinigusa mwilini napata goosebumps. When I am with you ni ukweli tu, I'll do anything for love. Nimpole tena msupa, moneni figa ya chupa. Nikiwa na ye mnisamehe, I'll do anything for love. Nakungoja kuliko chai ya saa 10 usiku mchana, ni wewe tu ndo nawaza. Nasubira wantuliza vizuri, nangoja fursa nikupeleke kwa mama. Tararara, tararara, Gimamara mari, c'est la vie my darling. Tararara, tararara, nishaona mbali, you're the one I wanna marry. Mama, wengi wanatuongelea kila siku ni songi, hawatujui usiachuna. Kiridao, I will keep you company. Kiriwaya mayabebo ile virundo. Wacha waseme ni kamote, hata waseme ni dumba. Penzi situ andale, tusirudi nyuma. Umoja kuliko chai ya saa 10 usiku mchana, ni wewe tu ndo nawaza. Nasubira wantuliza maramari, c'est la vie, my darling. Ta-da-da-da, ta-da-da-da. It's you're the one I'm gonna
try to save me, and I see it from the beginning. You are mine. From the start, you were doing it all by yourself. And you call me just to hear it, 'cause it mattered to you to know that you do it well, babe. I see it, yeah, I want it. Something about the way you hold me, babe. Nataka tukutane mbali mimi na wewe and nobody else. There is something, baby, about the way you carry it well. That's how I know that you are my love, and I'm certain that you are my love, baby. Yeah, I see it, twende mbali, wakuone ukiwa nami. Yeah, I see it, baby, ni wewe, baby, ni wewe. Yeah, I see it, no denying. Right from the corner of my eye, see you won't go. I see it, baby, ni wewe. Something about the way you look at me just screams it, that you know it, babe. Something about the way we think alike, there's no denying you are mine. That's how I know that you are my love, and I'm certain that you are my love. Yeah, baby, yeah, I see it, twende mbali, wakuone ukiwa na mimi. Yeah, I see it, baby, baby, yeah, I see it, no denying. Right from the corner of my eye, see you won't go. I see it, baby,
Ukona trust issues, kila siku unanishuku. Kazi zangu za usiku zinakukera sana. Oh no, na vile we ni msupu, umepewa kila kitu. Rafiki yako ndiye sumu, anakuchocha sana. No, hapana, sikukuwa huko jana. Unapenda kugombana sana kila saa. No, hasira imegeuka hasara. Ingawa tunapendana, nimechoka sana. No, mina, na itakuwa tu sawa hata tukiachana, mina, na itakuwa tu sawa hata tukiachana. Nenda lote ma, 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 nenda lote. Kuna trust issue, na saa zingine naonaga wivu. Jumanika wako na kakitu, so siku hizi unyombagi kitu. Hata ya vitu na ni sawa tu, hata kama haurudi siku. I hope and pray the things that you do never hurt me and you. Sitadanganya, nilikesha studio jana. Baby, mimi ungangana, kila saa, na hasira ikigeuka hasara. Si unajua nakupenda, baby, so I don't wanna fight you, no. Oh, itakuwa tu sawa, hata tukiachana, mina. Itakuwa tu sawa, hata tukiachana, mama. Nenda lote, nenda lote, mama. Nenda lote, mama. Nenda lote, mama. Nenda lote, sikukuwa huko jana, unapenda kugombana sana kila saa, hasira ikigeuka hasara. Ingawa tunapendana, imebidi tumeachana.
Shauri najua uko maji, design me ukucheki we ni mali. I wanna make it so real but sina mali. Baby make me feel new, nisiende mbali. Unajua vile mi uchoka, wakati ujibu na roho ikotoka. I try keep it cool, siwezi toka, but you got me locked kama jela niko locked, girl. Love ni evolve, ukisoma na nyuma, lakini nasema utaipata mbele na nyuma. Akiwa lai, mi nakudai, naka unitaki basi we utadai. Cheki my boys vile wanatembea, when they look at you waupiga binja. Oh, design tu, vile me ufeel low, na feel wivu manze boo. If you just see your wamba ni ya tu. Cheki vile wananibo, wakisema hatimisi wako boo, lakini ikisima mindo uchimba. Hata wakisema du, mini wako, weni wangu manzebu. Najua sometimes you amini vile na feel my heart is bleeding. Feelings zangu ziko loud, niko needed, but I keep it calm like kama weather ya Malindi. Tulikosana, now we ghosting. Mapenzi moto imekuwa sasa frosting, but mi bado niko posted kwako, na unaweza nioso kwako. Hila haiwezi bako, siwezi kuchorea vile wewe uniride kama sako. For love na loyalty, si mystery, let's history. Love ni evolve, ukisoma na nyuma, lakini nasema utaipata mbele na nyuma. Akiwa like mi nakudai, naka unitaki basi we utadai. Cheki my boys vile wanatembea, when they look at you waupiga binja. Design tu, vile me ufeel no, feel wivu manzebu. If you just see your wamba ni ya chu. Cheki vile wananibo, wakisema hatimisi wako boo, lakini ikisima mindo uchimba. Hata wakisema du, mini wako, weni wangu manzebu. Maybe we are in corners, relationships drive so cold, man. I feel like back to the old guy who was broken and dusted and no chosen by you. Maybe we have in corners, relationships try so cold, man. I feel like back to the old guy. Ukisoma na nyuma, lakini nasema utaipata mbele na nyuma. Akiwa like mi nakudai, naka unitaki basi we utadai.
Where she take wine on my face, I know she the one wanna take her home. Napenda your design and I take control. I take it as a sign, she go take my soul. See whatever the price I go pay, Nimejituna twice, wewe si ndoto. Body so divine, she an angel. A diamond, no pressure. I wanna catch you, catch you, catch you. Catch it for life, love you for life. Catch you, catch you, catch you. Catch it for life, love you for life. Catch you, catch you, catch you. Catch it for life, love you for life. Catch you, catch you, catch you. Catch it for life, love you for life.
Fine kawaii na makitiket. Just my type, sina mwingine. Vibes on vibes, a DJ on replay. Respect, hips don't lie, Shakira shindo. Hapo TikTok live, sa sita weekend. Wanna gift all night, hadi amalize. After that na slide, ndani ya DM niingize. Box inside, ndani ya dipstick. When the reason my ex was quine, nilizied. Tell you you no slow wine is to be vibes ni mutual looking wine yes yes me kuwa cushion ndio kama kale
Catch it for life, love you for life. Catch it, catch it, catch it. Catch it for life, love you for life. Catch it, catch it, catch it. Catch it for life, love you for life. Catch it, catch it, catch it. Catch it for life, love you for life. Bado nakudai, lakini ukiwine, nazirai, wanauliza why. Bado nakudai, lakini ukiwine, nazirai, wanauliza why. Bado nakudai, lakini ukiwine, nazirai.
Soul generation, this is another one, yeah. Hey lovely, umekuja na nani? Juni meno kivlo na cheka so bubbly. Nipe mechi ya tatupiga ka friendly. One time nikuonyeshe mapenzi, but your auntie hapendi wanati. Kwanza kiniona anaonanga bangi. Hata baba yako amenishika mashati. Ila naomba wewe unipe nafasi, yeah. The good times are calling. Why you ignoring? Don't say you're boring. And my heart is ready for you. The fun times are calling. I should be loving you. If I had to, I'm sorry. But tonight I came here for you. And I'm at your doorstep. Niko mavela na zimenishoni wewe. Nitapisha hadi babako watoke. Jusitoki hapa mpaka we utoke, yeah. At your doorstep. Niko vela na zimenishoni wewe. Nitapisha hadi babako watoke. Jusitoki hapa mpaka we utoke, yeah. Nitapisha hadi babako watoke. Jusitoki hapa mpaka we utoke, yeah. lazimisha ni wewe, nitapisha hadi baba kwa watoke, jisitoki hapa mpaka wewe utoke, yeah, yeah.
Inside and out, feeling so good and there is no doubt. I love you, baby.
Baby, baby, nimeshakuvisha taji, pale chumbani nimekuvulia shati. Baby, baby, umeniweka hewani, I'm high on your love.
I love you, I love you, I love you. Yeah. Nobody loves you like I do. I love you. Nobody loves you like I do. I got you, I got you, I got you. Nobody's got you like I do. I got you. Nobody's got you like I do, like I do. Like I do.
You give me good vibes every time. Nikiwa nawe siweza ngiponda. Me if you wonder if I'm losing my mind. Napenda vile unavyodondosa.
Baby, baby, nimeshakuvisha taji, pale chumbani nimekuvulia shati. Baby, baby, umeniweka hewani, you got me high all day. I love you,
I love you, I love you, I love
baby
you.
girl.
Nobody loves you like I do.
I love you,
I love you.
yeah.
Nobody loves you like I do.
Baby,
I got you, I got you, I got you. Nobody got you like I do. I got you. Nobody got you like I do, like I do. Like I do. I see you playing for you every day. I wrote this song for you, baby. I think of you on the daily. Your beauty lights up my way, babe. My baby, baby, nimeshakuvisha taji, pale chumbani nimekuvulia shati. My baby, baby, umeniweka hewani. You got me high all day. I love you, I love you, I love you, I love you. Nobody loves you like I do. I love you. Nobody loves you like I do. I got you, I got you, I got you. Nobody's got you like I do. I got you. Nobody's got you like I do, like I do. Like I do. Calm down, let me see what you done. Have a little splash in my calling all them shots with a little motion. Calling all them shots with my little motion. Last night you had a hold of me, telling me all of the secrets you tell nobody. First time I saw your whole body. Maybe I'm reaching, but girl, you got a show for me. You have my full attention. You giving me a ride of my life with that punani. Baby, you need a mention. You take me by surprise with your tights, cause I tsunami. Calm down, let me see what you don't wanna have a little splash in my little ocean. Calling all them shots with a little motion. Calling all them shots with a little motion. Calm down, let me see what you don't wanna have a little splash in my little ocean. Calling all them shots with a little motion. Calling all them shots with a little motion. Time flies, nikiwa kwa ocean. Kuna vile many bamba with that little motion. Madam, wine slow, let me see you watch it. Madam, wine slow, let me see you watch it. You have my full attention. You giving me a ride of my life with that punani. Baby, you need a mention. You take me by surprise with them tights, cause I tsunami. You have my full attention. You giving me a ride of my life with that punani.
Good morning.
Baby, you need a mention.
Tuliombewa jana leo, ama leo tunaomba tena? Haya sawa. Mko poa lakini? Thank you so much for coming this early. I will ask my dear colleagues here tupate maombi ya Mungu. Angalia kana.
Let's stand up and pray. Let us bow our heads. Heavenly Father, we thank you for the gift of life. We thank you for this morning. We thank you for giving us journey mercies to arrive here safely and in good time. Father Almighty, we pray for your blessing as we begin this session. We pray that you may guide our discussions, that you may help us to enrich ourselves so that we may be able to serve our patients better. Through Christ our Lord we pray. Amen.
Good morning once again. Good morning once again. Thank you so much. You guys, you are amazing. Jipigeni makofi kwa kurauka. Angalia jirani yako, unamjua ni nani? Angalia jirani yako. Unamjua kwa jina, sio kwa sura tu. Unamjua kwa jina? Haya, angalia nyuma yako kama kuna mtu nyuma yako. Unamjua nani yuko nyuma yako? Yeah, so the main aim of conferences usually is interacting and building connections. These updates, we can always get them online. We can get them everywhere. But remember, conference main aim is those meaningful interaction, building connections for future collaboration. So make sure you leave here at least 5 new connections to ensure you're going to do your collaborations. Even our team here, tunafanya pamoja lakini hatuonani. Leo pia tumeonana. Makofi kwetu. Okay, so I'm happy to start our today's session on the elephant in the house, which is about obesity. I have an amazing panel over here. So I have an amazing panel over here. I have Dr. Caroline Mithi. Mkono juu. Yes, I have with me also Dr. Roslyn Gogi. I have with me Dr. Pauline Lintari. I have with me Dr. Michelle, and I have with me Robert from the nutrition department. Thank you so much. So without taking further ado, I will invite Dr. Caroline Mithi to kickstart the session. Karibu Daktari. So Dr. Caroline Mithi, she's an endocrinologist, obesity specialist, and fellow MSc of University of Wales Obesity. So I could have many big hats. Atajiintroduce mwenyewe. Thank you.
Thank you, Abeid. So thank you, Dr. Abeid. We'll just go straight into it. I think the discussion has been globally and in the medical world now is about obesity and how it has influenced many other conditions. And so we just wanted to give a brief, but not only obesity by itself, but also how does it relate with diabetes? How does it relate with the kidney, the heart, oncology, nutrition? So this is a multidisciplinary team. Efforts. Okay. So if you look at how, if you're seated 2 of you, 1 in 2, one of you will have obesity or overweight or has in the next 9 years. Yeah. So choose who it will be. I'm hoping none of us here, but it's just saying that this is common. Like in the next 10 years, 50% of us will either be overweight or have obesity if we are not yet there. And so it's something that we need to do. Okay, so how do we define obesity? This is just an introduction so that we lay the groundwork for the other teams, and then we'll come back again and look at the management. So we define obesity now as a chronic, relapsing, progressive disease. So this is important, that's why it's highlighted, meaning that now, if you're asked, obesity now is like diabetes or hypertension because it is a chronic disease. It is progressive. Just go back to the previous slide. Okay. Am I going? I'm the one controlling. My goodness. Yes, I am. Thanks. So it is relapsing, meaning that you will be in and out of having the overweight or obesity, and it's progressive. It's a progressive disease, and that's why now there's treatment for it. And it is a disease of abnormal adiposity or excess adiposity in terms of fat. And now we are calling it the ABCD syndrome. That is the adiposity-based chronic disease syndrome. And that's because of the stigma that the word obese or obesity has come with. So how do we've talked about definition. Hey, let me tell you this one. So in Kenya, we have at least 13% of us living with obesity. That was as of last year, and 38% of us having overweight and obesity. So this is more common than it looks. And why is it important? But this was important in the STEP survey done a while back. We saw that majority of our women who have obesity, living with obesity, is around this region of ours. So Kirinyaga, Kiambu, Murang'a, Central. Yeah, so majority of us who are in these demographics live with obesity. And for men, it is in the areas of like Kajiado, Kakamega, Lamu. So that is where it is. But remember Nairobi, where we are at, and also just the surrounding regions, obesity is very common for us. So why is it all of a sudden we're talking about obesity? What are these risk factors or causes that are specific to Kenya? What's going on? Why all of a sudden we're having this bump of obesity? It's because our diet and our nutrition has shifted. Okay, so before we used to eat, the good food, the githeri, the nduma, but now we are eating very many fast foods, KFCs, Pizza Inn. It's everywhere where we go. That's a food environment. The urban areas are more accessible to the low nutrition and energy dense foods. Also marketing. What's the marketing? Will you ever see a billboard of sijui ndoma and vegetables? No, it's what pizzas, it's KFC, it's whatnot, and that's aggressive marketing that's there. Sedentary lifestyle. We are sitting more. Yeah, even as healthcare professionals, even as nurses and doctors, we see patients and then half the time we're seated. Yeah, so we've changed our work. We're no longer going to the farms. We're less physically active, and this is a major determinant as to why we're having poor eating habits. Yeah, it's easier to get the ones that are not too accessible. Urbanization. So these are the things that were shown in Kenya and also in the world that we're having more causes of obesity. So urbanization, higher prevalence of obesity in urban areas, and also higher income. The people seated here, the people who have a bit of extra money, you're more prone to actually having obesity. And that has been shown to do. Women, we are more prone to having overweight and obesity, and especially as we grow older, even as we have the estrogen decline, especially in menopause. And then now the environmental shift. So obesity, yes, there's the genetic predisposition, and we look at the pathophysiology. Some people just say, we are all big overs in our family, But then you have the genetic predisposition, but there's also the environmental factor that comes into play to shift you. Do you sit more? Are you smoking? Are you taking alcohol? Are you sedentary? What's your food like? What are we eating? And so that's why we're here, even as we take back the message to the rest of the team. Why do we care much about obesity? And this is really the gist of our talk today, because of how much obesity affects. We usually say obesity affects, it's like cancer. It affects every single part of the body apart from the nails. Yeah, but and sometimes cancer we say apart from the hair, but obesity also affects the hair. So we'll see why. So if we start at the top, so we have reduced fertility. Right? So many patients who have obesity or living with obesity, so we don't say a patient is obese. So we say living with obesity or with obesity may have reduced fertility. So you'll find patients who have polyendocrine metabolic ovarian syndrome, that was previously PCOS, may have obesity as an initial presentation. Patients who are struggling with fertility. Yeah, so that's one of the causes of obesity. The other thing is gout. Gout and other osteoarthritis is very common with obesity. We have gallbladder disease, and we'll see also just liver disease while we're there, where we have what we call fatty liver. Sometimes people will go do an ultrasound and then you're told you have fat around the liver, but what we call now muscle D. Cancers, and I'm glad that we have our oncologist here to actually tell us which cancers are more prone or directly linked to obesity. Things like breast cancer, colon cancer. What can we do? Because none of us wants to have cancer. So if we find one thing that we can do to reduce our risk, and that is, how about we get down our weight? So that's important. Dyslipidemia, that's high cholesterol, diabetes, and Dr. Roslyn is here to tell us how is that with diabetes and obesity. Heart disease, cardiovascular disease. Obesity is one of the leading causes of heart disease. Hypertension, obstructive sleep apnea, asthma, stroke. So basically, the reason we're talking much about obesity, it's no longer a symptom. Someone has obesity, so what do we do about it? No, it's because underlying you can actually have more than 20 conditions just because of obesity. So a bit about pathophysiology. I'll make it very simple to understand. So obesity is just not how much you eat and how much you don't exercise. There's a lot that's undergoing in your body that will actually lead to the condition that's obesity. So let's start here at the bottom where we have, I'm not sure, I hope you can see from there, it's a bit too bright from here. So genetically and environmental. So some people are predisposed to having obesity based on their genetics, but that's only 30%. The majority is environmental factors, what we talked about, sedentary lifestyle, we talked about, the food that we eat, and smoking and alcohol. So we have the dietary patterns further at the bottom. But what happens in the brain? So in the brain center, the place called the hypothalamus, we have the arcuate nucleus, and we have another place called the hypothalamus below it, where it triggers our appetite center. Basically, we eat. There are people who have, you'll hear people say in just simple terms, I have food noise. I can't stop eating. I'm just eating. And that's because of whatever happens in the brain. There's also whatever happens in the gut. We have the hunger hormone in the gut called ghrelin, where is increased in patients who are prone to have obesity. And so you have increased expression of the ghrelin and reduced expression of the leptin. And leptin is what helps with our fullness. So basically, we have whatever's happening at the brain where we have upregulation of the appetite center. You just feel hungry, you just feel like you want to eat. And then now there's also what's happening in the gut where it's always hungry. And then there's also an aspect of what's happening in the adipose tissue, and that is what is happening in the fat. So we have the good fat and the bad fat. Okay, so all of it, we'll just call it as adipocytes or adipokinins. So we have the good fat, what we call the brown adipose tissue. And this, the brown adipose tissue, we find in mostly children when they are born. They have brown adipose tissue where it helps with heat preservation and thermogenesis. So that is the tissue we want to have to help burn the extra fat. But then, as we grow older, then we have more of the white adipose tissue. That's the fat that we see around our stomach, around our, in the adipose tissue. But then we found, how can we now change this white adipose tissue to more brown? So we can't brown it, but we can beige it. And so now we are trying to see what are the ways we can give or cause us to have the beige adipose tissue. And things are things like exercise does that. You've seen people, there's a new trend of people getting into ice baths. Have you seen that? Yeah, so basically, and after that, they say, I've lost a bit of weight, after that. I mean, there's a bit of science, because what that does, the cold exposure, extreme cold exposure, helps almost beige your fat, your adipose tissue. And so if you do that very frequently, you do. But anyway, please, don't just dip and not exercise or go eat chips after that. So there is whatever's happening at the fat level, but also now we've seen there's something called the gut microbiota, which actually also influences how much obesity you're going to have. And that is still something interesting that's undergoing. So if you're asked, what's the basic pathophysiology of obesity? So yes, there is genetic and there's the environmental. But there's also what's happening in the brain. There's also what's happening in the gut. There's what's happening in the fat. And there is basically, it's a whole milieu of whatever else is going on. Okay? Classification, before then I let in Dr. Rosalind to come in. So before, we used to classify. I mean, it's still there. It's still a screening modality where we classify based on the BMI, where we say if you are above 25, BMI above 25, that's your height and weight, you have overweight. And then if you're above 30, then you have obesity, class 1. If you're above 35 BMI, you have class 2, and you're above 40, then you have severe obesity. But then we realize this is not a true marker of adiposity. And so what happens is now we're looking at, imagine this person here. He's a bodybuilder, he's a boxer. So he has a BMI of 30, okay? But then there's the other gentleman seated here down. He also has a BMI of 30. So would you say the bodybuilder has obesity? Why not? Yeah, right? It may not necessarily be adipose tissue. So people, that's why we're moving now away from just saying that your BMI is 30, you have obesity. So now we're looking at how do we confirm that you have abnormal fat mass or adiposity. And so we're looking at waist circumference, waist hip ratio, and now waist to height ratio. Okay, for example, if a patient has we have, yes, you do a BMI, you do a height and a weight, and you find the BMI is above 30. If they do not have excess fat mass, basically you do their waist circumference. If it is more than 102 for men and above 88 for women, then you say that they have obesity. Okay? Then you go ahead and do their hip ratio. So now as doctors, we should be walking around with tape measures around our necks. You know, like tailors, please, if you don't have a tape measure, you know, because then we're realizing it's just not a height and a weight. You also have to do the circumferences, okay? And so all we're saying is, please get to know, especially the clinicians and even our nurses, get to know the different cutoffs for the waist circumference and the waist hip ratio. If a person, especially for the Asian population, has a BMI that is low because of how small they are, but then and that's why now obesity for Asians is at a BMI of 27 as opposed to 30. But if they get an Asian population or the Japanese population who are smaller, who likely may not get to a BMI above 27, but they have a lot of central obesity, and you do their waist circumference and it's higher, then that is a patient with obesity or living with obesity. Okay, so please, we are also looking at, do they have, if they don't have excess fat mass based on what we've said, then they likely do not have obesity like the athletes. But if they have obesity, now we are going again and saying, okay, so you have a high BMI, you have a high waist circumference, a high waist hip ratio, but do you have other organ involvement? Now that's why we say clinical obesity. So do you have organ dysfunction? Do you have cardiac dysfunction? Do you have renal dysfunction? Do you have any other organ that's affected as a result of obesity? And so if yes, then we diagnose you as clinical obesity. Okay, so I'll leave that there. I'll come back with management after the rest of the panelists. And I'd like Dr. Rosie to come in and now tell us about diabetes and obesity. Where is the intersection? Why does this matter?
Thank you very much. I would like to introduce my co-chair here, Dr. William Davey, to continue introducing the next speaker.
Good morning. Sorry, there's been a lot of heartbreak since we saw a lot of African teams lose games yesterday. And I think these discussions we're having right now are extremely important. And the fact that you're bringing out these issues of BMI versus body roundness, I think those are very important things in terms of how we assess our patients and ourselves also. So I would like to introduce Rosalind Ngugi, Dr. Rosalind Ngugi. She's not only someone who we've been together in our undergraduate studies, but we've worked together for a duration of time. So it's my pleasure to introduce Dr. Rosalind Ngugi. Karibu sana.
Thank you, Ndavi. I hope I'm audible. It's really difficult to follow after Dr. Mithi because she says 1 in 2. Okay, I'm the 2, clearly. Then I'm half Asian, BMI of 27. I mean, so I bet this is what we're going to do because I was told to talk about the obesity. You have to invite me next year because I've started my weight loss journey. I've already lost 11 kgs. So next year I'll be closer to her size. Yes, under her guidance. So you invite me next year, then we say now we are practicing what we preach. Is that okay? I think, but amesema mini half Asian, BMI of 27. Either way, we are just round. So I'm waiting for my slides. And I called my topic, instead of saying diabetes, is a holistic metabolic rescue. And what I want to do is talk about an integrated clinical blueprint for type 2 diabetes and metabolic management. And the reason I thought of that is we have all this fancy medication, we do all this research with regards to type 2 diabetes, but yet, if you look at the number of admissions, it contributes to 70% in our hospital. So we needed to look back and see what is it that we are not doing right. The knowledge is there, the medication is there. Is it that we are not applying? And it's because we've been working in silos. So I'll just keep talking and eventually the slides will come. So a typical patient who we say has metabolic syndrome is a 20-year-old male presenting with, say, persistent headache, fatigue, palpitations, And BMI, this one now we are done, was 37.1. His waist circumference was 111 centimeters. When we checked his vitals, his blood pressure was 170/102 with an elevated heart rate of 118. That gives him a sinus tachycardia. Then he was sent to me because his A1C was 7.2, cutoff is usually 6.5. Fasting glucose was elevated at 7.07. When we asked for a lipid profile, then we found triglycerides of about 3.84. Today, I'm hoping I'll get the slides. But now just look at me. I think I have a good enough face. HDL of 1.15. Total cholesterol of about 7.29. And an LDL of 4.39. Now we went ahead and did something called the triglyceride to HDL ratio, and this was actually elevated at 3.34. Now what we found is it's actually a clinical surrogate marker for increased cardiovascular morbidity. So I really wanted you to see my pretty slides to show you that even us, we know how to do AI, but no? Okay, next. I only have 13 slides. So that was what the patient looked like. Now we can move to the next slide. Good. So we need to understand, and that is why we let Dr. Mithi give us the initial presentation of what is going on, because we focus so much on the sugar, we forgot to look at the patient. And she rightly talked about what we call the visceral adiposity or excess abdominal fat. And what is it doing? Enhancing interleukin production, causing chronic inflammation. This then causes the RAS activation and endothelial dysfunction. So eventually you have hypertension in the patient with diabetes. We've always wondered whether it's the chicken or the egg. Is it diabetes that led to hypertension, or hypertension led to diabetes? It's neither. It's a combination of, if you look at the patient, also because of the adipose tissue dysfunction, then they get the metabolic syndrome. Now, because of all this interleukin production, you also have, to your right, liver lipid accumulation. So you have atherogenic dyslipidemia. Then on the other side, why you end up with impaired glucose tolerance is this increased cytokines are then blocking the insulin receptors. Then you end up with insulin resistance, and that's how they end up at my door. But now we were totally focused on only one issue. When we, next slide, was we were only focusing on this patient's fasting blood glucose. But then we were like, what about all these other issues? I mentioned blood pressure was 170/102. His waist circumference was 111. All the things that she's mentioned, isn't it? But do we ever stop and think about this? We always say, okay, we'll tell the patient, go exercise, then go see the nutritionist. And we're not working together. So according to the diagnostic criteria, according to ADA, we say you're pre-diabetic if your A1C. Now, this differs between IDF and ADA, because you can see for ADA, they say A1C of between 5.7 to 6.3. But we follow the British system where it's 5.9 to 6.4. Otherwise, everyone would be pre-diabetic in this room. Actually, the next conference, we are going to do blood sugars and cholesterol. So be ready. You start exercising like me. Then your fasting plasma glucose of between 6.1 to 6.9 and a 2-hour OGTT of between 7.8 to 11. Now, when you end up to see me, which is where the problem is, you're waiting until the A1C goes to above 7, which is a problem. Send to me this patient when they're at the pre-diabetic level, then I can be able to sort the patient out. Next slide. So when we look at A1C, we call it the A1C dial. How do we determine who we are going to treat, more tight versus not so tight? So we give certain targets because, you know, we're using A1C to manage. So then we say if you target an A1C, a very tight control of 6.5, it's someone who's young, newly diagnosed, they can exercise, they have a low hypoglycemic risk, because that's very important. Standard control is for, well, majority of you here with an A1C of 7. But less tight control, that means between 7.1 to 8 are the patients I commonly see. While she likes to see the young ones, me, I like to see the wazee. So send me your parents. The elderly with major comorbids, high risk of severe hypoglycemia and a short life expectancy. When that elderly patient comes to you and you're telling them, stop this, stop this, stop this, and they're 90, what are you doing? But now let them live the little life that they have left. Please let them enjoy. But now you see, this is a patient who's also obese. So look at certain things. Beyond glucose, we have targets for lipids. We want our triglycerides to be very low, less than 1.7. Because what we realized, excess starch, what happens is converted into glucose, stored as glycogen in the liver. Anything excess is actually converted then to your lipids, and it's in the form of triglycerides. So if you want to find out if your patient is actually compliant to diet, and after the diet plan has been given, monitor the triglycerides. That will give you a clue. Then, of course, your targets for your blood pressure. Next slide. So, I like to make it a bit interesting so that we see what next. Next slide. Yes, so we talk about now lifestyle modification as being the key. Why I love Dr. Mithi is that she practices what we preach. Can you follow her online? She always has, I pretend once in a while, like 5 days in a month. At least I try. I've started somewhere where she always has targets. So we're looking at primary driver is obesity, right? So the first thing we target is weight loss. You aim for 7 to 10% of the weight loss within at least 6 months, realistically a year. Then you do the medical nutrition alongside, not one after the other. That as she's telling them about exercise, also we are talking about, can you have individualized plans? And that is why we stopped giving the diet plans as endocrinologists, because number one, nutrition, what we were taught then and now is so different, isn't it? And we're going to learn about it. So everyone has the area of expertise, and they give you certain, they emphasize on the low glycemic index foods to avoid this excessive postprandial hikes. And then physical activity. So it's either 150 minutes of moderate intensity or 75 minutes per week of vigorous aerobic exercise. We can move to next. This is where now you come to me. One of the things I was asked by my residents is, how do you decide which medication? You have so many. You can see this is just a few. Either do you give metformin versus the sulfonylureas. Someone else will give metformin with DPP-4s, SGLT2s, and GLP. But what we do is look at the patient in front of you. If your target is primarily just glucose lowering, then you'll go for agents that lower up to 1.5%. And sometimes what we do is combine. If you have, say, metformin lowering it at 1%, and then you have sulfonylurea also reducing it by 1, then you're able to reduce it by 2%. So if your A1C is 10, you don't have to go to insulin, combine agents. If your target is you're ensuring the patient is elderly, don't give sulfonylureas because of the high risk of hypoglycemia. If we are focusing on weight change, I want an agent that will assist me to not only lose weight, but at the same time help with glycemia. That's why then she will prescribe the GLP-1 analogs, and she'll talk about it in detail. But the SGLT2s are the ones that are favored. Please don't give sulfonylureas. What happens? The patient gets hypos, and then defensively eats because they're afraid of hypos. So then they end up with weight gain, similar with insulin. Then you already know the patient has obesity, dyslipidemia, diabetes, and hypertension. So you need to pick a drug that has been shown to cause improved cardiovascular benefit. And so from the trials, the ones that we found are the GLP-1s and the SGLT2s. So you'll find, instead of me prescribing metformin, I'll go straight to a GLP-1 if I know it can be able to achieve all this, isn't it? Next slide. So this is how I'd want you to escalate treatment. If it's at 6.5%, we always rush to start medication. But you know, sometimes those prescriptions are thrown away. Then they come when the sugar is 16 and then say, well, you know, it was the first time. So start having this conversation that it's a progressive disease, that we'll talk about lifestyle. That is your diet and your exercise. Even if we come up with all these fancy drugs, she'll tell you the GLP-1s work better if your patient is following the diet. Others will come and say, I'm spending 20,000 a month, but I'm not achieving any target. Then when it goes higher, then you start picking agents which I know are going to actually achieve my objective. Between 6.5 to 7, I'll add metformin. If it goes higher up to 8, then I'll be able to add, say, metformin, a DPP-4 and an SU, or a GLP-1. For our patient, I would not give an SU. I'm going to go by the straight. I can give metformin because it has a benefit of insulin resistance, but this is a patient I'd want to give a GLP-1 if they can afford. But supposing it's above 10%, the guidelines say give insulin, okay? But the problem is if you start that conversation day one with insulin, the only patient who will agree to insulin is the one who comes with an acute emergency DKA or HHS. Next slide. So this is how I want you to think of your patient. If they have a high atherosclerotic cardiovascular disease risk, then this is a patient you'd want to give a GLP-1 or a SGLT2. If the patient is already presenting with heart failure or CKD, you've seen all the studies that show SGLT2s are the drugs you should use. If your patient is obese or overweight, other than diet, exercise, GLP-1s are the ways to go. And it's not just about weight loss. I feel like the social media influencers were faster at this than us, and I think this is where we need to catch up. That's why I admire Dr. Mithi, because she goes there and tries to educate people out there that it's more than just obesity. It's reducing the chronic inflammation. I have a patient who I gave a GLP-1 and was on 5 antihypertensives. We're down to 1. She's lost 20 kgs. She feels good. Her quality of life is good. We can actually go for walks in Kutrrh. Then, if your patient is elderly, high hypoglycemic risk, then we are telling you that you can give your DPP-4s, your SGLT2s. We're even giving GLP-1s because it's been noted that it helps with retarding the progression of dementia. Give it to alcoholics. By the way, it helps to reduce their need for alcohol. Next slide. Next slide, yes. So in terms of renal guardrails, now that we have Dr. Rintari, I don't think I should talk about renal really because she's going to talk about it, but predominantly, you know, by the time you go to the nephrologist, one, they're not dialyzers. So we've agreed we'll be sending you the patients earlier. But supposing the patient comes late, please don't give metformin if your GFR is less than 30. You find us giving SUs, don't give glibenclamide, give gliclazide, but at a lower dose, and we combine that with certain DPP-4s, specifically linagliptin, teneligliptin, because they tend to be renal friendly and they're actually metabolized in the liver, but you can still renal dose the other DPP-4s. GLP-1s, less than 15, you stop it, but then we give it for the attendant benefit of heart failure and chronic kidney disease. Next slide. For a patient who A1C is above 10, you have done diet, you have done lifestyle, you have given orals, then let's introduce insulin. If you start straight away with a premix insulin twice a day, patient is likely to decline. Patient will get hypos, they end up putting on even more weight. That's why we're saying GLP-1 is the one drug we have found that lowers the A1C as well as insulin and is once weekly, as opposed to the insulin. But then affordability is an issue for most of our patients. So let's be realistic. Start with a basal insulin and look at your targets. If you've only managed to get to 9, then add a prandial insulin with the largest meal of the day where you find we're getting high postprandial sugars. Because your basal insulin corrects your fasting plasma glucose. Then your prandial insulins then help you with managing your postprandial hyperglycemia. Next is acute crisis. I found the reason why I introduced this is patients are started on insulin, they get hypos, they eat, they stay at home. They continue the same dose. Then they get another hypo. I got a patient who had 7 hypos in 2 days. Only when the patient was unconscious was the patient brought. Now the reason why we say bring to hospital is hypo is even more dangerous than hyper. We've had patients actually getting hypoglycemic ischemic encephalopathy. So even when your patient gets a hypo, and you correct, please don't send them home unless you've actually identified what was the reason. Was it they injected without eating? Or the issue was they had injected the basal insulin but had an underlying infection. So those are some of the things you need to think about. Now, I don't know, maybe I should not say I like it, but I like it when patients come in DKA because it gives me a chance, because I have my nutritionist with me there. Then they can be able to, we start on a very nice slate where we start to teach you. And it's easier because someone has been introduced to insulin. And when I get them off the insulin and go to orals for the type 2, then they're like, oh, I've done very well. But I tell them, this is a progressive disease. So we continue with you because 20 years down the line, you will need insulin. But if you work hard at your diet and exercise, you can actually push this diabetes into remission. That's why we also like the GLP-1s. So finally, this is what I want you to be the take home. Let's first have a holistic patient rescue. What does that mean? Let's address the root. What is the root? The adipokine metabolic imbalance, isn't it? Stop looking at the patient as, I know when we run the clinics, they say we need DOPC, we need MOPC. So we see only what we want to see, diabetes. The rest we say, go to the nephrologist, go to Dr. Ndavi, isn't it? That's not right. Let's start working together. So if we say the problem is adipose dysfunction, target weight reduction. Then target the symptom. If it's glycemic control, control that. Then start looking at, are they at increased risk of cardiovascular risk? So if they've had a risk of heart failure, MIs, then you know, GLP-1s, SGLT2s. And at the end of the day, let's work together. The paradigm has shifted. For diabetes, it's not just lowering glucose, it's the holistic rescue of systemic, metabolic, cardiovascular, and renal function. Thank you very much.
Thank you, Rosie. By the way, you've been doing a good job. We've noticed. We've noticed. So I think there's the other thing I wanted to add with regard to what she's presented in terms of holistic care. There was that pathophysiology, metabolic associated steatotic liver disease. It's usually one of those things in there where there was that issue of inflammation. Just imagine it is also part of that. You know, you can't put everything. You can't necessarily put everything on the slides. But I think it's very important to mention that. The other part of holistic care, yesterday we had very interesting sessions with mental health. And that is such an important part of the care of individuals who have been either struggling with obesity over their lifetime or has become a reality for various reasons. So I always feel it's important that we never leave that team out. So thank you so much. The next presenter is Pauline Rintari, who I happen to have met when we were doing postgraduate. And I always used to laugh and say I could have become her mentor, but now she's my mentor. So I would like to welcome Pauline Rintari, one of our nephrologists and a very brilliant individual. Karibu sana.
Good morning. Thank you, Dr. Ndavi, for the kind introduction. So for the next session, we'll move to the renal effects of obesity. And the title of my topic is Obesity-Related Glomerulopathy. Give a minute for the slides, then we can proceed. Okay, so I can be going through the outline of my talk. So we'll go through a bit of introduction to just know what obesity-related glomerulopathy is. It's also known as obesity-related kidney injury. So we look a bit at the prevalence, the clinical presentation, a bit on the pathophysiology, the current standard of care, as well as emerging evidence. So it is defined as clinical obesity with a BMI more than 30, which is coupled with biopsy-proven glomerulopathy, which is an enlarged glomerulus, which may be associated with focal segmental glomerulosclerosis. So in terms of the prevalence currently for both adults and children, we postulate that by the year 2035, we'll have about 1.5 billion people living with obesity. And in parallel with the increasing obesity numbers, we also have an increase in the chronic kidney disease patients, and currently it's affecting in excess of about 800 million people globally. So how does it present? So initially it is silent. Sorry. I hope you can hear now. So initially it is silent and usually follows an indolent cause, and may present with proteinuria, which is subnephrotic range in about 70% of the patients, associated with dyslipidemia, hypertension, a lowered EGFR, and a greater incidence of progressing to end-stage renal disease. So how does it appear histologically? So we've mentioned that on the biopsy, what you expect to find is an enlarged glomerulus, which is termed as glomerulomegaly, as well as perihilar segmental sclerosis. So on the slide, I think it's one slide, yes. So on the pink, yes, the slide on the left, which is pink, that is a normal glomerulus, while the one on the right, stained with blue, is an abnormal glomerulus, which you can see is enlarged. And on the central area, there's a bit of cellular loss, and that is what we are calling perihilar predominant segmental sclerosis. So how do we get here? What are the pathological mechanisms involved? So there are several direct mechanisms. So the first one is increased metabolic demands, which result from the increased body mass, increased blood flow, as well as increased cardiac output, resulting in increased glomerular hyperfiltration. The second mechanism is hormonal activation, particularly the renin-angiotensin-aldosterone system, as well as the sympathetic nervous system. And the net effect of this is increased water and salt retention, which also leads to glomerular hyperfiltration. The other mechanism is increased insulin secretion, coupled with insulin resistance, and also the increased release of pro-inflammatory cytokines such as the interleukin-6 and tumor necrosis factor alpha. There's also reduction in the anti-inflammatory molecules, and the net effect again is increased oxidative stress and cellular death. And finally, the last pathological mechanism is lipotoxicity, which is the direct deposition of fatty acids on the kidney cells, and this results in direct tubular and mitochondrial dysfunction. So all these pathways that we've described lead to one final common pathway leading to glomerular hyperfiltration, and because each of the nephrons is overworking, we end up with a podocyte injury and leakage of proteins through the glomerular basement membrane, and this comes out as proteinuria as the clinical presentation in our patients. And this is quickly followed by glomerulosclerosis, as well as tubulointerstitial fibrosis. And finally, you have CKD progression, and a good number of the patients also progress to end-stage renal disease. So how do we manage this? What do we do about this obesity-related glomerulopathy? So from the KDIGO guidelines of 2024, the first recommendation is lifestyle, which is for every patient. And this has been alluded to by my preceding presenters. So we have nutrition. There's also regular physical activity, sleep optimization, and also behavior modification. But remember that these lifestyle modifications on their own only achieve modest and usually unsustained weight loss. They always have to be coupled with pharmacological therapy. So in terms of the pharmacologic therapy, the guideline recommends that we use SGLT2 inhibitors. This is for CKD patients who have proteinuria, There's also the recommendation of using GLP-1 receptor agonists, particularly in the type 2 diabetic patients who have CKD and also in need of additional glycemic control, as well as the patients who are obese. And finally, for the patients who are severely obese, the recommendation is metabolic surgery. So these recommendations, particularly the pharmacologic therapy, are guided by the landmark trials. So for special interest in our patients with CKD, we have the FLOW trial of 2024. And the population for this study was type 2 diabetes patients who had CKD, as well as albuminuria. And the patients were given semaglutide 1 milligram. And the key findings, which have since guided the change of the guidelines, it showed that there was 24% reduction in kidney disease progression, as well as reduction in kidney and also cardiovascular death, also reduction in proteinuria and slowing of the EGFR loss. And it's also important to note that we also have another study coming up, the TREASURE CKD study, and its population currently is CKD patients who have obesity, and it's slightly different from the FLOW trial because most of the patients do not have diabetes. So we look forward to seeing what the results will look like. So as much as we are recommending weight loss for our patients, and this Dr. Mithi alluded to, we don't use BMI alone for our CKD patients because majority of them are fluid overloaded. They have muscle wasting and altered body composition. So we always have to do BMI combined with a waist-hip ratio, waist-height ratio. You also have to check the body composition, the functional status, as well as the metabolic health. So another important factor for our CKD patient, so once they achieve the weight loss, it's always important to interpret the kidney function tests with a lot of caution. This is because the serum creatinine is greatly influenced by the reduction in muscle mass. So a reduced EGFR and a reduced serum creatinine does not always mean recovery of kidney function. So it's important to always consider other tests that you can be able to do to get a more accurate measure of the kidney function, such as the cystatin C, as well as an accurate measure of the EGFR using tests like the DTPA. So research has been done, but there are several gaps. So on our side in nephrology, we want to find out which patients in our cohort benefit the most from weight loss, what are the long-term renal effects of the GLP-1 receptor agonists, and which of our patients with on dialysis and those who have undergone kidney transplant, how we can be able to manage them best if they have obesity, and what is the best way to assess kidney function for our patients who have had major weight loss. So for our take home in nephrology, I want to emphasize what Dr. Mithi and Dr. Ngugi have emphasized, that obesity is a disease and is not simply a risk factor, and it contributes both directly and indirectly to CKD. And as I've mentioned, BMI alone is not sufficient, so we have to assess the overall metabolic health of the patient as well as their body composition. Then remember that lifestyle therapy has to be coupled with the newer anti-obesity medications. And finally, management should always be individualized according to the CKD stage, the nutritional status, as well as the patient goals. Thank you very much. These are my references.
Thank you. Thank you, Dr. Intari. That was nice and crisp and clear. So I wanted to engage you a little bit. These incretin-based therapies, how many of you know where the story began? Do you know which animal a certain enzyme was picked from? I'm seeing residents here. There is a lizard somewhere. The World Cup is being hosted in America as we speak. That lizard, it's spelled G-I-L-A. Do you know about that one? So it's, how do you pronounce that, by the way? Don't be shy. We are here to learn. I keep telling you, there's no way you will know everything. How do you pronounce that? Gila. Yes, I found out yesterday it's Hila, not Gila. So, on that note, I would like to reintroduce Caroline Mithi because she's going to take us through some of these discussions and see the groundbreaking things that have been happening in that particular world of incretin-based therapy. I saw she had put there, you had put something about the Surmount trial. You know, maybe some of you may not realize that is a breakthrough trial in terms of landmarks in medicine when it comes to managing patients who have been struggling with obesity. And I will not continue any further. And let Mithi have the floor. Thank you.
Hiya, now we have entered the more interesting part of obesity management. How many people know Ozempic? Huh? Oh, you're having it. You're using it. Oh, heard of it. How many know Mounjaro? Yeah, Mounjaro? No, it's interesting. It's the same presentation that was there. How many know of people who've had gastric balloon? It's the in thing, you guys, in social media. And gastric sleeve and bypass surgery. And we're wondering, hey, things are moving so fast. And even for us in the medical world, like we wake up and there's something new, something different every day. And so we're here to talk about the Ozempic, so that when you hear someone is on Ozempic or Mounjaro, so please don't frown on them. You're just like, yeah, tell me, how are you feeling? What are the side effects you're experiencing? Because these are interesting medication that we're having. Is my presentation up? Okay. So, in summary, I'm here to talk about the management. So 4 pillars of management. Can I have the pointer, please? So 4 pillars of management. I know we talked about the pathophysiology. We won't belabor that now. And how to diagnose obesity. So we have 4 pillars of obesity management. One is nutrition therapy. That is important to know, and that's why we have Robert here, who will take us through a patient with obesity. What do they tell them? Because we cannot manage obesity alone. But just to preempt, it's no longer eat less, eat half-plate vegetables, half-plate carbohydrates, quarter plate. No. Now we have to calculate. And now we are focusing on more protein and more vegetables for these patients, and, kick out your starch and your sugars. And Robert will take us through that, so I won't preempt. The other pillar is physical activity. So this is where we get wrong. So if you find people who are just injecting themselves, which is an excellent drug, by the way, but then they're not exercising, you're going to lose weight, but the rebound that is coming will be, for days. So that's why we say you have to do physical activity. And what is the physical activity? If anyone met you on the road, you're working in a hospital, anyone who works in a hospital is daktari. I'm a sister, And you're asked, so how should I exercise? What do we say? 150 minutes a week. What does that look like? How many people exercise today? No, today. Hey, we are doing well. Okay, this side. Okay, how many has exercised this week? Okay, well done. Hey, this is good. Okay, so the typical exercise that we tell patients is at least every day, try and do 30 minutes of aerobic or cardio exercises 5 days a week. So Monday to Friday, take in 30 minutes in your day and do a form of aerobic or cardio. And now do at least 2 to 3 days of strength training. So people will be like, what is strength training? Now, in our patients, uinue chuma. How many patients will do that? Because we also have to translate in Kiswahili. What will you tell them? Is at least let's use our body weight. Kama unaweza fanya squats, then you do at least 10 squats with every bathroom break. Because you're going to go to the bathroom. Like what? How many times have you gone to the bathroom so far today? Yeah, like twice or thrice? Imagine if you did 10 squats for every of that bathroom break. You'll actually be toning up, strength training. How do we lift our hands up even when they're seated? They can lift their hands up. They can do. So you're using body weight. They don't really need to go to the gym for that. Behavioral modification. So any patient living with obesity, we have to go through these 4. Nutrition, physical, and behavioral. What does that mean? What is their sleep like? How many people slept for 7 hours last night? Okay, apart from football. Yeah? Who? How many? Okay. Hey, you guys, can you sleeping for 4 hours? How many did 5 hours yesterday night? My gosh, Dr. Ngugi, we are doing badly. Yeah? Oh, I move here. Okay, so I've been told not to roam around. How many people, so basically, what is their sleep like? Because sleep highly impacts how much you weight you gain. Ideally, at least 6 to 7 hours uninterrupted of sleep is the recommended. Half of us won't get to 8. And then other part of behavioral, you have to ask a patient, what's your stress level like on a scale of 1 to 10? Everyone gets stressed, but what we're really keen on is the chronic stress. Yeah, that's what we're keen on. And then also, what's their mental state like? Patients who have depression, anxiety will likely have obesity as a trigger, and we have to treat the underlying cause. And then let's go now to the exciting phase where we are at in terms of medical intervention, and we'll just mention a bit about. So this is how we go in terms of trends. So we always start with nutrition. We've talked about the 4 pillars, which is down, and then nutrition is second, okay? And now it's no longer eat less. It's a medical nutrition therapy. So we have to send them to our nutritionists for that. And if you do proper nutrition, you're actually supposed to lose 5 to 10% of your weight. For example, we are seeing patients who have 100 kgs coming to us. If we send them to their nutritionist, at least they should lose 5 kgs and get to 95%. And as Dr. Roslyn said, if you lose even 5% of your weight, you'll actually be, your diabetes will improve. So that is key. And then, what about all of us now who now need to know about the medication, which is Ozempic, Mounjaro, and we'll go to the scientific terms. If you use them, you'd actually lose 20% of your body weight. I'll tell you why this is exciting for us. Is because before these medicines, we'd only achieve 20% of our body weight loss only with surgery. Okay? But now, we are having this 20% body weight loss with medication, which is exciting for us. And we'll go through that. But who gets this medication? Is it all the influencers? Some people look at this like, hey, did you need really? I'm like, who are we to be the judge? So the indications for these medications is if you have a BMI above 30, or if you have a BMI above 27 with comorbids like hypertension, diabetes. What if someone comes and tells you, you know what? In December, I need to fit in my wedding gown. Yeah, and it is being imported. And it's a size 12. She's a size 16. We have to lose weight. Would you give this medication? Is that a correct indication to give? How many think, please give as a doctor? How many will not give? Why wouldn't you give? Because of the indication. As doctors, we're not called to be the judge. So regardless of why the patient wants to lose weight, are you at a BMI of above 27 or a BMI of above 30? Whether it's because you have a holiday coming up next month, you just have to go through the due process. If you're looking for endoscopy, because now we know a lot of gastric balloons, patients are taking in balloons. How much weight will you lose with that? 20% of loss of weight. So if you are 100 kgs, you probably go to 80 kgs within the 6 months where the balloon will be in. And then surgery, then we have the gastric sleeves where they go and cut out half of your stomach or a part of your stomach, or bypass surgery. And we'll just touch on briefly that. So I know Dr. Ndavi mentioned about where have we been. For 100 years, you guys, we didn't have anything to treat obesity. For almost 100 years, since 1933, we just now realized in 2021, that's when our first agent, that's semaglutide, or what we call Ozempic, came about. And then now we have the tirzepatide, which is a dual, what we call Mounjaro, which is amazing. We have retatrutide, which is a triple analog, and there's hundreds more in the pipeline. And that's why I think for us, this is exciting. And so how do these medications work? If someone asked you, so I'm on Ozempic or semaglutide or tirzepatide, how do these medications work? So don't even look at the busy slide. So from the brain, what does it do? It suppresses the appetite. It shuts off the food noise. So you don't think about food. Remember, we talked about patients who just say they have food noise. They're thinking, like some of us here are thinking of what you're eating at 10 a.m. You guys, it's not yet there. But just chronic food noise thinking. So it shuts off the appetite, it decreases the appetite, and it increases our satiety, fullness from the brain aspect, okay? So patients don't feel hungry. Patients always feel full, which is exciting. Also in the gut, what does it do in the stomach? You eat little, and it slows down the movement of food from the stomach, okay? So you end up eating little, and then it also increases satiety or fullness in the stomach. So you're always feeling full. You don't feel hungry. How do we use it for patients with diabetes? It also works at the pancreas level to tell the pancreas, give us a bit more insulin. And insulin stores away the extra glucose. And as it does that, then there's also loss of weight. And then there's also breakdown of fat. There's effects like we've had in the kidney. It helps the kidney. It helps the heart. It helps the brain, decrease dementia. So we are calling it, this is the drug that keeps on giving. We've never had such a drug in medicine where it has benefit for all places in the body. And so it's an exciting medication. So don't frown upon people who are using it. It's actually giving them more benefit than just the weight loss that we're seeing. It has benefit for diabetes, for the heart, for the kidney, for the brain. It is an excellent medication. Semaglutide, I won't bore you much with this, but this is just to tell you there are trials that are there to show that we have decreased weight loss in semaglutide, which is Ozempic, and also tirzepatide, and this is just because of the crowd, so we won't go through the details of that, and we've talked about the mechanism of action and how that works. So what we need to know is these tirzepatide and semaglutide, because now we are getting these molecules even in our hospital. A patient will come and say, okay, so you have Ozempic and you have Mounjaro. So which one do I use? How do we know which to use? Yeah, so what you'd know is now when we compared the two, the Mounjaro and the Ozempic or tirzepatide and semaglutide, we had greater weight benefit with tirzepatide and other benefits. So that's what we'd routinely give for these patients. And it also changes your waist circumference. So in summary, in the medical department, so what do we give for obesity management? 1, nutrition. 2, physical therapy. 3, psychology counseling for sleep, mental state, and stress. And then for medical therapy medication is the GLP-1s, the semaglutide, and the tirzepatide. And now we have orals that are coming up. Oral semaglutide called the oral Wegovy pill. And we have Fondayo, that's also oral. That's coming up. So let's look at just, this is my last slides. It's balloon, just because this is also what we're seeing right now and it is indicated. So basically there are 2 different types of balloons. There's one that you just swallow and then they push air and it dilates in your stomach and it sits in your stomach for at least 6 months. Okay, so what does that do? It just decreases the amount of food that you're able to eat because you have something that's half of your stomach there. There's also what we call endoscopic, and this is the safer one because you just go in with an endoscope and fix the balloon over there. What is the problem with the balloon? Is it hasn't changed anything in your mental state. It hasn't changed anything in your brain. It's just decreased how much you're able to eat. So what happens after 6 months when it gets out? You go back to eating. And that's why most patients with who've had gastric balloons, they balloon afterwards, yeah, just like the name. And so now we are looking at, can we combine the balloons and the medications together? And then we have surgery. So we have 3 types of surgery where we've had. So we have gastric sleeve. So we go and cut out the bigger part of your stomach. That's the gastric sleeve. And we leave your stomach as a small sleeve. So your space is smaller of how much you can eat. But also we've seen that when you cut out that big part of the stomach, that's the one that you can see, the curvature, the greater curvature. So that also removes the ghrelin, majority of the ghrelin hormones, which is the hunger hormone. So you find these patients also don't feel hungry. So it almost works like the GLP-1s in a sense, but it also does not affect the brain. So it will just eat less, and then now you feel fuller, and you have at least 23% of total body weight loss. We have the bypass surgery, and also we have the duodenal bypass. So we have several, but the commonest are the balloon and the sleeves. So in summary, what are we saying? That management for obesity is just not curated to weight loss alone. We also have to look at what's going on in the brain. What can we use to adjust? So a lot of psychotherapy has to go into place, a lot of nutrition, a lot of physical activity. And then if these patients, especially if you see them even at casualty, and they have comorbids, they have heart failure, they have diabetes, they have obesity, please don't tell them exercise and go home. Now we have treatment for it. Send them to us, send them to the endocrinology clinic. We're also looking to starting an obesity comprehensive center soon, and so we'd be able to see majority of these patients. So thank you very much.
Thank you so much. One thing that you have to remember with invasive procedures, especially when you look at those gastrectomies. Some of them look very nice and tidy, but we know the reality, especially when we've been managing many of these patients. Imagine a small stomach, the level of dehydration you tend to get, the issues with reflux. So indeed, the medical option does work. So, and I think that's something that you always have to make sure you have at the back of your mind. So for our next presenter, it will be a very timely topic, because we also know that obesity is considered a risk factor for a variety of malignancies. And I think it's a timely discussion that which has been ongoing for a long duration of time. And I believe Dr. Michelle is going to take us through that. And I would like to welcome her. Karibu sana.
Good morning, everyone. All right. So, as you've been told, my name is Dr. Michelle Naisai. I'm an oncologist. I'm currently working with the county government of Kilifi. I'm really honored to be here in your midst. I really feel that after the presentations we've had before, I don't need to be here. I mean, if we can do everything that they said, then I don't need to be here discussing obesity and cancer. Yeah? So since we caught up a bit late on the oncology front, so we'll be chasing after you. Okay? And we'll see why we caught up late. So today we're discussing the impact of obesity on cancer. To begin with, the International Agency for Research on Cancer has now listed obesity as the third leading modifiable cause of cancer worldwide. That is just after tobacco and infection. So you can see how high up it is. Yeah? And if I remember very well, while we were in school, I don't think we paid so much attention to obesity. We were talking about alcohol and tobacco, and that was the gospel of avoiding cancer. But it's coming to a mind that obesity should be considered. It is associated with up to 13 malignancies, and we'll see which ones they are. Apart from causing the malignancy, it also affects how the patients respond. Oh, this is mine. Sorry. So which is what? This one. Sorry. Oh, someone is moving. Okay. Okay. I have practiced. All right. So apart from causing the cancer, it affects also how the cancer will respond to treatment. It affects whether the cancer will come back or not after treatment. It affects the prognosis, how long this patient will survive. That's why even once the patient has gotten, once a patient with obesity has gotten cancer, we still want to be keen on managing this obesity, even as we proceed with our oncology treatment. All right. More statistics for us is that approximately 500,000 new cancer cases every year are associated with obesity. 500,000. All right? And in women, there is a higher percentage of these cancers associated with obesity than men. Why? Because of because of those cancers that are attributable to the sex hormone, the female sex hormone, the estrogen, and we're going to see as we go on. So the main cancers that constitute 2/3 of obesity-related cancers are just 3. We have 13 that are associated with obesity, but just 3 contribute to 2/3 of this cancer. So that is endometrial, the postmenopausal breast cancer, and you will see why we are saying postmenopausal. In fact, one of the presenters here has alluded to it, and also colorectal cancer. So these are just some of the landmark studies. I just put this slide here to show you that why we were a bit late. In 2003, very good researchers told us that there is increased cancer-related mortality. There's increased cancer mortality in patients with obesity. However, it is not until the year 2014 that there was a position statement given by the ASCO telling us that now obesity should be a priority in oncology. So you see, we've had 10 years, lagging behind to catch up. But I'm happy to say that currently a lot of research is going on in terms of obesity and cancer. So those are the 13 cancers that are associated with obesity. We can see thyroid cancer up there, endometrial, gastric, pancreas, colorectal, I can see the rest. Let me just... So we have all these cancers, the multiple myeloma, hepatic cancer, ovarian cancer, and of course, the breast cancer. With current research, we're even seeing some diffuse B-cell lymphomas. So we are seeing some lymphomas being associated with obesity and also some types of some subtypes of prostate cancer. So men, probably we are going to see now those numbers increasing of obesity-related cancers in men. Right? So what are the biological, what is the relationship between obesity and cancer? How does obesity cause cancer? The other presenters who are before me have given us some indication of the biology that takes place in different people's body when they have increased adipose tissue. And that is exactly what also results in cancer. Before I get to this section, I would just like to highlight to you what we call the hallmarks of cancer. Basically, this is, in simple layman terms, how I would explain it to a patient. Where does cancer come from? So we tell them, one, there is a sustained signaling. There is a sustained signaling of your cells to grow. So the cells are just encouraged to continue growing and growing. We also know that after some time, a particular group of cells is supposed to die, depending on which part of the body. However, cancer cells do not die. They find mechanisms to avoid this programmed cell death. We also find that cancer cells have increased blood supply. They are able to tolerate even situations where they lack oxygen. They have mechanisms to allow themselves to detach from the group of cells where they are and to get into the bloodstream and spread. They have mechanisms also to alter the DNA so that it just keeps encouraging cell growth. So all these things are what obesity tends to stimulate, and then we end up with cancer. So number one, when a patient has obesity, they usually are in a state of a chronic inflammation, low-grade type. So in these patients, you'll find all those inflammatory markers that Doc mentioned, the interleukins, the TNF, and once those factors are there, they result in an oxidative stress. So now here we go back to the hallmark. Oxidative stress leads to a change at the genome level, so we have the DNA damage and all those other factors we've caused. So they result in increased angiogenesis, that is increased blood supply, resistance to cell death. So you can see how the chronic inflammatory state results in stimulating the hallmarks of cancer. Their second biological mechanism is insulin resistance, which thankfully has been well explained here. Patients with obesity usually have hyperinsulinemia and also an insulin resistance. Once this is because when insulin binds to its receptor, then it activates some of the pathways that result in cell proliferation, which is now those sustainable signaling of cells to grow, which we have already mentioned as a hallmark of cancer. Sex hormone dysregulation. Now, this is related to postmenopausal women. As Doc has told us, we expect the estrogen levels to go down at postmenopause. However, now the body, when a patient is having excess adipose tissue, then that creates a ground for what we call the aromatase to act. So aromatase converts androgen to estrogen. So now the patient ends up having a lot of estrogen in their body, and that estrogen stimulation ends up now ends up now increasing the cell proliferation as well, and also they reduce, or rather they prevent the cell from dying when they're supposed to die. So cancers that we see associated with increased estrogen are the hormone receptor breast cancer. We have different types of breast cancer. So this is the one, the hormone receptor one, the endometrial and the ovarian cancer. Just to point there is a relationship between the sex hormone dysregulation together with the hyperinsulinemic state. So hyperinsulinemia also prevents the liver from producing the sex hormone binding globulin. This allows free estrogen to continue being in the body and ends up causing that stimulation we've just discussed. Adipokine dysregulation has been mentioned here. I'm so glad Doc explained the leptin and what it does, the adiponectin. So with obesity, you have increased leptin. Increased leptin stimulates the cell growth pathways. Adiponectin is supposed to be protective to our bodies. However, with obesity, we have reduced adiponectin. And when the adiponectin is reduced, then it is not able to suppress that pathway known as the mTOR pathway, which is also a pathway that encourages cell growth. So we have less adiponectin, then we have the mTOR pathway hyperstimulated, and we end up with the hallmarks of cancer activated. Right. This slide is going to explain to us how the fat cells stimulate cancer, and how in return the cancer stimulates the fat cells to continue encouraging the cancer to grow. So when you have hypertrophic adipocytes, then you have a release of free fatty acid, cholesterol metabolites, proteins, and all these factors are nutrition to the cancer cells. In return, the cancer cells continue to continue to induce further lipolysis on the fat cells. So the fat cells release nutrition, the cancer cells induce it to further break down and continue releasing all these factors that they need to grow. Immune dysregulation. When with obesity, there is an impaired intertumor immunity. Among the hallmarks of cancer, there is an immune mechanism that results in the programmed cell death. However, with obesity, this mechanism is impaired, so therefore encouraging the cells to continue growing and living longer than they should. Doc has mentioned the gut microbiome. And with obesity, you have that gut dysbiosis, which means you have an imbalance of the bacteria, virus that are supposed to be protecting you in the gut. As a result, you end up with increased intestinal permeability, which further results in some chronic inflammation in the gut. And this is one of the mechanisms that we commonly see with colorectal cancer and bile duct. And cancers related to increased bile acid metabolism. All right, so moving on to the impact on cancer treatment, obesity also affects treatment of cancer patients. For example, during surgery, you can imagine there will be a longer duration of the surgery. There are increased anesthetic risks, and more importantly, maybe airway obstruction, cardiovascular effects. There's also a higher wound complication rate, increased risk of SSIs. We see this in obese patients, especially like the CS mothers. I think maybe all of us who have been in maternity have seen this. The mothers with obesity, the mothers with obesity end up coming back with a lot of surgical site infections and wound dehiscence. So also you have a venous thromboembolism. In terms of radiotherapy, usually we have to position a patient in a very particular way. Sometimes they need to be strapped. Sometimes there is a mask that they need to wear. So during radiotherapy, it becomes difficult to position these patients, difficult to immobilize them. And then also there is a lot of skin toxicity because sometimes you have to use a higher dose to be able to achieve the dose that you want to reach the cancer cells. There is also a wider treatment margin, which also results in a lot of radiotherapy associated toxicities. So usually there's a lot of problem in making sure that the patient is able to complete their radiotherapy because of the toxicity. In terms of systemic therapy, this is what now we commonly know as chemotherapy. However, it's not only chemo, there are other types of systemic therapy. So all of them, because these are drugs the patient is taking, there will be an effect in the pharmacokinetic of the drugs, how the drug is absorbed, removed from the body, etc., when you have increased adipose tissue. Also, there is an increased volume of distribution now when the patient is having obesity. Now, this is what has currently come to inform us that we should not just give our patients chemotherapy based on a standard dosing. It should be based on their weight as well. And we consider the full body weight so far. However, as Doc says, now we will move away from just the weight and consider other factors that will help us describe obesity better in a patient. Also, there's altered hepatic metabolism and altered drug clearance. Something I needed to add here. All right, so I need to highlight a particular type of drug, which is known as immunotherapy, because we've seen the relationship between cancer development and immune dysregulation or altered immune status. Over time, there have been some research that was suggesting that maybe the choice of immunotherapy could be based on whether a patient has obesity or not. And it looked in some studies that obesity was even giving patients with obesity were having better response to immune checkpoint inhibitors. However, the conclusion of that matter, because there's debate from one front and the other, is that we should not consider obesity as a single factor to modify the checkpoint inhibitors. So this is for the oncologists in the house. What's the impact of obesity on prognosis? As we have said, there's increased cancer-related mortality. We discovered this since 2003, and it is a significant increase. A lot of studies have been done on breast cancer, and we have seen there's a 33% increase in mortality. That is a third. It's really significant. Increased rate of recurrence of cancers. If we just check all cancers together, it's between 10 and 35, but in breast, it's much higher, again, 33. There's a higher risk of secondary primary malignancies. Remember, the same factors that resulted or that caused the first cancer could still be in play and cause yet another primary cancer if we do not take care of this obesity. In terms of survival, there is reduced survival on all fronts: the disease-free survival, progression-free survival, and eventually the overall survival. So how do we prevent and reduce risk? It's all those things Doc has mentioned here, that we need to maintain a proper BMI. We need to prevent central obesity. We are very keen on this, not just the general BMI. Regular aerobic and resistance exercises, as Doc said. In fact, just January this year, there was a study among patients with colorectal cancer, and they were being put through various types of resistance training and exercises. And we want to see whether this can be translated even in other studies and replicated, so that we can even now start learning those exercises and advising our patients. So we are catching up. Diet, what we've been told, we need to limit alcohol intake and processed foods, all that. Also manage diabetes and other metabolic syndromes optimally. So now, maybe some of us got lost with all those oncology terminologies. So now get your pen and paper, take this home with you. 1, adipose tissue is now viewed as an active endocrine and immune organ. The fat now is considered an organ, endocrine and immune. This is from the current studies. And also, we need to consider a full weight-based chemotherapy. Now, we don't just give single dosing for all patients. Then obesity also should not modify the checkpoint inhibitor. As we said, weight management should be routine in oncology care. And future oncology practice also is increasingly putting together body composition assessment, as Doc said, metabolic biomarkers, personalized lifestyle interventions, so that we are not describing obesity just using the BMI. Those are my references, and let's start exercising, as everyone here has said. Yeah.
Thank you so much, Michelle. That was not only concise, but very interesting. I would like to also recognize the chair of our board, Mr. James Wambu, and Karibu Sana. Thank you for being with us. We're going to go into hard science, so you'll forgive us. So thank you because of the presentation. Let me be honest, I'm a student of Professor Binya. So when we were residents in the University of Nairobi, as part ones, we also used to not only manage patients, and we used to prepare chemo. And at some point, we started behaving like oncologists. So when I was seeing Janus kinase and signal transducers and activators of transcription, I was like, I'm home. So we are not lost. The beauty about internal medicine, we made sure we did oncology well in Kenyatta National Hospital. But do I say? Thank you so much for that. So I would like to also introduce our next presenter, who is actually going to present a pillar of one of the interventions that are there in terms of the care of individuals who have lived with obesity. And this is Bwana Robert, who is going to talk about dietary intervention and the nutritionist perspective. So I would like to welcome you. Thank you so much.
So good morning. So thank you, Dr. for introducing me. I'm honored to be here. So I work here as a dietitian, and doctors have done a great job. I'll not take much time because much of the things that the doctors have talked about, there's no need of me in going back to them. So just to go to the introduction. Set it working. Oh, thank you. That is it. So for definition, this according to WHO, so it's a chronic disease, and this has already been done, so I'm not sure I'm supposed to keep on repeating this, but you can see the excess body fat, that what is dangerous and increases the risk of type 2 diabetes, cardiovascular diseases, and also certain cancers. So excess body fat is assessed by reliable measures, and this excess body fat can increase the risk of type 2 diabetes and also other conditions. So we should always use respectful language when handling these patients. So for example, we can talk about weight and healthy weight, but it's not respectful to talk about morbid obesity. Like telling a patient, Mami, naona uko morbid or you are fat. So let us try and use the most respectful words so that to avoid stigma. How do you feel if you come to the clinic then and tell, Mr. You are fat? Yeah. So let's try as much as possible to use respectful words. So obesity classification, one, we use BMI, and for BMI you can see we have all the way from underweight to obesity class 3. BMI is calculated by dividing weight and height, and the normal range should be between 18.5 to 24.9. For children, what we do, we use the Z-scores or the weight charts. These ones are the ones that try to guide us to know if you are okay. About the circumference, it's a measure of obesity, but I wanted to mention BMI is just a screening tool, it cannot be the only measure for obesity. As Dr. had already said, you can have clients who have very high weight, BMI is 35, but now when you assess them, the weight is not a result of the fat, but now the other composition like the bone weight, the muscle mass. Yeah. So waist circumference for men, if it's above 1 or 2, that means they are obese, and for women above 88 centimeters. So we should aim to lowering the waist circumference. These certain measures for body fat. We have Kutrrh, but now Kutrrh, these are skin fold measures. They usually measure the subcutaneous fat, and they are not reliable because they don't measure the visceral fat. Energy X-ray. This uses a raw beam X-ray to estimate the amount of fat and bone minerals, and also the lean mass. So this is very accurate, and it's inexpensive compared to MRI or CT scan. So this is very essential and can be used to estimate the body fat. Bioelectrical impedance. These are machines. We are lucky to have 2 of them in our institution. BCA machine, they use a small current, and the resistance of these small currents they pass through the body is what estimates the amount of fat that you have in the body. So for obese, the fat levels for men are above 25, and for females 32. So I'll not dwell so much into this, but you can see in 1990 there were 95 million people living with obesity. In 2022, that was 897 million. So 31 million in 1999, that's for children, and 159 in 2022. So in every 8 people, 1 of them is living with obesity. So in Africa, you can see this a rapid rise of obesity, and Libya is the leading country with obesity, and Ethiopia the lowest. But now we cannot just say that Ethiopia is doing very well, because Ethiopia has double burden of malnutrition, with obesity and the same time with undernutrition. And this is because of the economic situation, and also the poverty level also contributes a lot to this. So Dr. had already mentioned about our situation in Kenya. Okay, so Dr. had already talked about this. So about obesity among healthcare workers, we can see these studies that have been done. There was one study was in Gishu and another in Kisumu that showed high prevalence of obesity and overweight among the healthcare workers. So healthcare of obesity, we have already discussed that. So, and you can see by 2060, it is estimated that 3.3% of the GDP will be used in treating obesity and the related conditions. So this human circadian clock system, this usually controls how our body uses energy. It controls how the hormones work. What usually happens, we have a clock system in our body, 24-hour clock system. And we have 2 major ones. We have what we call the central clock and the peripheral clocks. The central clock manages our sleep-wake cycles, the hormones. Like, for example, what happens in the morning, the melatonin levels are usually lower. So that means you are not supposed to be asleep in the morning. So if this cycle is disrupted, that can bring a lot of disruption in the system, and that can also cause obesity. As you can see, a disruption of this can make you use your body to store more energy, and that can result to overweight and obesity. So these ones, I'm not going to talk about them, but now this one, we have to work as multidisciplinary. We have our mental specialist. It can help us as much as nutrition is important, but now this, because there are psychological effects, we can try and work as a team. Binge eating disorders, is night eating disorder. There's some people who just wake up at night around maybe 1 or 2. They just cook, eat, and go back to sleep. It's a disorder. So yes. So we should try and work with our mental specialist to see how. Yeah. So complication of obesity, we have already talked about this, so I'm not going to dwell much into that. So weight loss is very important, and studies have shown 5 to 10% weight loss may improve obesity-related health conditions. So the first treatment should be lifestyle, and when a client comes, these 5 A's that we use. First is to ask the patient, if the patient willing, ask about permission to discuss about weight. Mami, I can see your weight is this, so would you like us to tell the patient about the benefit of having a lesser weight than the weight that the patient currently has? So ask permission, explore readiness to change and address. Then assess if there is any other health condition, for example, comorbidities like diabetes, hypertension, complications, and any barriers. How does this client obtain the food? Who cooks the food at home? Yeah. Advice. So you discuss benefits of modest weight loss in context, discuss treatment options. Then you have to agree on realistic. We should individualize our patient. Not all plans will work for all our patients. So tailor the diet plan in according to your patient, because you will tell a patient to eat a certain food and the patient cannot really tolerate that food. So you should tailor your plan in accordance to the patient. Then you should assist in addressing this, for example, giving handouts, giving a tailored meal plan, and also arranging for follow-up. Because what usually happens for a patient, it's not a one time off. It's a chronic condition that needs follow-up. So you should also access if the patient understands about nutrition, take diet history. For example, what we do here, we take 24-hour dietary recall. Let the patient tell you how he or she eats on a normal day. So assess the food quality, the sugary and sweetened beverages, for example, soda and vegetables. Yeah. So define meal times and snacks versus grazing. So the patient take the 24-hour recall, all the usual dietary intake, how the patients eat in a normal day. Then reasons for eating out, for example, convenience, work, leisure, or enjoyment. Household factors also need to be accessed. For example, access to healthy or unhealthy food in the house, influence all household members on eating, lack of meal planning, and also, is there any designated eating area? Because some of these things happen unknowingly. You can find you are eating while, for example, watching a TV. You find that you are not going to control the appetite at that particular time. So avoid distraction when you are eating. So when we are focusing on weight loss, we make meal plans, and these meal plans should be individualized. So we have very low caloric meal plans, and this one should be used under supervision of a doctor. So what usually happens, after assessing the patient, after assessing the client, we come up with a meal plan, and this meal plan should be very specific. Yeah. So understand the rock of food that the patient takes, because it will not make sense prescribing something that cannot be available, and also that the client cannot be able to afford. Yeah. Yeah. So it should be tailored and specific to the particular patient that you are having. So this is very important. And for weight loss, anything that you need to, all that you need to do is to balance the amount of energy the patient takes and the expenditure. Because for you to have a negative balance and encourage weight loss, the intake should be less than the expenditure. So here is where also the physical activity comes in. So for physical activity, the recommendation is 150 minutes of moderate intensity or 75 minutes for vigorous intensity. And you can see the recommendation for children. Physical activity for children under age of 5, you can see from the chart, this is how they are supposed to, at least 30 minutes, that would be crawling, yeah. Then 180 minutes, and that one for 5 to 17 years. So at least 60 minutes a day of physical activity for 3 days a week, and should limit screen time. Yeah, screen time should be limited, because you see nowadays children have been addicted to the screens. They are on TVs, they are on their phones. So this can really be detrimental. 18 to 64 years, the recommendation is 150 to 300 minutes for moderate aerobic exercise, 75 to 150 for vigorous, and also should also encourage strength training. For example, as Daktari was saying, we can do the squats, the press-ups, yeah? And it's not a must you have all the 150 minutes at once. You can split this. For example, there's those who can do a morning and in the evening. If you have breaks during the day, you can try and utilize that, because sometimes getting all the 300 minutes or 150 minutes at once could be a bit hard, yeah? So, and that goes up to 65 years and older. These are the recommendations. So it should include aerobic and anaerobic, and strength training is very important to ensure that there is energy balance. Behavioral therapy, this where you should also involve the psychologist and also the psychiatrist, because some of these patients have mental issues that can hinder the weight loss journey. So always make sure you work as a team to ensure this. So give these patients the handouts, guide them according to their needs, and this makes it becomes very important to make sure you take a very good history. Know how the client eats. Does the client takes even more when they are under stress? Because there are some people who eat a lot when they are facing certain challenges. Yeah. So, for example, a client comes, maybe may experience a breakup hivi karibuni, si ndio? Yeah, there are some people who eat a lot at that particular time. So stress can also lead to obesity. Then I'm not going to discuss about surgical management that Dr. has talked about. This intermittent fasting that people has been using, and research has shown that its effectiveness for weight loss is with individuals with obesity. This was a meta-analysis of randomized control trials. This was done in August 23, and the results were intermittent fasting is not associated with greater or lesser weight loss than non-intermittent fasting diets. Yeah, have we tried intermittent fasting? Yeah, will give us testimony if you share here, because I was also following up on the Citizen weight loss program that was running a few years ago, and I discovered most of the clients who were on those programs, they had a rebound. They gained a lot of weight. And why? Because sometimes you are given some programs that are not sustainable. Yeah. So you are used to taking maybe 2,000 kilocalories in terms of energy. Then all of a sudden you're taking 800. You will of course lose weight. But now, is it sustainable? The program should be very sustainable. And we should encourage a gradual weight loss. Don't be happy when you lose like 20 kgs at once. Yeah. The body has its way of defending, yeah, that loss. So it should be modest. And that's the reason you are saying you should talk to your client, ensure that the client understands this process understand they can be rebound, and support where possible. Repossession is not a weight loss. It's not a weight loss procedure, but it's a cosmetic. This is just removing fat from specific areas of the body. Yeah. So this has also been trending. So surgical removal of fat exerts several metabolic benefits in the short term, but only improvements in insulin sensitivity last beyond 6 months. Then there's also fat diets. We should avoid the use of fat diets. For example, there's this thing. What has been trending shortly about weight loss? Juicing. What else? OMAD. What is OMAD? 1 meal a day. Yeah. So these fat diets, the problem is they are not sustainable. You can imagine taking 1 meal a day until you die. Yeah? Because for any program that you implement, it should be sustainable and right from. So ensure that the program that you take, and that reason should come to us guys. We have the machines here. We'll be able to take your body fat levels, the visceral fat levels, that the fat around your abdominal organs. Then come up with a meal plan that will be able to control the portion that you take, because portion control is very important. You could be eating very healthy meals, but now the amount of energy you are giving your body is high. Yeah, you could be taking very healthy meals, but the amount of energy you give your body is high as compared to the level of expenditure, and that can lead to weight gain. So take home points. Obesity is a chronic, multifactorial, and relapsing disease that affects millions and requires lifelong treatment. So there's interplay of genetics, epigenetics, yeah, and also understanding this disease and treating patients affected by overweight and obesity will have a significant impact on the lives of our patients. Thank you very much.
Thank you so much for that presentation. As usual, things on food can be very provocative. And I always like to say that one of the interesting things we have in this hospital is the meal plans our patients are usually given. And I always laugh because when I look at the meal plan, I usually see there smoked salmon or salmon. So then when I look at the patient, I ask them, Mama, unajua smoked salmon ni nini? And usually she would look at me and just smile. And the other reality, whenever I do my ward rounds with the residents, I always ask them, so this patient was cancelled on what they are supposed to eat. Did you ask who actually cooks in that house? So they say no. So I ask, and usually it's for the men. Habari baba, mzuri. Kwa nyumba yako, ni wewe unapika? Hapana. Nani anapika? Ni madam. So please, when there's nutrition counseling, I always insist, it's almost like a family therapy session. You get the wife on board, and then the husband also has to agree to what the wife will bring. Because the husband, when he'll get home, he will say, hii chakula umeleta ni ile daktari alisema. Mimi ninataka iyo nyama, iyo ugali, na nataka uweke iyo. Usually they would add butter even in the food. So those are the realities. It's not an exact science when we're trying to look after these patients, but it's a journey. And I always insist, when we're looking after these patients, it is holistic. It starts with science, but there's the art. So what I'm trying to say in a very polite way, we need to look at the patient information that we give, especially when it comes to some of these things. Keep on working on it and seeing what is relevant. Find out in the general population. You mentioned here the fact that there's a fad diet called OMAD. There's also a reality diet called Hakuna Vitamin M. Hakuna pesa. So there are people who eat 1 meal a day. And that is the reality. So I guess, with a light touch, of course, we've brought this brief session to a close. I would like all the panelists to be here. I would like Dr. Mithi to come on board, because now what I would like to do is open the floor for any burning questions. I feel it's also very important to have that. Is there a mic available? Or I just go with this one? I can. Okay.
Thank you. This is an interesting topic. I'm so glad I was here this morning. Maybe I'm looking for free tips or consultation. But on Zempic and the other one, it's called? Yes. I want to hear about the side effects. I know a lot of people, I know a few people who are using. So, and my question has been, what is the side effect? Then the other one is, I don't know, I said it's free consultation. What happens? I eat very well. I exercise at least 3 times a week, strength, kila kitu. But the 6 kilos are refusing to go. Just to know, premenopause, maybe issues checking in, but free consultation on what's next. And can you use Ozempic or these things to lose minimal weight? And when you stop, there's that rumor that when you stop, you add, every month you're adding, 10-20% of what you lost.
Okay, very good question. So side effects, let me take them short-term and long-term side effects. So the first thing is when you're injected, you'll experience nausea because it works at the brain center. You'll have nausea, you may have a bit of vomiting, you may have, because it slows down the movement of food in your gut, you'll have constipation. Some patients will have a bit of diarrhea. You'll have gastritis because the food is sitting more in your stomach. So you'll have hyperacidity and gastritis. So those are the short-term effects to expect. Long-term effects, if you take alcohol, there's a risk of acute pancreatitis because this medication works also on the pancreas to produce insulin. There's a risk of developing gallbladder disease or gallbladder stones, but we know that if you have fat, there's already a risk of having developed the gallstones because that's what forms so it almost unmasks the gallstones or the gallbladder disease that was there. The other risk factor is if you have a family history of thyroid cancer, we wouldn't give you this medication because in rodents, it was found to have an association with medullary thyroid carcinoma. So all said, it is a safe medication. In the eyes, if you have severe diabetes eye disease, there's something like causes blindness. So it's really not blindness, it's something called neon, which is retinopathy worsening. And so any patient who has diabetes will need to first be seen by an ophthalmologist to tell us, do you have diabetes eye disease before we put you on this medication. That said, it is a safe medication. We need to educate patients that these are the side effects to expect. I mean, given these medications have been with us less than 15 years, or rather 10 years around thereabouts, so there are other long-term effects that we do not know. But what we know is that this medication is a lifesaver for us and for many patients as of now. So what happens if you want to lose a few kgs in a few? So you will, especially there's something called plateau where, like Robert mentioned, your intake in terms of how much calories you're taking in is almost equivalent to your expenditure. And there's something called BMR, basal metabolic resting rate, which actually slows down, especially as we grow older because of the lack of estrogen. So you'll hear patients in perimenopausal and menopausal are not losing weight as fast. And so would you take these medications? The answer is 2 ways. Yes, if you meet the criteria, if your BMI is above 30 or your BMI is above 27 with comorbids, a risk of diabetes and hypertension. But if your BMI is not 27, please do not take this medication to lose the short-term weight. Yeah. So, Dr. Ngugi, I'll send you my invoice.
In essence, mambo ya luku sio muhimu sana. Any other questions? And feel free to ask questions. As the mic gets there, did you know that the BMI formula was developed by a Belgian mathematician and used by an insurance firm owner to enforce the whole thing on who are the people to be insured health-wise or not. I just thought it's a fun fact to know.
Yes,
Go ahead.
good morning. For me is, what about us who got obesity after what about us who got obesity after taking steroids from a chronic ailment? And you find that you're trying by all means to lose the weight, but it's not going because you're still taking those meds. And I've been also told that the zebra, the elephant, and everybody else, those kind of animals take vegetables or greens, but then when you look at the lion, the tiger, it's the meat. So we get confused somewhere. Please kindly help us. Thank you.
Thank you very much, Lucy. Lucy, could you please stand up? Yeah, Lucy is one of our patient advocates. She's a breast cancer survivor. Makofi kwake. Yeah, she has been a very strong pillar supporting all our cancer patients, supporting us, the doctors, to ensure they're getting timely diagnosis and treatment follow-up. Thank you so much, Lucy, for coming. Yeah, so one of the biggest elephant we are having in our cancer patients is obesity. And Dr. Michelle has put it very crystal clear that our patients, they're having poor diagnosis if they become obese. So I'm sure Lucy is mentioning steroids because she didn't want to mention she's a cancer survivor. Yeah, so she's our hero. Nowadays, they don't want to be called survivors. They call themselves which name? Exactly. Yeah, so I will give it to Dr. Mithi to help us in that area.
Thank you, Lucy, for sharing. So what do we do in what we call medication-induced overweight or obesity? So the 4 pillars still go into place, where we have the nutritionist come on board, and they're able to do, like they said, the bioimpedance, and it will tell us what is your basal metabolic rate, and we calculate how much calories you're allowed to eat, or rather you're able to eat, especially if you want to have that caloric deficit. That is 1. 2, then we recommend physical activity or exercise. And I'm happy to hear that you've done, the physical activity and the exercise. What I need to mention now, nutrition, it's not only now eat vegetables and you lose weight. So we found that there's a great role of protein. And so now we are saying we have to get back to eating protein and get back to eating meat or lean meat. What we want to kick out is sugars or sugars in any added form, and also starch and carbohydrate. We want to get our calories from the protein and the veggies, as opposed to a lot of carbohydrates. So we'll get much of our carbohydrates from what we call starchy vegetables, or we'll get from also cereals like beans, peas, which already have carbohydrates in them. So if you can cut out the rice, the sugar, the bread, then we focus on whole foods. That will be good. But working the nutritionist. And then now we look at, together with the other physicians, is, are you a candidate for these GLP-1 medications, or whether oral or what we'd call the injectables. So there are options over and above just the lifestyle. And especially if the overweight or obesity is causing what we'd call like a morbid condition going on. So now there is treatment. That's what we want to say. After your course of treatment, then you come to us and we're able to put you through. And it's progressive. Not everyone will get the medication up front. We'll first do a month of lifestyle, and then we assess and see. Yeah.
Thank you very much. And I think it's important that we must add that care for every particular patient must be integrated. So I guess even for those who are the thrivers and who are moving on, I think it's very important within the hospital we have to start having the mentality of integrated care and not necessarily operating from silos and pure referral. I was told to share my testimony. I was hearing this story about starch and reducing starch. And I'll put a full disclaimer. I'm very proud of where I'm from. My home is in Ukambani, though I also have heritage from Western Kenya. So I have generally broad shoulders from ugali that I've eaten in Western Kenya, and played a lot of rugby. So I was rather large in some ways. So I had added quite a bit of weight and had some injuries, and started doing certain things for myself. I've always had an active lifestyle, played sports, done all those things. But food noise is a reality. Food is good. Food is good. But because of a bit of discipline now, we've brought weight from 99 to 93. There are trousers I could not wear before. Now I can wear them comfortably. Oversized shirts now are slowly being put away. Very soon I'll be wearing shirts like a bed. And on that note, I want to release you for the tea break. But there are also some things. Okay.
Sorry for that. Number one, thank you so much for your kind attention and being here early on time. We are slightly behind the schedule, but we want to do justice because people have done really hard work to prepare their research to be presented. So from here, I would like to thank my panelists, but first we'll take a group photo for my panelists. Makofi kwao. Then after that, we are going to move to yesterday's abstract because these people have really worked hard. And with that, I would like to recognize Dr. Joanne Simam, Director of Research and Data Informatics from the National Cancer Institute. Dr. Joanne Simam, watu wakuone, na tunakuomba uje mbele tafadhali. Yeah, so these are the kind of research Joanne will be very interested. Usually they have very good grants. This year they gave us 3 million. I'm doing that research. 3 million. I'm very rich. So thanks to Dr. Joanne. Yeah, I've been given 3 million by the NCI so that we can be conducting research. So now, have a seat, please. So thank you so much for coming. Mwongeleshe vizuri. This is the person you need to meet during the tea break. Mumzunguke kabisa. Ako na pesa mob sana. Lazima tufanye research, si ndio? Tunaitwa nini? Kutrrh. Hiyo R sasa amekuja hapa. Nimemuita kusudi. Nimejua akikuja hiyo pesa tumepata. Mumshike mashati tafadhali. Thank you so much. Let us take a group photo. The next session is abstract, which were missed yesterday. We are going to do what we call rapid fire abstract. That means we are having only 5 minutes to present the most important data in your research. Moko tayari? Our first presenter is Maureen. Get ready. A group photo. Thank you so much. No, this is after the tea break. So, are you ready for the rapid fire? Maureen? Let's move. As how the team obesity coming down, I have a very big question. Elephant anakula nini? What does elephant eat? Anakula majani. Those are vegetables. Lakini tukiangalia body size yake ni gani? Hiyo mtatusaidia watu wa obesity. Mtuambie kwa nini? Elephants live long and they are obese and they are eating grass. Thank you. So I would like to introduce Dr. Maureen, who is going to present. This is real data from the KU Referral Hospital. We have been doing an amazing job. We all know that cancer is bad. You must undergo surgery. So Maureen is going to tell us it's not a must for you to undergo surgery and you're going to survive your cancer. Welcome.
Good morning. My name is Maureen Wanjiru Nganga. I am a Year 3 COSEXA resident training in general surgery. I'm making this presentation alongside Dr. Alex Muturi, our colorectal surgeon, who is joining us shortly. So today I want us to see what the findings are for our patients with rectal cancer who are able to achieve complete response after total neoadjuvant therapy, and we subjected them to the watch and wait protocol. So traditionally, the treatment for rectal cancer has been that we have to undergo surgery for you to achieve cure. But this is associated with loss of function. The surgery that is done for rectal cancer is often a very invasive surgery, very high morbidity associated with the surgery. So now, with a shift to total neoadjuvant therapy administered to rectal cancer patients, there was a trend noticed where the cancer that was initially there was noted to have resolved completely on clinical examination. And so now for this cohort of patients, the discussion now started being, can we actually just observe these patients and not subject them to the major surgery? And so what that means for our patients is that the patients undergo a very strict protocol where they are observed intensely for the first 2 years, because recurrence of rectal cancer, even after achieving complete clinical response, is very high in the first 2 years. So for our patients, what we did was that we gave them 4 monthly DREs, 4 monthly MRI, CEA, as well as 4 monthly sigmoidoscopy. And then every 6 months, we want to do CT scan of the chest and the abdomen and pelvis. And so from the period of March 2025 to June 2026, we were able to follow up 14 patients, of whom 10 were male and 4 were female. Of these patients, we had patients with ECOG 0 and ECOG 1. So our patients, 7 of them were ECOG 0, 7 were ECOG 1. And a lot of the patients had mid to low rectal cancer, and majority of them were T3 in terms of T staging, and N1 in terms of N staging, and most of them were M0. What we noted for our patients is that after getting total neoadjuvant therapy, about 57%, that is 8 of our patients, got complete clinical response, which is very encouraging. And then of our patients, 6 of them, 6 of them got near complete clinical response. Now, what this means is that for the patients who had for all these patients who had near complete response or complete clinical response, we offered them the option of either going through watch and wait or going straight into surgical intervention. All the patients initially wanted to have watch and wait done, and which we started them on the monitoring. During the monitoring, from the 14 patients, 7 of the patients underwent surgery. So meaning that to date, we have 7 patients who achieved clinical response and are having sustained clinical response many months after they were enrolled into the program. Now, of note is that for the 7 patients who underwent surgery, we had 4 patients who had tumor regrowth as the reason for undergoing surgery, and 3 patients who opted to just undergo surgery without waiting for the whole duration of time. And now the patients that we had undergoing surgery, 3 of them underwent low anterior resection, with 5 undergoing abdominal perineal resection. Just a note on some complications for our patients, or findings from our patients. We had 1 patient unfortunately passing away following complications of surgery, for the patients who underwent surgery. And then 1 of the patients who had a near complete response and underwent an APR subsequently developed an ascending colon tumor, for which he underwent a right hemicolectomy about 14 months post the APR. Interestingly, we had a patient who had near complete response but opted to go for surgery despite not having tumor regrowth. At the time surgery was done and the histology was done, the patient was found to have pathological complete response. On the pathological specimen, they actually didn't find any tumor, which is in keeping with the data that we have, saying that the peak time of properly developing complete clinical response after total neoadjuvant therapy is actually 19 months after the radiotherapy has been administered. So for the longer the patient can wait, even with near complete response, there's potential for them to achieve complete clinical response afterwards. So what we are saying in essence is that we can be able to preserve the organ. This is now the rectum, for these patients who have rectal cancer and achieve complete or near complete clinical response, for as long as we have to put them through a rigorous surveillance. As you can see, there are 28% of our patients, that is 4 out of our 14 patients, had tumor regrowth within the 2 years. This is in keeping with the data that has been published internationally. And it's possible for these patients who undergo tumor regrowth to get surgical salvage and have it successfully done, and now for them to continue with their management. We had just some information about generally rectal cancer and the management. So of note is that with studies that have been done, a lot of patients are very keen on avoiding a permanent stoma. That is why these findings are very encouraging, because it tells us that for a majority of patients who achieve clinical response, we can actually help them avoid a permanent stoma. And now this, we've essentially discussed it in the presentation. And now what you do is, when you do a DRE and you do endoscopy and you do a pelvic MRI, you can be able to properly predict complete clinical response in about 98% of patients after total neoadjuvant therapy. And now, with a near complete clinical response, the data is not as clear, but there's a room for these patients with near complete clinical response to just wait it out for as long as there's no tumor regrowth and see if they'll achieve clinical response. There's no role of biopsying the tumor bed after achieving complete clinical response or near complete clinical response due to the fragmentation that often occurs and often the negative findings on histology. This is just a video which... So this is a patient who had near complete clinical response. As you can see, we have an ulcer and a bit of stricturing at the area of the previous tumor site. So this is a patient who will monitor but may likely end up having to undergo surgery. In terms of improving complete clinical response, what has been done is that we've intensified chemotherapy and we've intensified radiotherapy, but there's always the risk of local regrowth, there's a risk of distant metastasis, and the need for salvage surgery as required. As the last thing, let me just mention this. In a subsection of patients with rectal cancer who have MSI high rectal cancer or deficient MMR rectal cancer, there's a new drug that is actually showing quite a bit of positive findings, where you have, when you administer PD-L1 blockade, you have complete disappearance of the tumor without necessarily needing any chemotherapy or any radiation therapy for this subsegment of patients. Thank you. Sorry, it was very fast. I will...
Thank you so much. Thank you so much. Makofi kwake. So mnaona how our COSEXA residents are really hardworking, yeah? Dr. We want to publish that data. We're coming back to you. Thank you so much. Okay, so we have seen like this is just a multidisciplinary work, which we, the oncologists, we give chemotherapy. After the chemotherapy, now we follow with the radiotherapy. So because of that, the patients, most of them, they had complete response. The cancers disappeared completely. Then after that, we are handing over to the surgeons. So all these, the surgeons are the one following up to confirm if the cancer is back, will the patient require surgery or not. So these guys, they are doing amazing jobs. Makofi kwao. We are moving to our next resident. Now we are going to see the ugly side. We have seen the good side. Let us have a look at the ugly side. I'm going to invite Dr. Florence Wanjiru Wangui. She's another COSEXA resident here in KU Referral Hospital. She's going to talk about argon plasma coagulation for radiation prophylactics, experience from a single center. Karibu Daktari. 5 minutes. Please don't talk science. Talk about your research. The science will go back and read. Talk us about your research. Thank you.
Good morning, everybody. Okay. Good morning once again. As you've heard, I'm Dr. Florence Wanjiru, the dear General Surgery COSEXA resident here at KUTRH. I acknowledge my supervisor and teacher, Dr. Alex Muturi, who we've been working with in this presentation. So we are going to talk about argon plasma coagulation as a management for radiation proctitis, the experience we've had here at KUTRH. So just as an introduction, we know that radiotherapy is a cornerstone in terms of management of pelvic tumors, especially gynecological tumors such as cervical cancer, rectal carcinoma, prostate cancer. And we see that radiation proctitis, which is a common complication of radiotherapy, presents after we have some mucosal injury to the rectal. Okay. Okay, I hope you can hear me now. Okay. So I'm saying that radiation proctitis is a common complication of radiotherapy, a cornerstone treatment of pelvic tumors such as rectal tumors, cervical cancers, and prostate carcinoma. Most of these patients, they have presenting symptoms of rectal bleeding and some irritative symptoms such as diarrhea, tenesmus, cramping, and pain. And in the acute phase, this is mostly due to inflammatory injuries to the rectal mucosa. And later in the chronic phases, mostly the pathophysiology is due to end enteritis and also progressive ischemia causing fibrotic changes into the mucosa of the rectum. Majority of the patients will present when acutely presenting, they present between 1 to 3 months of radiotherapy. And we have chronic phases where they can present up to 36 months after radiotherapy. Majority of our patients, as we'll see, they presented in the chronic phases with a range of around 8 to 12 months. We see why this is important in terms of management of radiation proctitis is because it impacts the quality of life of our patients, where they have sometimes they have severe bleeding requiring multiple transfusions, and we see this can also cause frequent hospital admissions and of course deterioration in terms of quality of life of our patients. So in our endoscopy unit, we are able to analyze a total of 33 patients between the period of February 2024 and May 2026. After we analyze the total number of patients, these are the ones we are able to analyze. The range of, in terms of age distribution that you are able to see in our patients is between 40 to 82, with a mean age of around 63 years. We see in terms of etiology of the cancer of the patients presenting with radiation proctitis, majority of the patients who presented to us had a primary tumor of cervical cancer. And the next subgroup of patients we saw is patients presenting with prostate cancer and also vulval cancers. The gender distribution, this ties with the etiology, where we have majority of the patients being female, presenting at 75% compared to our male patients who are at 24%. In terms of clinical presentation, the major symptom that our patients had was rectal bleeding. We had a mean HB of 9.6 in the patients that you're able to get pre-treatment HB levels. But you see a subgroup of patients, around 20% of the group, presented with severe anemia of less than 7, with the lowest recorded HB at 4.4. This patient had severe bleeding as one of the presenting symptoms. In terms of endoscopic findings, majority of the patient presented with telangiectasia, and we see on top of this telangiectasia, some patients, like 18%, presented with features of active bleeding or features of recent bleeding on endoscopy. Some complications that were encountered, we had some patients who presented with ulceration already at 9%, and one patient presented with a friable mass, which after biopsy was found to be benign. So in terms of the intervention, we'll see with management of patients with radiation proctitis, there's both non-surgical and surgical management, or rather medical management and endoscopic interventions. In terms of the argon plasma coagulation that we're able to do on our patients, we had like a mean number of sessions at around 1.6 sessions, where majority of our patients either got 1 to 2 sessions. Especially those who got 1 session, it was either because of improvement with 1 session, and sometimes we have challenges and financial challenges, they're not able to come back. Around 12% of our patients had 3 sessions, and we will see this ties mostly with the severity. Most of the patients who have more severe symptoms on presentation will also have the requirement of more sessions in terms of the number of APC sessions they require. We see that some of the patients had combined therapy using both medical interventions and APC. And among our patients, 42.4% had formalin therapy as an adjunct to the APC, and 18% had use of sulfate enemas as an adjunct as well. So in terms of outcome, when you talk to the patients during follow-up, we see that 55% actually reported improvement or rather cessation of bleeding after the APC sessions. And we have 30% of the patients that reported improvement, even though partial. This was mostly described by reduction in the frequency in bleeding and also the reduction in severity in terms of the amount of bleeding. So when we say partial improvement, the bleeding that remained did not interfere with their day-to-day activities. A small number of patients reported persistence of symptoms, and mostly these patients are the ones who also had very severe symptoms during presentation. In terms of transfusion burden, we're only able to pick 8 patients who really required a number of transfusions before treatment, and most of them, the range was between 2 to 4 units of blood of transfusion before treatment. But we noticed after the APC sessions, only out of all the 33, only 2 patients required transfusion, and of the 2 is still the patients who had very severe symptoms. Remember, we had one outlier who had very low HB and actually required almost 7 transfusions post treatment, but not in the same sitting. These were 2 different scenarios. Of note is that she was not able to get several episodes of APC because of financial reasons, but we called her back to the unit. We should be expecting her back. So as I was mentioning, mostly return of symptoms or recurrence is mostly associated with severity on presentation, where patients who had more severe symptoms had more occurrences where they had recurrent bleeding, even though not as severe as the initial one. 48% of the patients still remained with no symptoms at all. 39 had minor recurrences which did not interfere with their day-to-day activities, and only 12% or around 4 patients who reported some significant bleeding. We also see that also the number of transfusion was also related to the presentation in terms of the severity, and also the requirement of more APC sessions was also related to the severity on presentation. Of note is that we noted patients who had adjuncts in terms of medical management also had better outcomes, with patients who had formalin therapy actually having lower rates of recurrence or bleeding after that. In terms of the safety of APC, of all the patients we reviewed, 94% did not have any complications, and the 6% that had complications, they reported minor pain and also some procedural spotting, which were self-limiting for most of the patients. It's only one patient where there was a feature of probably more severe complication, where after one APC session, there was report of some mucosal thinning, so the second APC session was deferred to avoid other complications such as perforation. So we see with all this, we come to the conclusion that from just our data, Probably we'll need more patients, but just from the data we have, we see that APC can be used as an effective method of managing these patients with radiation proctitis due to the clinical outcome where there's some clinical improvement, the safety profile where we have minimal complications, and also the reduction in terms of transfusion needs for this patient. And this is in keeping with the different guidelines that allow the use of radiation proctitis as one of the major interventions for, the APC as major interventions for radiation proctitis. Yes. Yes, thank you.
Thank you very much. Thank you so much, Maureen. This is amazing job. Sorry, Florence. Thank you so much, Florence. Mnaona vile resident wetu wako sexa wanasoma na wanafanya kazi. I would like to recognize the presence of their supervisor and their teacher, Dr. Alex Muturi. Salimia watu wakuone. Yeah, so Dr. Alex Muturi, I think, is among the few colorectal surgeons we are having in Kenya. I think we are less than 5. There are only 2 in Kenya, so KU, we are privileged to have a colorectal surgeon. Makofi to the team. Now we are moving to the nursing side. We would like to show you also what our nursing team they are doing. Somber Faith, are you ready? Yeah, so she's going to talk about the case series patient-centric kidney care, the evolving role of the nurse in incremental hemodialysis for better patient outcome in patients with chronic kidney disease. Karibu sana. Please let us focus on our data. As the science we can refer online. Thank you so much.
Good morning. My name is Somber Faith. I'm a nephrology nurse. You'll find me at the renal unit. Forgive me for the dates. Seems like someone was sleeping on the job. So we can move to the next. You've seen the beautiful pic of your KUTRRH main entrance. Oh, sorry. Okay. I want us to talk about incremental dialysis for better patient outcome, the evolving role of the nephrology nurse. So definition, hemodialysis. Hemodialysis is a renal replacement therapy whereby patients with kidney failure get treatment via a filter enhanced by an hemodialysis machine. And so what is the incremental approach? The incremental approach is a short treatment time dialysis through which clearance goals are achieved by combination of renal residue function. In this case, we prescribe dialysis considering the renal output. So it is an approach that has been utilized for better patient outcome in patients with renal residue function. And so the nurse comes in very instrumental in this because the nurse understands the interdialytic and the interdialytic dynamics of renal patients undergoing chronic dialysis. So leaving us with the question, when does the nurse take into account optimizing incremental dialysis? For the renal team, you'll picture this, and even for the other, it's a multidisciplinary approach. These are client dialyzing thrice weekly with exemptions of fluid overload. Why would the client get 4 hours hemodialysis treatment? So optimal dialysis adequacy can be achieved even with a 3-hour hemodialysis treatment, and we can go in thrice weekly depending on how your patient is presenting. I don't know, do you agree or not? So we will all agree that in advanced countries, optimal hemodialysis is achieved through 3-hour, thrice-a-week sessions. While we appreciate that we are limited to bi-weekly, courtesy of SHA, that is where we are at currently, and that is what informed the dialysis sessions to be bi-weekly, lasting for 4 hours. So in as much as we are trying to reduce this the duration time, we are factoring clearance goals. So we consider optimizing incremental hemodialysis for patients. And we also factor the BUN, the blood urea nitrogen, serum creatinine, potassium, phosphate, calcium levels, etc. Most importantly, we consider the ultrafiltration volume. So 5 patients were under study between April 2023 and 2024. They were adult patients, 40 to 70 years. They qualified the study. They had a urine output of over 500 mils. They all went through incremental dialysis approach. The results were 2 were weaned off hemodialysis. The first and the second patients were weaned at 4 and 7 months respectively. Thereafter, both patients have been on monthly routine clinical checkups. On the other hand, the remaining 3 patients received incremental approach after reinitiation of dialysis. Recently, 2 weeks ago, one was graduated to biweekly. So we only have 1 patient undergoing incremental. That is not captured here. So patient outcomes, less intradialytic hypotensive patients. It's a good approach for when your patient has low BPs. Number 2, weaning off patients from hemodialysis within 4 to 7 months. Thus, patients can enjoy dialysis holiday. And the greatest of them all, preserving renal residue function. So examples of incremental approach include 3-hour dialysis twice weekly, 3 hours dialysis session lasting with a frequency of thrice a week, or even 4 hours dialysis session once a week. So the challenges we are having, inconsistency with compliance regarding tri-weekly hemodialysis. These patients face, let's say, a burnout of the regular visits to the hospital. SHA provides, currently it provides for the 2 sessions. So the third one, patient has to pay for it, which is also a challenge. And the third one is the nephrology team also not picking up the approach on time. There are also gaps in input and output for the clients, maybe when they're doing so at home. So thorough follow-up by the renal team in liaison with multidisciplinary team, especially with the CKD patients, is also a gap. Part of the recommendations, we recommend that the renal multidisciplinary team incorporate incremental approach in dialysis session. We recommend that patients should be informed about the incremental approach. To provide interesting evidence-based approach on the same, initiation and reinitiation, we acknowledge that more data is needed, including randomized experiments. It's an ideal approach for intradialytic hypotension, also for geriatrics. So the role of the nephrology nurse, you can see that.
Thank you so much. We said we are presenting data. The rest we are reading, okay? So this is a rapid fire session. Thank you so much. Don't stay on the floor. Rudy, please. Somba, Faith. Rudy, please. The other residents, please. Karibuni. Naomba swali moja moja kwao. For each person, 1 question, 3 minutes. We are going for tea break. Mko na maswali you want to ask them? Okay. Microphone. Have a seat, please. Have a seat.
I think for my residents, I'm here to shield them. So if you have any questions, direct them to me.
So since I'm seated next to you, I'll bring it up. There was the one I was asking. We were just, of course, having our small chat here. Was, for example, for CA prostate patients with some of the modalities they have for radiotherapy. I know that now the 28-day session seems to be, people are moving towards that direction for radiotherapy from what I believe is either low risk, CA prostate. I don't know about high risk. I'll not comment about that. But I do know that that movement towards the 28 days at least has been helping in terms of the issues of the proctitis that tends to develop. And why I was asking, it was not necessarily pointed at the team here, but I guess I was asking our ABAID and our team who deal with oncology patients, whether our country is now, many of our teams are moving in that direction because of better outcomes. So it's not a question, more of the what other comments you could give us.
Okay, thank you. So among the patients who usually experience proctitis, these are prostate cancer patients, cervical cancer patients. So like in the world of oncology, especially radiotherapy side, we are moving to what we call hypofractionation. Hypofractionation, it means like the standard treatment, if you used to give it for 4 weeks, now you shorten it. You make it for 2 weeks, 3 weeks, or even lesser. So he's asking whether in prostate cancer, are we applying the shorter one and does it have a better outcome? The answer is yes. Once you fractionate your cancer treatment, you are going to have less toxicity because you're exposing them for a shorter period. However, you are giving it for a longer period. So according to most of the studies, we are having good evidence. It is much better if you can shorten the treatment. So the answer is yes. Even in breast now, we are going to move into 5 fractions, moving from 15. When we started breast, we started with 25 fractions. Then we moved to 15 fractions, which we have been applying since 2000. Last year, we have now and presented this year in major meetings, like breast cancer, it is now safe. You can give 5 fractions and you are done with the treatment. So even in prostate, here in KU, with our CyberKnife, we want to start giving prostate for only 5 sessions. But the question is, where are these patients? Because this is only requiring patients coming with an early disease, very small tumor. So we are going to start here in KU with our CyberKnife, just 5 fractions, and the patient is going home. Next question. Next question. From the audience. It means you guys, you did an amazing job. Thank you so much. Let us proceed for the tea break. So we are going to shorten the tea break for only 15 to 20 minutes, please. So all of us will move out there. Our faculty, there's a small room on the left here once you are going out. Let us enjoy our tea. Let us be back here by 11:35. Okay, thank you. Sorry, my residents and all the speakers, come on the stage for a group photo. My residents. Cameraman. Our registrars, please, come. Somba. And you, yes. Huh? No, those who presented. You guys are very important. Take the stage.
such a rush, my baby, slow down, come find your love. I'm hoping you see me, come serve it up. Loving when you stir it up. That body belong on TV. Oh, this feeling I can't hide. You're feeling up my mind, and I just don't know why. I just don't know why.
Thank you. Would like to continue. I hope you guys enjoyed your tea break. Like the catering guys, I was asking for a cake. Then they were asking me, hey, Daktari, kumbe you have a sweet tooth. I told her, no, I just have a sweet heart. So I hope you guys also enjoyed yourself. We are going to start with the rapid fire. Are you guys ready? Because it's going to be fire. Please let us not talk science. Science only for the introduction, less than a minute, okay? Let us share our data because we want to see what we are doing in our institutions. Sawa? Okay, thank you. So our first presenter will be Dr. Penina. Penina is going to talk to us. You remember in the obesity, we were told like young men looking healthy and everything. Now she's going to show us a real example, like what people are going through out there. Is it too young for a heart attack? Acute anterior STEMI and heart failure. Musi confuse na ile ya education STEMI. Heart failure with mildly reduced ejection fraction in a previously healthy 32-year-old male. Welcome.
All right, good morning, everyone. So I'm going to take us through a case that we have managed in our facility. So I think from the theme of this conference is closing the gap, like care without gaps. So for us, we are trying to do that even in various departments. So this is a case of a 32-year-old who presented to us with acute STEMI, myocardial infarction, what we commonly call heart attack. So we thought it's very important that we highlight some of these cases and some of the success stories that we have in our facility. So I have to acknowledge my consultant, Dr. Kanyeki, Dr. Kutrrh, and Dr. Kivai, whom we have managed this patient with. Sorry, the slide. Where do I point? All right, so yes, so part of the presentation is just to go through all that. So just to highlight some background is that premature MI, these are like acute myocardial infarction, which occur in patients who are less than 45 years for male, and then for women, patients who are less than 55 years. So in terms of the global incidence, we have a percentage of like 5 to 10 patients who have acute MI. Among these patients who are within that age group. And in the US, they did a community data which reflected that the incidence has been increasing annually. They did a 20-year analysis, and they noted that the incidence has been increasing by 2% every year. And in terms of 30-day mortality, we find that we have quite a high percentage of mortalities. So I think for the data, we'll be able to review that. For the etiology, these are things that the morning speakers have been mentioning about the obesity. We have, those are the traditional ones. And then we have this spontaneous coronary artery dissection. And then we have these other trends which are coming up for the substance abuse, even among the very young people, including adolescents. So we have to be keen on that. So for this case is a case of a 32-year-old male, a patient who is a boda rider. He didn't have the typical traditional cardiovascular risk factors. So for him, he was just going around his business, and then suddenly he had this retrosternal chest pain, which was radiating to the axilla, and he had diaphoresis, and all other factors were okay. So this patient came as a referral from another facility within the time period for acute care. So for this next table, is just illustrating the risk factors, which he didn't have any of those, apart from the psychological aspect, whereby he was dealing with some major family issues. So for the ECG, this is the second one after we did thrombolysis. So the one attached there is after thrombolysis. The echocardiogram already was showing us the features of acute myocardial infarction, and also the reduced EF of 44%. And then for the troponins were quite elevated, and over time, we did a repeat because we usually do the zero ECGs, the zero troponins, and we can see that it jumped up to 50,000. So for this patient, we did some interventions, and part of it is to do we did the medication therapy and the pharmacoinvasive therapy, and after which we did a coronary angiogram, which showed that we end LAD. So this is a video, but I don't know whether it's able to play, but if you can appreciate in the first dark thing you can see there, that is where we have the stenosis in the LAD. And then after that, there's another video just to show us what we do in the cath lab, the PCI. So we'll end to dilate that area so that this patient can have some improvement. All right, so this is for the percutaneous coronary intervention. So in terms of the symptom onset, the patient got the symptoms and was able to present to the facility within a stipulated time for an urgent intervention, and that's why he got to be assisted. So then in terms of the ECG, we've mentioned that here in the ST changes in the anterior leads, that is the V2 to V5, and then the biomarkers, we were able to do them on time. The other thing is we were able to intervene to give the thrombolysis. I think one of our colleagues did an extensive program online, which we were able to reach out to many people about acute MI care. And then we did the coronary angiogram within the 48 hours, and you were able to improve the quality of life for this patient. So for this they are not the typical patient we see every day, because we know for myocardial infarction is more to the older population. So we thought it's good to highlight, because there are current trends which are coming up. As you've seen, substance abuse, we have cocaine, we have smoking, we have vaping. So these are risk factors which are not, we are not able to screen through the normal metabolic screen. All right, so this is just a part of pathophysiology of how the psychosocial stressors can also lead to acute myocardial infarction, but I won't belabor this because we are able to read this online and you can check it out. Also, this is the literature. We have some from Kenya, but we don't have a structured data in terms of keeping these registries for this patient with premature myocardial infarction, and this is a call to us, even as a center and even as a healthcare system, to have such program in place. So in terms of the long-term management, I think you can appreciate the acute care there. We do the dual antiplatelet, we give the loading dose, and then we have to continue with the other care. The other bit is for the in-hospital, the interventions. We are currently in Kenya, I think not many centers are able to do the primary PCI, but we are getting there. And with the more resources allocation to the health sector, we will be able to achieve that. So for the secondary prevention, it is important to highlight that for this patient, you don't just leave them at admission. We have to follow them up for a quite long period of time as we try to investigate what are the causes, because still for this case, we are not able to do a comprehensive panel to screen for thrombophilias, to screen for family-related genetic conditions which can lead to myocardial infarction in such a young man. So in terms of our discussion, it is important that we mention that premature myocardial infarction can occur to anyone. So it is good to be empowered and know, if I get such a patient, where do I refer them? What centers are around me? I think in medicine, like usually in trauma, they say, get the right hospital, get the right, so that the person can get the right treatment. So the same applies even to acute myocardial infarction, because it's a life-threatening condition. And then we have to be vigilant to screen for unconventional risk factors. The other bit is in terms of cardiac follow-up and also the rehabilitation, cardiac rehabilitation. I think we still don't have very good structure and program, but we are trying to improve on that. So in conclusion, if you find a young man who is presenting with symptoms, don't delay the care. Make sure that they get the appropriate treatment and they get screened in time. Don't ignore that and say that this person is not overweight, they are not hypertensive, they are not diabetic, and let them just go like that. So I think in Kenya we also need to be more systematic to screen for these things and be vigilant to get them in time. So thank you. Sorry, it was a rushed.
Thank you so much. Thank you so much, Dr. Penina. She's our amazing ExaCop student. ExaCop is the IMED of the COSEXA. So here in KU, we are running an ExaCop program. And what is most important here, like she's saying, time and going to the right place. So in KU, we are among the few public institutions in Kenya we are having a cath lab. So if you go to other world-class hospitals, we are going to be costing you millions. Here, we just do it with thousands using SHA. So please don't let your heart patients die at home. Bring them to KU Referral Hospital. Next, I'm going to move to the next speaker. He's a young man, who is very close to my heart. Dr. Abdullaim, he has been doing a lot of amazing research. I know, Grace, don't worry. So he has been doing a lot of amazing research. He's also an entrepreneur doing a lot of AI work. So I would like to invite Dr. Abdullaim Hussein to present on the current trends in burden management of pediatric osteomyelitis in the African continent, a systematic review of the last decade. Welcome. Abdul, ungekuwa umefika kitambo. Makofi kwake akija kwa stage.
Hello.
So some technical challenges. He had uploaded the slides, but I think the other end, they are not ready. So I will move to the next speaker, Dr. Grace Wanjiku Mwangi. So Dr. Grace Wanjiku, she's going to give us updates on management. Sorry, on the management of HIV. Karibu daktari.
Thank you for the kind introduction. My name is Grace Mwangi. I am a medical resident under the ExaCop program. Today, I am here in the capacity of NASCOP TOT here at KUTRRH, and I'm going to take you through the guidelines. The 2026 HIV guidelines, which are grounded on, as I wait for my slides to come up, person-centered care, integration of care, as well as evidence-based medicine. The scope of my discussion is going to start first by the new HIV testing algorithm. Then we're going to look at the changes in the regimen. Then we're going to discuss the PrEP options that we have. And we are also going to look at the change of STI management from the syndromic approach to the etiological diagnosis. HIV testing algorithm has previously been a two-step algorithm, but now we are moving to 3 steps. So we have 3 immunological assays, which do contain 3 different antigens, HIV antigens, and they are meant to test the HIV antibodies in the HIV, in the person we are testing. So the 3-step algorithm, the first step is a very sensitive and also specific test, and it is the screening test, which if it is negative, we confirm that person as negative. Then we move on to a possibility of a HIV positive patient. If the first assay turns reactive, then we move to the second assay, which if reactive, we move to the third assay, which if reactive, then we confirm this individual as HIV positive, and a second tester comes and runs the 3 assays again to get a clear diagnosis of a HIV positive result. So DNA PCR is the first line for children, mainly because, and infants, mainly because there's a likelihood that they may have maternal antibodies, and it is no longer recommended in inconclusive results for adults, mainly because you could actually have false negatives in a patient or an individual who has viral suppression. Moving on to now the ART recommended combination, I'm going to focus on the pediatric regimen, which has now changed. It is going to be a fixed dose combination of abacavir, lamivudine, and DTG in one dispersible tablet, and this will enable accurate treatment of the children. Then the other change that has come up is the regimen that we're giving to the older population. For adults who are more than 60 years of age and also those with comorbidities, the initial regimen is going to be the TAF regimen. So it's TAF, telafenamide, 3TC, and DTG. Before we move from that slide, we are also moving away from the terms like first line, second line, and third line. Now we are going to have the initial, subsequent, and constructive regimen. The initial and subsequent are fixed doses, and the initial to the subsequent could actually just because of drug reactions or comorbidities. The constructive regimen is going to be formulated by the Regional Technical Working Group following drug resistance testing. We can move to the next slide. In advanced HIV disease, the message remains of family screening early and identifying the OIs, opportunistic infections. And what has changed in these years' guidelines is a change of terms from serum Kutrrh to blood Kutrrh. And this is going to enable the lab to do a reflex testing on the CD4 count sample so that they can also run the Kutrrh. Once Kutrrh positive, what is also changing in this guideline is that all the patients who turn blood Kutrrh positive have to undergo an LP for a CSF Kutrrh. Previously, if you turned blood Kutrrh positive, and you do not have symptoms, we never used to proceed and do an LP. But now, for everyone who turns blood Kutrrh positive, we have to do the CSF Kutrrh as well. We're going to move to the next slide. Yes, so in terms of prevention, we have the PrEP, and under PrEP, we have several options. We have the oral options as well as the dapivirine ring, which is to be inserted in the cervix, can either be assisted or self-inserted. And then we have the exciting new kids in the block, the injectables. So we have the cabotegravir, which is long-acting and is going to be injected every 2 months. Then we have lenacapavir. This one you just get the injection 6 monthly. So these medication confer protection and are going to aid in preventing HIV acquisition, especially in individuals who are at ongoing risk of acquiring HIV. The column on the left is highlighting the eligibility criteria. Just to mention one, you have to be confirmed HIV negative. And during the subsequent dosing, we have to confirm that you're still HIV negative. So the tests have to be done, case in point for lenacapavir, every 6 monthly before you get your subsequent dose. Let's move to the next slide. Yeah, so this is an important slide because we're talking about prevention of mother-to-child transmission. Now, a term that we are doing away with, we are going to talk about prevention of vertical transmission to avoid stigma. Here, we are going to, the mother's risk will determine the infant prophylaxis.
So how do we risk stratify the mother? We have the high risk and the low risk mother. The high risk mother is all ART naive, and also young ladies at the age of less than 19 years. For such, then that infant is going to be classified as high risk, and we're going to start them on basically ART regimen for infants, which is abacavir, 3TC, and DTG for 14 weeks. Then we continue with nevirapine up to 6 weeks after cessation of breastfeeding. Then for the infants who we classify to be low risk are of the mothers who have actually been on ART and are virally suppressed. So their viral copies are less than 50. And in such a case, we're just going to put them on azathioprine and nevirapine, and then continue with nevirapine up to 6 weeks after cessation of breastfeeding. We can move to the next slide. Yeah, so the other major highlight of these guidelines is STI management. So we are doing away with syndromic management, and now we are going to do etiological management. Syndromic management was actually easy to use because, case in point, you'll actually just find a patient who has symptoms that are likely to be urethritis or vaginitis, and you lump them up with empirical antibiotics. But you might actually be missing the diagnosis because probably it's just a parasitic infection or even a fungal. So because of that, we are moving away from that, and we are now focusing on etiology. So you have to get the history from a patient, identify that they are at risk of a possible STI, examine the genitalia, as well as the anus and the oral, collect samples, submit the samples for nucleic acid amplification tests, microscopy, culture, and sensitivity. Then once the lab has identified the organism, treat the particular organism. However, this should not delay management, especially in a setting where they do not have the facilities, the lab facilities that can support these. So you could still initiate medication. And in such facilities, they are encouraged to use point of care rapid diagnostics tests that are available there. Finally, this was just a glimpse of the highlight. There's a lot, and however, the guidelines are available in the Ministry of Health portal, and our key takeaway home message are first, integration. Integrate HIV care at our point of care services everywhere, from inpatient, outpatient, maternal and child care, family planning clinic, TB clinic, surgical clinics, everywhere. And then risk stratification changes treatment, as we have seen in the PrEP eligibility and HIV-exposed infant prophylaxis. Then precision protects patients and programs as of the etiological care of STI management. Thank you very much. I believe we are now equipped to integrate HIV care in our management.
Thank you very much. Actually, I learned a lot myself because like up to 80% of my cervical cancer patients, they are HIV positive. And one of the things we usually look in our treatment, like we look at the patient is on which line, first line, second line, what is the viral load, what's the CD4 count. At least today I got to learn a lot from you. Thank you so much, Dr. Grace. Next speaker, Abdul. Yeah, so as we mentioned earlier on, he's going to talk about current trends in burden and management of pediatric osteomyelitis in the African continent, a systematic review of the last decade.
Okay, hello. My name is Abdunaim Mohammed, as he has introduced. I'm a third year medical student at Kenyatta University. So I'm going to present my study titled Current Trends in Burden and Management of Pediatric Osteomyelitis in the African Continent, a systematic review of the last decade. So pediatric osteomyelitis, it's just an infection of the bone, and it's a major cause of musculoskeletal morbidity, especially in LMICs. The incidence is, compared to high-income countries, it's very high in low-income countries, substantially higher in low-income countries compared to high-income. If not treated, can lead to severe complications like limb deformities, growth plate damage, pathological fractures, and the epidemiological data remains limited and fragmented in African due to limited research being done. Next slide, please. So this is just the pathology, how it spreads through direct inoculation, contiguous infection like foot ulcers, hematogenous spread. Next slide, please. Globally, it's estimated 12 million children are affected by this disease. And so you can see the difference in high-income countries, 8 out of 100,000 children, and in low-income, 43 out of 100,000. That's like more than 5 times higher. And you can see the age predominant is around 11 to 20 years. Yes, and this explains the big difference is because of the diagnostic and the delayed healthcare access, nutrition, and the late presentation. Next slide, please. So the significance, why this study was important, there is limited data in the African setting on the true burden, and even the existing studies are usually single-centered, retrospective. So, and there was no synthesis of pediatric osteomyelitis in the entire African continent. So these are our study objectives. We aimed to synthesize the evidence on the burden and the management of pediatric osteomyelitis in Africa, and we also evaluated clinical presentation, microbiology, treatment strategies, and outcome, and also highlighted some of the emerging innovations and the knowledge gap. So it was a systematic reviews. We used the PRISMA 2020 guidelines. We included 9 studies, and the study period was between 2014 to 2025. These are PRISMA flowchart. Next slide. Next. So these are some of the key highlights, insight from the included studies. Chronic osteomyelitis predominates in the African pediatric population, and the rural and the malnourished children show high rates of chronic disease, and Staph aureus was the leading pathogen. Next slide, please. So these were some of the included studies. As you can see, it's fragmented from various few countries. Kenya was not one of them. Next slide. These are some of the papers we included. Next slide, please. Next slide. So these are some of our findings. Types of osteomyelitis. As you can see, most of them were chronic. It was the majority of them. And this also explains the delayed diagnosis. That's accounted for around 84%. Chronic osteomyelitis is really stubborn. Once it settles, it's really hard to eradicate. It's like it's like that relative who comes to visit but never wants to leave. Next slide. So these are some of the etiological agents. So the highest you can see is Staph aureus, accounting for 44%, and the rest follow. Next slide. This is just repetition. Next slide. Yeah, so anatomical distribution of the infection, tibia was the most affected, for around accounting for 45.7%, and then followed by femur. Next slide. So these are the management and the outcomes. So most of them were managed surgically, and others were combined with antibiotic medications, accounting for and the outcomes. Most of them recovered. Some were lost to follow-ups, and 5% got the complications. Next slide. Next slide. Okay, so these are some of the novel insights, highlights. We got from Uganda. It was first reported to use the vascular fibular flap graft for post-osteomyelitis defect. And then also in Somalia, they used gentamicin-loaded cement pellets for local infection control. And the rest. Next slide. So this is the case report from Somalia. It's a 9-year-old male with chronic osteomyelitis of the right radius shaft with a history of distal radioulnar trauma. So they used antibiotic-impregnated pellets to control the infection. Next slide. So this is the pellets. As you can see, the antibiotic is mixed with the polymer and directly placed at the site. It's better than the IV because it gives a very high concentration of the antibiotic. And there you can see the fibular graft. It's just the bone with its blood supply, the peroneal artery and the vein, and it's used for the graft. Next slide. These are some of our limitations because most of the studies were retrospective and single-centered, and there was a lot of heterogeneity, and the report on follow-up was inconsistent. Next slide. So in conclusion, just want to conclude from our paper, pediatric osteomyelitis still remains a significant but under-recognized cause of morbidity in Africa. Chronic disease dominates due to delayed presentation and health system limitation, and strengthening microbiological capacity and standardized treatment pathways is essential for. Thank you.
Thank you very much, Dr. Abdullah. I should call him a doctor, yeah. He's a Dr. Abdullaim. So mashallah, he's very young, but doing big things. You know, doing a systematic review, even consultants are shying it away from it. So that's a big job. Thank you so much. Congratulations. Makofi kwake. So we are moving now to the D University of Nairobi. Yeah. So Dr. Kutrrh Nyangweso, she's going to present to us the maternal mortality trends, causes, and underlying delay models at Kakamega County General Hospital from January 2016 to December 2023. So this is very important because we are in the era of every woman, every woman. Hiyo nitaachia Dr. Githinji kwa session yake. Karibu daktari, welcome. Okay. So welcome daktari. Let us see the data from Kakamega. Please focus on the data.
Good afternoon, everyone. Thank you very much for the kind introduction and for the opportunity. As introduced, I'm Sister Dr. Kutrrh Nyangweso from the University of Nairobi, Year 4, in the Department of Obstetrics and Gynecology. I did a study on maternal mortality trends, causes and underlying delay models at Kakamega County General Hospital from January 2016 to December 2023. My supervisors were Dr. Diana Ondieki, Professor Alfred Osoti, and Dr. Geoffrey Matete. Okay. So I'll skip the definitions, but it's good to note that we defined maternal mortality itself according to WHO, maternal mortality ratio, direct causes, indirect and underlying delays. Onto the background, maternal mortality remains a significant public health challenge with sub-Saharan Africa bearing disproportionate burden of about more than 2/3 of worldwide deaths. And then Kenya, we have the Big Bet initiative that was initiated by the AMREF, and also basing on the efforts to achieve the Sustainable Development Goals, SDG 3.1, which has remained high in tertiary facilities. And then there is a recent study in 2025, a meta-analysis on subnational health data that noted that while some regions maintain lower institutional ratios, high-volume referral facilities still bear an overwhelming burden. And we know that the overall maternal mortality ratio has been 355 deaths per 100,000 live births, according to MOH. We know that KDHS has been giving us 362. Our objectives were to describe the maternal mortality trends, causes, and underlying delay models. Specific objectives were to describe the trends, direct and indirect causes, and also to evaluate the underlying delays. So the study, as I mentioned earlier, was done at Kakamega County General Hospital. It was a descriptive cross-sectional study. The target population was records of all women who died receiving care, both antenatally, intrapartum, and postpartum, until 6 weeks. So we included all those records of women who died during the study period. The strength was that it was an 8-year study, so it was able to capture all the maternal mortalities of that period. And we used complete enumeration, meaning that we did not exclude any maternal death, and it minimized bias. The limitation is that some deaths might have occurred in a community or private facilities that we were not able to capture. That was our flowchart. On to the socio-democratic characteristics. Most of the deaths were between 16 and 46 years. Most of them, 75% were married, 43% were of secondary education, and about 66% were unemployed. Those were our results. You can see on the trends, we have a peak in 2020, and then we have two troughs in 2017 and in 2023. The second objective, as we were trying to answer it on the trends of direct causes, we realized that 3 leading direct causes, and that was hemorrhage, puerperal sepsis, and preeclampsia and eclampsia. For the indirect causes, we had malaria, anemia, and COVID-19. Not that COVID-19 virus per se, but of course the situation that was surrounding, like lockdowns, which prevented most of the mothers with complications to go to the hospital. Answering objective 3, distribution of the 3 delays, we noted that the third delay, which is delay already when the mother is in the facility, accounted for 71.8%, followed by the first delay, 62.7%, and then the second delay. And then we realized that there were also composite delays. When we combined, like some mothers could have both first and second delay, first and third, and so on. In conclusion, the overall maternal mortality rate was 455, peak in 2020, and troughs in 2017. The direct causes contributed to about 83.6%. That was, the leading was the hemorrhage at 35.02, followed by preeclampsia, eclampsia at 19.8. The indirect causes, we noted that malaria and anemia were the leading causes, and then the third delay predominated. For the recommendations, we thought that we could have concerted effort to reduce the high maternal mortality rate, to address leading causes of maternal mortality, to strengthen emergency obstetric care and timely provision of life-saving obstetric interventions, and then to address especially the third delay when the mother is already in the hospital, early referral, escalation to the next level, especially the consultants to be involved quite early, and then to improve staff competence through trainings and available availability of the essential drugs. Then we also can collaborate with centers that have done better. Thank you.
Thank you very much. This was amazing. Makofi kwake. Have a seat. Two things which caught my eyes and my attention. Number one, consultants. Mulisikia mkiitwa? Consultants, umejisikia? I think we can do better. But I was very happy seeing the trends is coming down. It was really coming down. That was very happy. But one thing caught my attention. Being an oncologist, I only see oncology. Out of those deaths, 6.9% were malignancy related. So you only see what your brain knows. So for me, my eyes are just focusing, looking for oncology, and happy it was mentioned. And this is we are going to talk about it in the next session, which we are going to start in a few. I would like to invite all the speakers on the stage who just presented. Please welcome on stage. We'll just take a question from each if there are any. If not, we move to the next session. As they are coming to the stage, maybe whoever has a burning question based on the previous speakers, please raise your hands. If not, we'll be happy to close this session. Okay, there's a hand behind there. Sorry.
Good afternoon. My name is Odna from Taveta. So my question, I have two questions, one for each for, I don't remember the name. There's one who did the presentation on HIV, and then there's the other one for Kakamega. On HIV AIDS, I think we need to look at the issue of integration, because from our hospital perspective, we only concentrate on clinical officers, nurses, and by extension HTS counselors. But when it comes to the medical officers, they are purely left out on these special programs, HIV, TB. So like now, we are being told to do integration, but our medical officers, consultants, I think there's a very big gap in terms of support. So that because even in clinics, we'll get some of them referring to the HIV AIDS coordinator when during clinic. So maybe we need to do a better integration process with our senior colleagues in their facilities. So maybe it's a recommendation. For the lady from Kakamega, for the doctor in Kakamega, I have seen the data, but maybe is there any correlation in the location? Because I can, from our perspective, you can get a certain area. Maybe let's say like Ruiru is experiencing a certain degree of number of deaths, maternal deaths. In a traditional setup, maybe they are TBAs or retired nurses or something. So maybe in your presentation, I didn't see if there is any specific location or for the 8 years, it cuts across the whole of Kakamega. Maybe it's something that you can tell us.
I will respond. Thank you very much for the question. According to the numbers that we found, I'll talk about the indirect causes of maternal mortality. Yes, there is a relationship between the location and what we found, especially in terms of malaria. We know that western part of Kenya is a malaria endemic area. And also another thing that happened is that it is in our discussion, I didn't have enough time. Another thing is that there is a period when we lacked the prophylaxis. It's called Fansida. We lacked it for some time, so which means that the mothers lacked the prophylactic for malaria for some time. Thank you.
Thank you to all of you for your presentations. Sorry, I missed your presentation. I was busy chatting with some of the individuals out there. And what I wanted to discuss with Grace is, rather than a question, it's more of a point of information. There was the joint program where they had the release in terms of integrated care and why by 2030 we are hoping that Specifically, AIDS-related mortality is reduced by 50%. And there were certain discussions which I was privy to, at least within the Syndemic Council, to improve the standard of care of treatment for many of our patients, especially for us who are a level 6 facility, that there are bare minimum standards that need to be there. That interesting point about the medical officers and feeling sort of left out, I think the main issue tends to be that CCC for a long time had been siloed because of issues of stigma, together with the other issues that arise in terms of making sure that their care is not disrupted. So I think the whole goal of integration also stems from the point of view of dealing also with stigma. I think that in itself has made some of the care to sort of be pigeonholed in one way or another. So I believe that is something that will be sorted out as we move forward. But there's something I needed to talk about, especially when it comes to PrEP. The uptake of PrEP has been very interesting because it seemed to have plateaued around 2022, where the uptake is about 39% of individuals, especially those who are key populations or most at-risk populations. And the question is, why is it that the uptake has not sort of increased? Because there's a period it was on the increase, and it seems now to have tailed off. So I think that's one thing. And another very important thing to remember is that 62% of the new infections that we've had in our country as of last year were aged between 15 and 39 years. That gives us a lot to pause about. So I don't know if you had mentioned about hepatitis B management in this, but it's also something that's very important when it comes to managing these patients. Hepatitis B and hepatitis C, apart from the usual STIs. So thank you for those presentations.
Okay, thank you so much. Allow me to close this session. The speakers are available during the break time because we have to consider the interest of time. I would like to ask our cameraman, we have a group photo for the speakers. Please align here, or you could stand just where you are for the group photo for the presenters. As they are taking the group photo, I would like to invite my the next chairs and the next session, which is going to be maternal and child health, which will be chaired by Dr. Githinji and Dr. Abdallah Bajaber. So welcome here, Dr. Abdallah Bajaber, Dr. Githinji. But I have a question. Why are all pediatrics either small or short? Maybe they should tell us when they're here. Welcome, Dr. Githinji. Dr. Abdallah, please, the stage is yours. And without any bias, you'll confirm my question once they come here. So Dr. Abdallah is like Salim Abdallah Bajaber, but I'm used to Dr. Abdallah, so don't be surprised when you see Dr. Salim. It is the same person. And he's the cousin to the famous Bajaber we see in the Kenya Harambee Stars. So mkitaka jazz kusainiwa mnamuona yeye tu hapo kando.
Thank you so much, Dr. Abed. Good afternoon, everyone. It's afternoon already, right? So thank you so very much. As introduced, my name is Dr. Githinji Janet. I'm a consultant gynecologist here in KUTRH, as well as HOD OBGYN. I'll probably want to just do a small thing to make sure that you guys don't sleep, because I know it's about lunchtime. If you know you're a woman, please stand up. If you know you're a woman. Or if you identify as a woman, please stand up. Raise your hands. Wave them in the air like you just don't care. Great. Sit down. If you're a man, please stand up. If you identify as a man, please stand up. If you're a man, jipige kifua hivi. Aya, take a seat. So this session involves every man, every woman, and every child, everywhere. I've actually taken a wene and just expanded it, because if it wasn't for a woman and a man, there would be no child. Okay? So thank you so much. You represent the society. So I'm happy to be speaking to a sample size of our community today. Not just at a conference level, but I want you to take this and be ambassadors of the kind of session that we're going to have today. All right? So, without further ado, we're going to start with Dr. Ifraj Abdullahi Sharif. Are you here? Please come to the stage. And you're going to present an abstract on prevalence and severity of anemia at delivery and its association with primary postpartum hemorrhage among pregnant women at Wajir County Referral Hospital. Thank you so very much, Dr. Ifraj. Karibu sana. Mpigeni makofi tafadhali.
Good afternoon. Good afternoon. My name is Dr. Ifraj Abdullahi Sharif. I'm a year 4 resident, University of Nairobi, in the Department of Obstetric and Gynecology. Okay. So today I will be taking you over a dissertation that we did on prevalence and severity of anemia at delivery and its association with primary postpartum hemorrhage among pregnant women at Wajir County Referral Hospital. I'm the principal investigator, and my co-investigators and supervisors are Professor Zahida Qureshi and Dr. George Gwako. So in the background, anemia is the most prevalent nutritional problem among women of reproductive age globally. WHO defines anemia as a HB of less than 11 grams per deciliter. According to the developmental indicators collected by the World Bank, 40.3% of pregnant women in Kenya were anemic. And as Dr. Mukoya has just discussed, PPH remains a leading cause of maternal mortality, especially in our low and middle income countries, despite increased facility deliveries and use of uterotonics. Evidence on the association between anemia and PPH is limited, particularly in rural and undeserved settings such as Wajir County. Therefore, this study was done to assess the association between maternal anemia and postpartum hemorrhage among women delivering at Wajir County Referral Hospital to generate locally relevant evidence for improving clinical management and prevention strategies. So our objective was mainly to determine the prevalence and severity of anemia at delivery and how it's associated with primary postpartum hemorrhage. So the specifics were to determine the prevalence of anemia and severity of anemia at delivery, and then after that, evaluate for the association between maternal anemia and postpartum hemorrhage. So the study's design was a cohort study with a nested case control design. The participants were classified at recruitment as anemic, who are the exposed, and then an anemic and exposed based on hemoglobin levels. They were then followed until delivery, with women who developed PPH enrolled as cases and those without PPH as controls. The study setting was at Wajir County Referral Hospital, antenatal postnatal ward, population being the pregnant women who delivered at Wajir County Referral Hospital. The women who we included in the study were women who had singleton pregnancies more than 28 weeks and delivered vaginally, and those who had independent risk factors such as documented postpartum hemorrhage. We were excluding them from the study and include also those who had coagulation disorders. So the outcome was postpartum hemorrhage, which we defined as blood loss of more than 500 mils per vagina within 24 hours of delivery, and the exposure variable was anemia in pregnancy, which was defined as HB of less than 11 grams per deciliter. And then in the specific objective, we talked about severity. So whereby we were still classifying the anemia into 3 different groups: the mild, who were between 10 to 10.9, moderate 7 to 9.9, and severe anemia less than 7 grams per deciliter. And then still checking how is it associated with occurrence of primary postpartum hemorrhage. So for the data collection procedure, after, of course, getting the ethics approval from UN and KNH and ACOSTI and also the Wajir County Referral Hospital, we enrolled the patients, took the informed consent, HB was measured at entrance after taking demographic characteristics, of course, and the clinical characteristics. After that, we followed the patient until delivery, whereby we quantified the blood loss using an objective drips, which were placed under the mother's buttocks, so that immediately after placental delivery, we were measuring exact amount of blood loss after delivery. So for the data analysis, we did descriptive statistics, and then when we were assessing for association, we used binary logistic regression. And then results were reported as odds ratio, and the statistical significance was set as a p-value of less than 0.05. So, sorry about that. So this was the result flow chart. So in the demographic characteristics of the study participant, especially in the case control arm, we noted that between the two groups, the PPH and the no PPH groups, statistical significant differences were seen in age, in marital status, which was at 0.017, and also just mainly those two in the demographic characteristic, age and marital status. But for the clinical characteristics, we noted that there was statistical significant differences between the PPH and the no PPH patients in parity, which was at p-value of less than 0.001, and number of ANC visits and iron supplementation. Of note, the thing that you need to see from this slide is that and half of the patients had less than ANC visit of less than 4 visits, and also the routine iron supplementation throughout the pregnancy, almost like 40% of the mothers were actually going to got the iron supplementation throughout pregnancy, while 60% didn't get even the iron supplementation. So for the first objective, which was prevalence of anemia delivered among pregnant women, the prevalence, we noted that anemia was present in 83.8%. Approximately 84% of mothers were anemic at delivery, having a HB level of less than 11 grams per deciliter, while 16% had at least above 11 grams per deciliter. For the second objective, whereby we were categorizing that anemia into groups, we noted that majority had moderate anemia, a HB of between 7 to 9.9 grams per deciliter, and that majority was at 58.6%. Mild, 20.5% had mild anemia, while 4.7% had severe anemia, HB of less than 7 grams per deciliter. So for the third objective, which was to assess the association between anemia at delivery and the primary postpartum hemorrhage, we noted that the patients who had anemia were 3 times more likely to have to develop primary postpartum hemorrhage. Okay, 3 times higher odds of developing primary postpartum hemorrhage as compared to those without anemia, and that is after adjusting for confounding variables such as age parity and ANC visit. For the ANC clinic visit, that is for the fourth objective, which we were assessing for the association of severity of anemia at delivery and primary postpartum hemorrhage. What was noted is that patients who had moderate anemia, HB of between 7 to 9.9, were 3 times more likely to get primary postpartum hemorrhage as compared to those without anemia, and those who had severe anemia of less than HB of less than 7 were 6 times more likely to develop primary postpartum hemorrhage, and that is still after adjusting for confounders like age, parity, and ANC. So in my study, the study strength included that it was a prospective study, and with a nested case control design. This it was good in that it was enabling us to assess temporal assessment, and it was also helping us to reduce recall bias, and also the use of the calibrated drips were helping us to have objective blood measurement quantification, and it was not just like machometer. We were not using machometer. So for the study limitation, it was a single center, so this will reduce generalizability, and also the PP, when we were measuring the PPH, we were using these drips only for like 2 hours. You can't keep a mother on the bed more than 2 hours. So after 2 hours, whatever that we were losing, that might have underestimated the number of PPH cases that we got. So for the conclusion, anemia at delivery was highly prevalent at 83.8, with moderate anemia being the most common. Maternal anemia was significantly associated with primary postpartum hemorrhage. Moderate and severe anemia significantly increasing the risk of PPH. For the recommendation, we recommend that we strengthen the 3rd trimester anemia screening, which we strengthen it as part of routine antenatal care. Mostly in our places, we just do booking HB testing, but we will have referred if we can still do a 3rd trimester so that we can we can identify early and manage before labor onset. And also we can improve early detection of PPH through objective blood loss measurement using calibrated drips. And also we can enhance iron supplementation, nutrition support, and antenatal education to improve adherence to iron therapy. And thank you.
Thank you very much, Dr. Ifraj, for that. Surprising and astonishing data. 83% of women with anemia, toddy. Yeah, blood, what were blood and blood products. But we'll discuss in details hopefully in my presentation and Toddy's presentation. Next, I'll call another baby of Professor Zahida Qureshi, Dr. Barke Mohammed, who is a UON resident in Obsgain, who will talk to us about prevalence of teenage deliveries and associated adverse outcomes compared to adults among women who delivered at Moyale Sub-County Hospital, Marsabit County. Karibu Daktari. You have 7 minutes, is it? Thank you.
Good afternoon, everyone. Good afternoon. My name is Barke Mohammed, a year 4 Obs and Gynae resident in the University of Nairobi. This was my dissertation. The topic was prevalence of teenage deliveries and associated adverse outcomes compared to adults among women who delivered at Moyale Sub-County Hospital, Marsabit County. I was the principal investigator, and my supervisors were Dr. Diana Ondieki and Dr. Rosa Chemwe. So our background, worldwide, about 1 in every six people is a teenager, that is 13 to 19 years, and almost a tenth of all births globally were to teenagers, more than 90% of them occurring in low and middle income countries. Teenage pregnancy is associated with a myriad of challenges, including increased risk of maternal and neonatal morbidity and mortality. According to the KDHS of 2022, 15% of the women aged 15 to 19 have ever been pregnant, 12% have had a live birth, 1% have had a pregnancy loss, and 3% are currently pregnant. So our broad objective was to determine the prevalence of teenage deliveries and associated adverse outcomes compared to adults. The specific objective was to determine the prevalence of teenage deliveries, to determine the adverse maternal outcomes in teenagers compared to the adults, to determine the adverse neonatal outcomes amongst the teenagers and adults, and the fourth one was to compare the psychosocial effects of pregnancy among teenagers and adult women who delivered at Moyale Sub-County Hospital. Our methodology, it was a mixed method design where we had a quantitative and a qualitative arm. The quantitative arm comprised of, we utilized the comparative cross-sectional design where we compared the adverse maternal and neonatal adverse outcomes. The qualitative arm, we had focus group discussions and case narratives which were conducted between the adults and the teenagers. The study setting was Moyale Sub-County Hospital in the postnatal wards that was conducted in January 13th to April 30th of 2025. The inclusion criteria were women aged 13 years who delivered at Moyale Sub-County Hospital, postpartum women who had consented to be part of the study, teenage mothers or caregivers who had given consent, and deliveries after 28-week gestation. We delivered any woman with comorbidities. So the data collection procedure commenced after permission from UNERC, Nakosti, and Marsabit County with Moyale Sub-County Hospital as well. So eligible women were enrolled into the study after informed consent. Qualitative, for the quantitative part, interview field questionnaire was conducted from the information was conducted from the mother's files, obtaining the maternal and neonatal outcomes, and then we gave a 10-minute questionnaire that was comprising of the Oslo Social Support Scale and the Edinburgh Postnatal Depression Scale. And then for the qualitative data, we conducted focus group discussions and case narratives. Descriptive analysis was summarized. Descriptive analysis was used to summarize the patient's characteristics and the prevalence of teenage deliveries. Maternal and neonatal outcomes were analyzed using binary logistic regression and was reported as p-value and odds ratio. Psychosocial effect was audio taped, transcribed thematically, and reported as narratives and using themes and sub-themes. This was our results flowchart. During the study period, we had 422 deliveries. Of 422, we had 80 who were teenagers and 342 who were adults. Amongst the
80 teenagers, we screened 76. 4 of them declined to give consent, so we recruited 72 into our study. Amongst the 342 adults, total screened were 146. 2 declined to give consent, so we recruited 144 into our study. On to our results. This was the demographic characteristics. Of note is the mean age of teenagers was 18.1, with marital status of the teenagers. 97% of the teenagers were married, while 97% of the adults were also married. Of note is the employment status. 90% of the teenagers were unemployed. So for our objective 1, the prevalence of teenage deliveries, during the study period, we had a total of 422 deliveries, and 80 of which were teenage deliveries, giving us a prevalence of 19%. The objective 2 was to determine the adverse. Objective 2 was to determine the adverse maternal outcomes associated with teenage deliveries compared to adults, and we didn't find any statistical difference between the teenagers and the adults in terms of the composite maternal outcomes, the mode of delivery, APH, PPH, or the sepsis. On the objective 3, comparing the adverse neonatal outcomes between the two groups, we found that there was statistical difference between the teenagers, who were 2 times more likely to have composite adverse perinatal outcomes. Teenagers were also 8 times more likely to have a low APGAR score at 5 minutes. They were 5 times more likely to have a preterm birth, and 32 times more likely to have their babies admitted to NBU. Objective 4 was to look at the psychosocial effect of pregnancy, comparing the adults and the teenagers. So we used the Oslo social support, looking at the family and the social support, and for the depression we used the Edinburgh postnatal. So after adjusting for parity, we found that the teenagers were 7 times more likely to have poor support, and 5 times more likely to have presence of depressive symptoms. So we conducted focus group discussions, and after that, the ones who were coming out more and expressing the symptoms more, we took them aside and conducted case narratives. So amongst this, we developed themes, which were psychological challenges, social challenges, and support and improvements. And we also went further and subdivided them into sub-themes. So under the psychological challenges, we looked at shock and anxiety. And I quote, one of the teenagers said, "It felt like my whole world was upside down. I felt like my childhood was over. And I was worried about everything, how my friends would react and what my future would look like." On the depressed mood, one of the teenagers said, and I quote, "Yes, I had moments where I felt like everything was too much and I didn't know how to handle it. I was really sad and felt alone." On the social challenges, we looked at negative attitudes from healthcare providers. One of the teenagers said, and I quote, "Some of the healthcare providers seemed to treat me like I wasn't capable because I was young. I felt like I was being judged during each of my clinical visits. I remember once I overheard them asking each other about why I got married and pregnant at such a young age." On the financial constraint, one of them said, "Yes, finances were tough. We had to rely on the family support because my husband's income alone wasn't enough." So our strength was, it was a mixed method design where we had both the qualitative and the quantitative arm. So it captured more than the clinical outcomes, but also the lived experiences of the teenage mothers. The limitation was that due to the nitty-gritties of the topic and the stigma that was associated, some of the participants may have underreported the depressive symptoms or lack of support during the focus group discussions. Our recommendation is engagement of religious and community leaders to shift the social norms that perpetuate early marriages and teenage pregnancies by encouraging the need for education, and integrate routine screening for postnatal depression, like the Edinburgh postnatal depression scale, during the postnatal visits for the teenage mothers.
Thanks, Dr. Barke. Are you depressed? You should be depressed following such things. Aya, how many of you are parents? Raise your hand. How many of you have a teenager in the house? How many of you have discussed comprehensive sexual education with your teenager? Are you seeing how the hands have gone down? Yet you've been told here 1 in 6. According to her data, it tells you 1 in 5. And there's even 1 in 4. So if I count 1, 2, 3, wako. 1, 2, 3, wako. It's trouble, okay? So let me just introduce Dr. Abdallah Bajaber, my fellow co-chair, who's going to talk about every child counts. Is a teenager an adult or a child? I don't know what his age limit will be, but let's talk about the children right now. Every child counts, and we're reimagining child survival beyond the hospital. Karibu daktari.
Good afternoon once again. My name is Dr. Salim Abdallah Bajaber, whatever you want to call me, pediatrician and head of department pediatrics, Mama Lucy Kibaki Hospital, the Mama Lucy, as you call it, the only hospital that is on the other borders. Now, to start with answering Toddy's question, my presentation captures, hopefully, all the age groups. I didn't want to put neonatal, child, adolescent. And I want us to shift our mindsets. I know it's a scientific conference. I'm not going to talk about anything technical. I'm going to talk about the question that should be in everyone's mind. When a child passes away, when you have stillbirths, when you have neonatal mortalities, when you have an adolescent dying while giving birth, who has failed? And that is the gist of our topic today. I do not claim to know everything about child health because this is a very vast topic. When I was coming to present this, the data that is there is massive. So I've tried to summarize, and it's going to be an interactive session. So let me give you some stories. This is one story. A pregnant young lady delivered a baby, 38 weeks, born in a rural Kenyan county hospital. She cried, she breathed. A bouncy baby. Day 2, discharged from the hospital. Day 5, gone, died, sepsis, far away from the hospital. Yeah? I'll give you another very quick story. A lady carried pregnancy for 9 months, went to the clinic, 3rd trimester, no BP cuff, yeah? No pre-agents, nothing. Enda nyumbani ukisikia anything, let us know. Goes to the hospital, a baby or a fetus that lived for the 9 months does not come out alive. Yeah? Who has failed? Who has failed? There's no one single failure. It's multiple systemic gaps. So these are numbers. And I just don't want us to talk about numbers in that sense, because we've seen these numbers severally. I want us to put it into perspective. By the end of this presentation, 4 children would have died. Let's put that into perspective. 35,000 stillbirths in Kenya per year. That is 100 families with empty cribs every single day. Every day. The context note is that most of these deaths do not happen in hospital. We know that. They happen at home, in communities, or on the road, out of sight of the health facilities. Yeah? Neonatal mortality rates, maternal mortality are repeated in almost every conference. But what do they mean? Are they just statistics? Is it something that we can do about them? The illusion that access equals to efficient healthcare system, we should get that out of our minds. The facility deliveries are at what, 89% right now? How come our mortalities have not come down? Does it matter when someone delivers in a facility that does not have oxygen, that does not have an incubator, that does not have CPAP? So there's facility access, there's quality gaps, and then there's this fragmentation of care. Do we have proper post-discharge follow-up? Do we follow up the mothers who have not come for their postnatal visits? Is it 48 hours? And babies alike. So why do we say the first 1,000 days are very, very critical? Studies have shown that by age 2, 3, 80% of the baby's brain development has happened. That is the most critical period. Yet it is one of the most neglected periods. We look at primary school education, we look at school programs and things when children grow up, but when they're younger, and you know that the environmental effects, affect the genetic expression. They might not change the DNA sequence, but they change the expression. So it affects how they grow up in terms of their healthcare needs. Now, I was hoping I thought maybe the CS or the policymakers would be here to see the data on the right. The unmatched return on investment. Si kila mtu anakuuliza what is the return on investment? For every $1 invested, you save $13 later. And what is the cost of not acting? Adults who experienced early adversity earn up to 33% less than their peers, permanently constraining national wealth creation. So when we look at a child, you're not looking at the hospital, you're not looking at the healthcare worker, you're not looking at the time when you have that child or neonate or adolescent in your hands. The discussion should start before conception, preconception, which I think none of us do. When you want to get married or when you have a spouse, to know their medical conditions, to know the children that you're possibly going to have, if any of you is carrying any illnesses, what does it mean? Your family medical histories, how do they affect your offsprings and things like that. Stillbirth, newborn care, home and family, immunization, early learning, all the way to the adolescent and adulthood. This is a continuum of care. It's a pathway. Now we all know the WHO framework of nurturing care. A child needs good health, adequate nutrition, responsive caregiving, early learning, security, and safety. But beyond this, you have from the immediate relationship of the child, families, family-centered care and kangaroo care, innovation. How do we use AI and digital health? How do we use the dashboards that we have? Communities. Are we engaging our religious leaders, faith-based organizations, CSOs on child health issues? Workforce. Are our healthcare workers motivated and supervised? I will not ask here, I know the CEO is not here, but I'll not ask how many of you are motivated because I know I won't see hands up. Yeah? You are motivated. Good, good. Systems, integrated referral pathways. This has been the biggest challenge even in MPDSR. Yeah? Referrals, been my biggest challenge even where I'm working. Yeah? Quality, zero tolerance for avoidable deaths, and this is where MPDSR comes through. Yeah? So we need to shift the mental model of child survival from the legacy paradigm, as we call it, to the survival ecosystem, where focus of care used to be hospital isolated to community integrated. The other day I was saying, why are we managing malnutrition in the hospital? Why? Why are we having, so much invested in how to manage severe acute malnutrition when somehow that investment could be addressing the nutrition issues at home? Because we know, I don't know about your data, I think it's the same, but whenever you get a child that is malnutritioned, majority of the mortalities, whether it's pneumonia, it's HIV, whatever, you name it, if you have some, then the prognosis is not so good. Post-discharge protocol, used to be reactive. Families are left to independently recognize danger signs, and then if crisis, arises, escalate. But become predictive. Structured follow-up, AI-flagged profiles, and proactive community health promoter visits. Data and accountability. Fragmented data. We have so many dashboards of various things. Moving into unified EMR, stroke the ECHI systems, and the many other systems that are existing. So as I said, this is a repetition. The child and caregiver capabilities are surrounded by empowered communities, supportive services, and enabling policies. Yeah. Do you have proper health education, child protection, WASH programs, and so on? Time, resources, health when it comes to empowered communities. Supportive services, the social networks, the local champions, faith groups, and then policies, paid leave, minimum wage, universal health coverage, all those things affect the child well-being. So Kenya's closest lifeline, the community network. And this, we have to bank on this. Community health promoters. The other day I was saying that we are just working within our hospitals, and most of the things we address it to the community, yet we do not have the community health promoters join us. When we're doing our audits, and you have, community death, maternal death or something, are we inviting the local chair or community health promoter to ask them, what happened here? Professional associations. I forgot to introduce myself, but it was in the introduction. I'm the Secretary General of Kenya Association of Muslim Medical Professionals, which is the counterpart of CHAC. And these are some of the things that we are trying to do. Yeah? Get the religious leaders to explain to the people about their health issues. They are the gatekeepers. Right now, if a patient leaves the hospital and you've given them a prescription and they meet a religious leader who they really trust and they tell them throw away that prescription, they will throw it away. Yeah? So faith leaders and elders are an important part of our communities. So this is the architecture, I talked about the WHO nurturing care. So you have quality, families, communities, people that are skilled, systems that work, and innovation. So the whole essence of a tiered system of care, you have the universal system of caring for people universally that target all caregivers. Yeah? The actions include the national policies, public media, and basic health support. Then you come to targeted support, which includes families at risk. These are those in poverty or displaced. The actions include home visits, affordable daycare, participatory community groups. And then now you have that small group that actually, we call it indicated support. That is the specialized group that really needs close care. And these are the things like the kangaroo, mother care, and things like that. So the intensity of intervention going down from universal support to indicated support, and the population coverage narrows down. So capacity pipeline. This is where we need to invest in people. Update the standards. We have all these standards as a head of department or even a healthcare worker. Do you tell people about the current guidelines and the current standards that are existing in management of something? Train the workforce. Extremely important. We're just working, you see someone has done a mistake, use it as a teaching lesson. Supervise and mentor. This is something that we've all been battling right now, and we say, the juniors, they don't want to learn, but have you taken a moment to actually teach them what is right, what is wrong? And then monitor the development. Are you doing better or are you regressing? So innovation, I won't talk about all the data systems that are existing, but data right now and how it used to be is that we see what went wrong yesterday or what is going wrong today. Data now is moving towards prediction or prevention. We should be using data for prevention and prediction of risks. So I'll touch on this because it's something very dear and close to our hearts, the Ewena initiative. Every woman, I had Dr. Abeid asking and no one knew about it. So I want us to all say it out loud. Every woman, every newborn, everywhere. Again. Amazing. I want us to think about this not just as a policy that was launched by the president the other day, but in essence of the word. Every woman matters. Every newborn matters. Everywhere. It doesn't matter where they're delivered, they're supposed to get the highest, affordable, quality standard of care. And the targets, you all know, 90% births attended by skilled personnel, 80% newborns receiving essential quality care. Sorry, this is supposed to be 90. 80%, no, these are the wrong targets, sorry. So 90%, who knows? 90%? ANC, how many ANCs did you attend? 8. There's leakage here. 4, and should be 4 quality ANCs. Okay, the next 90%, skilled birth attendants, yeah? The next 80%, postnatal visits within 48 hours. The next 80%, the last 80%, yeah, properly equipped facilities in all districts to be able to attend to emergency, obstetric, and neonatal care. So these are my references. By the way, on this references part, the policies that exist in Kenya, oh my goodness, are amazing. You have, for just pediatric, I had like over 50 policies, both nationally and globally. But do we implement them? So that would be all. Let's all remember every child counts. Thank you.
Another round of applause for Dr. We would like that by the time we finish our maternal and child health circuit, that you will be as incited, as infiltrated, as excited, as passionate, as depressed as we are. Because that's the only way we're going to create change. As Doc has said, we have a lot of policies. But if they're not implemented, they're just a piece of paper. Sindio? See, how many of you have ever written even a thesis or even a paper of any kind? Raise your hand. How many have published? You can see. So we have like 80% and then a 20%. If you do not put your work out there, it is still a piece of paper. Okay? And all these policies are there so that they can assist us. Now, I would like to introduce a friend, a colleague, a consultant, obstetrician gynecologist who works here in KUTRH and also very, very passionate about maternal and fetal medicine. Her name is Dr. Frida Odera, and she'll be presenting the impact of multidisciplinary clinical interventions towards mitigating severe maternal morbidity and mortality. Obstetric conditions and medical conditions in obstetrics are contextualized to our setup. So thank you very much, Dr. Frida. Makofi akikuja.
Thank you very much, Dr. Gidinji, my HOD. Good afternoon. My name is Dr. Frida Odera, consultant obstetrician gynecology, a gynecologist, and I also have a passion in maternal and fetal care. So today I'll take you through the impact of multidisciplinary clinical interventions in mitigating severe maternal morbidity and mortality. So we look at the introduction so that we are on the same page with the definitions, and then the major causes of maternal morbidity and mortality. We go through a bit of management of the obstetric conditions and also medical conditions in pregnancy, and we look at the systems level tools of the multidisciplinary care, and lastly, we conclude. So, maternal health is a critical indicator of the quality and effectiveness of healthcare systems worldwide. That is why when a mother dies, there is shouting all over, and that is why the maternity department is the biggest consumer of resources in a hospital. So, severe maternal morbidity refers to unexpected outcomes of labor and delivery that result in significant short-term or long-term consequences to a woman's health. And maternal mortality is the death of a woman either during pregnancy or childbirth or within 42 days of termination of pregnancy. That is either delivery or miscarriage, and from causes related to or aggravated by a pregnancy or its management. So, in spite of the significant advances in medicine, we still have severe maternal morbidity and mortality as leading to substantial challenges, especially in countries like ours, which are low and middle income. So we look at the causes of maternal morbidity and mortality. We have the big five, that is obstetric hemorrhage, commonly known as PPH. We have hypertensive disorders of pregnancy, preeclampsia, eclampsia spectrum. We have sepsis, complications arising from unsafe abortions, and then complications of obstructed labor. And we also have complications from pre-existing medical conditions, conditions that are aggravated by pregnancy, like cardiovascular disease, diabetes mellitus, thyroid disorders, renal disorders, and others. So multidisciplinary clinical interventions improve the prevention of adverse maternal outcomes. They ensure early detection and rapid escalation of care and coordinated management of patients. So we look at it this way. As obstetricians, gynecologists, we still need support from our physicians, from our anesthesiologists, from our intensivists, pathologists, in order to manage this woman. While we look at a woman who is pregnant and our primary goal is management of the pregnant woman, it still does not separate her from other conditions that she may be having, which our colleagues are better equipped to handle. So that is why the multidisciplinary aspect comes in. So as you all know, this is a level 6 national teaching and referral and research hospital. Therefore, it is privileged to have anesthesiologists, cardiologists, emergency care providers, hematologists, intensivists, physicians, obstetricians, midwives, gynecologists, and neonatologists, among others. So we look at the obstetric multidisciplinary clinical interventions towards managing obstetric hemorrhage. So the first thing is rapid diagnosis, which can be diagnosed by anyone because hemorrhage is bleeding. When you see blood, you know someone is bleeding. When you see blood coming out of a pregnant woman, red flags. So the intervention is geared at prevention of hypovolemic shock and organ failure. The implementation of standardized hemorrhage protocols, massive transfusion pathways, emergency response teams has significantly improved patient outcomes. So early involvement of multiple specialists, timely surgical interventions, and blood replacement and hemodynamic stabilizations, of course, will lead to better outcomes. We also look at hypertensive disorders in pregnancy, that is the preeclampsia, eclampsia spectrum. We know that they lead to serious sequelae such as stroke, renal failure, liver dysfunction, can also lead to blindness, pulmonary edema, and maternal death. Early screening, that is by way of the antenatal care. Dr. Bajaber had mentioned about the BP curve, very important. Appropriate referrals, when you have found someone with a high BP, what next? You don't just tell them to go and drink some water, lie down, punguza stress. You send them to people like us for comprehensive and specialized antenatal care. We run a high-risk clinic every Monday, robust for this kind of care. We need things like close monitoring, administration of antihypertensive medication, seizure prophylaxis with magnesium sulfate, timely delivery planning, and also preconception care for people who already have hypertension and you're following them up. These have been shown to improve the maternal outcomes. Then multidisciplinary care in this may involve obstetricians, physicians, especially in hypertension that is refractory to conventional treatment. We have nephrologists, especially when we're now getting into renal failures, ophthalmologists for fundoscopy, and when we have things like retinal detachment, neurologists for people who are developing seizures and strokes, and also critical care specialists to facilitate comprehensive assessment and treatment. So we look at maternal sepsis, which is also part of the big five. It is usually severe and potentially life-threatening condition resulting from untreated infection, either during pregnancy, you have at childbirth, or during the postpartum period. So when there's delayed diagnosis and treatment, it can rapidly progress to septic shock and multi-organ failure. So an approach involving obstetricians, infectious disease specialists, microbiologists, anesthesiologists. I forgot to write laboratory, especially for results like the blood tests that we do, the cultures, the sensitivities, and also the intensivist. They promote early recognition and prompt care. We also use sepsis management bundles, early antibiotic administration, and coordinated organ support to reduce the mortality significantly. Obstetric emergencies like uterine rupture, a placental abruption, and ectopic pregnancy, those ones require immediate intervention. So the multidisciplinary teams facilitate rapid decision-making, coordinated care involving surgical, anesthetic, laboratory, and also intensive care. And availability of multidisciplinary emergency response systems, of course, will go a long way in improving, enhancing the effectiveness of life-saving interventions, and thereby improving maternal survival. For cardiovascular diseases, like congenital heart diseases, which become apparent during pregnancy because of the increased load, there is cardiomyopathies that also just develop when somebody is pregnant or at childbirth. Heart failures and arrhythmias can be exacerbated by the physiological changes that occur in pregnancy. So care involving obstetricians, cardiologists, anesthesiologists, and intensivists enable individualized management plans and continuous monitoring and safe delivery. Then specialized cardiac obstetric clinics have shown significant improvement in maternal survival, and sometimes they even necessitate termination of pregnancies when it's obvious that the pregnancy cannot be compatible with a feeble heart. Then we have, it's not working. Okay. Yeah. So we are having a lot of diabetes mellitus, mainly because of lifestyle and the changes, and also because we're having the older woman getting pregnant. So we can have pre-existing and gestational diabetes associating with increased risk of maternal and fetal complications. And of course, poor glycemic control correlates with adverse neonatal and maternal outcomes, and also necessitating a lot of operative deliveries. So multidisciplinary interventions with endocrinologists for the glycemic control, obstetricians, nutritionists, dietitians, and neonatologists support effective blood glucose management throughout the pregnancies. Then we can also look at renal disease. We know that chronic kidney disease is a contraindication to getting pregnant. Although a woman still retains their autonomy, if they want to get pregnant, they will get pregnant. So when you have a woman with chronic kidney disease presenting with pregnancy, then it gives a significant challenge, especially due to now the increased risk of hypertension, preeclampsia, and progression of the renal dysfunction. So we have nephrologists and obstetricians collaborating and in order to now improve and optimize the maternal outcome, and also having multidisciplinary teams to for regular assessment of the renal function, medication, adjustment, blood pressure control, sometimes even requiring, these women sometimes even require now dialysis, hemodialysis, because the needs of the pregnancy and the kidney are just not compatible. So such interventions now reduce the complications. Then in our region, infectious diseases are still a burden. So things like HIV, AIDS, malaria, tuberculosis are still prevalent, and we know their effects on the pregnancy. So we work hand in hand with infectious disease specialists in order to offer the CCC comprehensive care and provision of the medications in order to suppress the conditions and improve pregnancy outcomes. So we can look at the systems level tools of multidisciplinary care, where we implement the maternal early warning signs. It's a chart that helps us to categorize the woman according to the we look at the vital signs and chart, and then it helps to stratify the risks and categorize the women who requires what kind of care. And then we have the critical protocols and care bundles, whereby when you have standardized bundles for hemorrhage, sepsis, hypertension, they help to avert adverse outcomes by reducing the variation in care. So it standardizes the care, then improves the guideline adherence, and also betters the patient outcome. Then regular simulation trainings to help with the drills to improve team communication, role clarity, and response efficiency, which also reduces the delays, especially now the delay in the facility, and who not knowing what to do and who to escalate to. And then also having strong referral networks, whereby which facilitate timely referrals in centers that are not very equipped to handle such cases. So in conclusion, the management of a pregnant woman is not the job of an obstetrician alone. A well-coordinated multidisciplinary approach will transform it from maternal care from reactive management of complications to proactive prevention, early intervention, comprehensive treatment, and thereby reducing severe maternal morbidity and mortality substantially. Thank you.
Asante sana daktari. Please have a seat. Dr. Odera taught me a lot. She doesn't remember me, but you know how celebrities work. You remember them, but they can't remember you back. At this juncture, let me welcome a fellow short man who called pediatricians short, Dr. Abeid. We are constrained with time, so all your 2-page titles and accomplishments, I won't read all of them. But for a start, the chair of the scientific committee for this conference, consultant, clinical oncologist, head of department, oncology, Kenyatta University teaching, referral, research and referral hospital, Kutrrh, yes. Fellow schoolmate, I bullied him before I proceeded to go get bullied by Dr. Odera. And also a very active member in the association we serve, Association of Muslim Medical Professionals, who is also a co-chair of the scientific committee for our upcoming conference in October. Karibu, Daktari.
Abdallah, I'm taller than you. I'm taller than you. Thank you so much for the kind introduction. You know, sometimes you are like busy with a lot of work. You even forget yourself. Like in this case, I even forgot myself. I'm a speaker in this conference. So like they were asking me for my slides. I told them, oh my God, let me prepare them. So whatever I'm going to present you is not my best. So naomba mnisamehe kabisa. Okay, so that's a very big disclaimer. Actually, I've just sent the slide now. So he's opening them. So just give me 1 minute as he tries to download the slides. I was supposed to share this podium with Dr. Deepak. We have been working very close in terms of obstetricians and oncologists, because there's a strong connection between oncologists and the obs-gyn people. So we have been working together, and this is one of the things we'd like to integrate. Just like they say, every woman, every newborn, everywhere, I think they should add an oncologist at the end, so that we can be working as a team. Please consider that, because oncofertility is very big. We care about we treat women, we are giving them a lot of side effects. So these women, they need to live longer. They need to continue with their sexual life. They need to understand everything in their life. So it is very important for us to continue with their life. I will repeat the same question Dr. Todi had asked. How many are married? Okay. Keep your hands up. No, zimeongezeka, zimetoka wapi? How many are married? Okay. Among the married, how many are having children? Oh, how many are having children or they have children? Okay, hands down. How many are having children? Everyone now. How many of us here have children? Okay, I just misgender group of schools. How many have kids at home? How many have children? Okay, at least I'm seeing 3/4. The people in blue, don't worry, you'll understand this very soon. So this is a very important question because now we are seeing a very alarming trend. We have a very alarming trend. How many had their children before the age of 20? Please don't judge. This is a very open. How many had their children before the age of 20? Okay, good. How many had their children before the age of 25? 1, 2, 3, 4. Okay, good. How many had their children before the age of 30? The number is going up. It's a trend. Naona tunachelewa kuzaa. That is the trend I'm trying to show you guys. Tunachelewa kuzaa. How many had their children at the age of 30 and below? 30 and below. Had their first child 30 and below. Men, we are also having children. Yes. How many had their children at the age of 30 and below? Good. How many had their first child between the age of 30 and 35? 1, 2, 3, 4. Okay, good. How many had their first child between the age of 30 and 40? Okay, so this is my topic today. So this is a global problem. It is not only us here in Kenya. Okay? This is a worldwide problem. So I'm going to talk about cancer during pregnancy. So as introduced, that's my name. I'm Dr. Abeid. So this is headline in the US. Is it very different from what we have been raising our hands here? Is it very different? It is just a reflection. Yeah, so it's a global problem. I don't know if I should say it's a pandemic, but we're having a big issue. More people now, they are delaying having their first child, they are even delaying having their marriage. Because in African traditions, before first you get married, then you have children. But nowadays, tumebadilika, we have evolved, we can have children, then marriage later. Even in I believe in Christianity, you can have children first, then you have your marriage when you are 50 years old. Sindio? Yeah, but it's still a marriage, it is acceptable. So I think that marriage part might not apply to us, some of us here, okay? But for us in Muslims, we can never have children before having the marriage. Okay, good. So this is the global trend. If you look at this one, you can see there's a decline in birth rates among the married women. We can even see there's decline in birth rates even among the unmarried people. Okay, looking at that age, look at the age where the first child is like the age at which you're having the first child is increasing. From 25, it is now pushing upwards. So all the curves are climbing upwards. And for those who used to have their children like at the age of 30 and below, they are coming down. So we are having a bigger problem. It means we are going to have more women going to have their children delayed. With an increase in trends of cancer, most women, they are going to be diagnosed with cancers before having their first child. So it means we have to be discussing this problem. Okay? We know that among all the cancers we have been seeing since yesterday, breast cancer is the most common one. And we in the low and middle income countries, most of us, they are going to be diagnosed with breast cancer before the age of 40, up to 30%. I did the local data in KU is 35%. Most of our breast cancer patients diagnosed in KU Referral Hospital at the age of 40 and below, 35%. Who can guess what is the age of the percentage of women diagnosed with breast cancer before the age of 40 in Europe and USA? Who can guess? Just a guess. Dr. Todi, 10. Another guess? 15 coming from this end? 16, another guess? So in the USA, it's 5% before the age of 40. Breast cancer diagnosed before the age of 40 is only 5% in the USA. In Europe, another guess? At least you have a hint now. Huh? 7%. Okay, so we can see that in Europe and the USA, the age at which we are having the first diagnosis of breast cancer is at the age 5 to 7%. Here in Kenya and Africa, is 30-35%. Isn't that alarming? Why? Because this is the age we want to have children. So imagine now you are choosing between becoming pregnant and having a child. It's becoming a very big problem. So these are the teams which are involved when a woman is diagnosed with breast cancer while pregnant. So it is a multidisciplinary team. Is there anyone left out there? We have radiologists, we have pediatricians, we have neonatologists, we have everyone involved. So this is a multidisciplinary problem. So if you think you are not in the space or on the sphere of oncology, or you are not obstetrician, you're not going to face this problem, see it there. Because I have a big problem with my colleagues from the radiologists who are not updated, who don't have the information about managing or imaging of breast cancer women in pregnancy with cancers. It's a big problem we are having here, but we are changing that slowly by slowly. So what do we need to consider before we do anything with our cancer treatment? Number one is the diagnostic part. We need to know what are the stages, what is the diagnosis, what is the imaging modality we need to do. Because in cancer, we have to image our patients from head to toe to confirm there are no cancers, okay? So usually our preferable diagnostic method is CT scans. Is CT scan safe in pregnant women? Is CT scan safe in pregnant women? The answer is no. It is not safe. We don't image it, okay? So we need to understand what are the images we need to do during pregnancy. Is MRI safe during pregnancy? The answer is yes. Say yes. Watu radiology wache kufukuza wanawake wote tukatumia image huko kwa breast. Sawa. So breast MRI is safe in pregnancy, but even that one, it has a period when you can do it safely, okay? Is surgery safe in pregnancy? The answer is yes. Say many yes. Say surgery is safe in pregnancy. Doesn't matter which trimester you come, whether it is first, second, third, it is safe, okay? The next elephant in the house, is chemotherapy safe in pregnancy? How many are saying yes? Dr. Michelle has said yes. She's an oncologist. That's why I know yes. She's the only person amesema yes. Makofi kwake. Yes. The answer is yes. It is safe. Now, it is safe at which trimester? Okay? Let us have a look at this. So this is the normal physiology which any woman goes through during pregnancy. You can see the other, before the week 8 coming backwards, this is the embryonic period. This is the period where you are going to have most of the congenital anomalies if you are going to give your treatment, your imaging and everything. So we are very careful when we are treating our cancer patients. So first we look at this. Is the woman already in second trimester? If the woman is in second trimester, almost everything is applying to any cancer patient, it applies to a pregnant woman. Tuko pamoja? Anything which applies to non-pregnant woman, it applies to pregnant woman after the second trimester, with a few exceptions. And I'll not discuss that. Kwa hivyo, the message I want you guys to take home, chemotherapy is safe in? After which trimester? After first trimester. So any woman coming after first trimester, let us advise them it is very safe for them to get chemotherapy. That is my message home. Me, I can even finish my talk now. Okay? So here we go. Because these are the physiological changes, so we need to understand. But I will not go deep into this one. We all know that there are cardiovascular changes, there are kidney changes, the GI changes, hepatic changes. These ones, they're helping us to know which chemotherapy is safe. So which are the chemotherapy, which are the cancers which occur in pregnancy most of the time? Cervical cancer is the leading one. What is the most common cancer in Kenya? What is the most common cancer in Kenya? How many are saying cervix? Oh my God, you guys, you are amazing. You all know it is breast. Makofi kwenu. So the most common cancer in Kenyan women is breast cancer. Tumekubaliana? However, it is not entirely true. It depends which part of the Kenya you are coming. But overall, it is breast cancer. Ukiwa unatoka kule kwetu watu wa kukula samaki kule Lake Victoria, sio Coast, the leading cancer ni cervical. Tukikuja huku kwengine towards Nairobi and the rest of Kenya, the leading cancer is breast cancer. Tukienda kule northeastern, tukisema bahari yake, huko tunasema nini? Esophageal cancer, head and neck cancer. So the distribution is very different from each part of the country, but generally the most common cancer in Kenya, number one, is breast cancer. Tumekubaliana. So it means more women, they are going to be diagnosed with breast cancer while they are pregnant and cervical cancer. Tuko pamoja? Nishamaliza presentation. So what are the common symptoms we are having in cancer? Most of the time the breast becomes big and thick, so it is sometimes becoming very difficult to differentiate it with the pregnancy. So this is where I really want you to pay attention. If a woman comes to you with a lump during pregnancy, don't brush it away saying like, no, don't worry, this is just breast cancer pregnancy related changes. We have seen a lot of women coming early, presenting very early to their obstetricians and more clinical officers, but they are being assured it is normal. Please, there's nothing normal with a lump. Any lump more than 1 centimeter is abnormal. It has to be investigated unless it is otherwise, it is breast cancer, okay? If we think like that, then we are going to have all our breast women being diagnosed very early. Then the other thing in hematology, they can present with fatigue, with malaise, shortness of breath. So you are seeing there, the differences is like a borderline. You cannot even able to differentiate what are the symptoms of pregnancy and what are the problem in with the breast cancer or the malignancy related. But generally, these are the most common symptoms we are going to see in our cancer patient, also in our pregnant women, okay? So now let us go step by step. In first trimester, what can we do in second trimester and third trimester? Number one, ultrasound is very safe. We said MRI is extremely safe. CT scan is not safe, okay? When we come to the pelvic region, ultrasound is safe. MRI is safe, but if you're imaging the pelvic region, it is safe after with certain conditions. So for me, I'll just tell you, just leave it for now, okay? Then for distant metastasis, whole MRI, it is safe. PET scan is contraindicated in pregnancy, okay? For biopsy, you can do in any trimester. Whether it's a core biopsy, FNA, everything you can do. So whether you are doing your technetium, you can think about it. The indiocyte green, yes. Blue dye, we are not doing it, especially for the surgical part, when you are doing the sentinel lymph node. We don't use it because they are saying it has some effect in their children, okay? The circulating DNA and the pelvic biopsy, it is okay, acceptable. So surgery, it is ideal. It is possible in all trimesters, but ideal in the second trimester and above. Okay. Chemotherapy, we said it is safe in the second trimester and above. Radiation, in the early part of the pregnancy, if this patient has already completed her treatment, you can consider giving radiotherapy because we can do what we call shielding because the fundal height is still very low. Usually with radiotherapy, we go up to the level of T3, T4. But we know that in the first trimester, it is just there, down there. So we can do shielding and do radiotherapy in the first trimester. But most of us, we are usually scared. We avoid it in all cases unless like the patient is having aggressive features. Targeted therapy, they are totally contraindicated in pregnancy. The same applies to immunotherapy. So chemotherapy is safe. Radiotherapy can be discussed. Surgery is safe. And all other imaging as we discussed. So I will not repeat this one. Okay, so in summary, I've just tried to summarize what I've been discussing with you, the normal symptoms, the cancer symptoms, and the diagnostics tools which we can use in each stage of pregnancy. And this is our QAU data. We have been getting a lot of patients. Because I forgot to prepare the slides, I had just to go back to the data very fast and put this one for you. So most of the patients we have been managing with breast cancer in pregnancy, I have highlighted this for here. 3 of them, they had breast cancer. Another one had leukemia, and the last one had Hodgkin lymphoma. You can see all of them, we manage them through CS because usually sometimes we are scared because we don't want to prolong the labor. They have already been getting chemotherapy and all the risks. So sometimes the obstetrician, they are not comfortable with the normal delivery, but normal delivery, it is safe again. But we can see in our trends here, we have been doing CSS because of one reason or another. And we can see all of them, they delivered very safely, except one patient, the second patient. She came at a very advanced stage, pregnant. There was nothing we could do, so we lost this woman. But the rest, all of them, they came pregnant from first trimester all the way to the third trimester, and they delivered very healthy baby. Actually, one of our patients had triplets, the non-Hodgkin lymphoma patient. So we're able to deliver triplets, and they're all doing well until now. So this is in summary what is safe. I will not repeat again because I remember it was very interesting to hear you guys singing it, and you have understood very well. This is the same, and this is the end of my presentation. So treatment in pregnancy, treatment of cancer during pregnancy is safe, but what is the most important thing is multidisciplinary care. Thank you so much.
Thank you, Daktari, for the amazing work you do and for enlightening us. The theme remains care without gaps. So if you're seeing someone, a patient, who you need input from the radiologist, from the obstetrician, multidisciplinary, and you're not involving them, then that's a gap, definitely. So let's keep spreading the knowledge. I think Daktari was sent by Dr. Freda and Dr. Kithinji to ask us how many are having children, so that he refers us to them. But yes, we are still having children. Yeah. Last but not least, they say save the best for last. And I have the pleasure of introducing my fellow co-chair, as we know her, Dr. Todi. Yeah. Dr. Janet Kithinji, daktari wa mtaa. Yeah. Sijui kama huku kwenu ni mtaa. Ni mtaa, yeah? Okay. Sawa. Atatugusia hiyo lugha yake kiasi, yeah? Shembeteng. Daktari is a consultant gynecologist. She's also a fellow member. We are together in the inter-county MPDSR team. She has been very instrumental in MPDSR, especially on the dashboard. There's a place called Marifa Center. Senator Marifa. Yes. Marifa Center is where positive stories from various counties are published. Coming from where I come from, which I don't want to repeat, we've been in the news all the time, but you're not that bad, please. Yeah? We're not. Things are changing. And it's because one conceded goal would hide all the goals that you would have scored. Yeah? So we need to tell positive stories every now and then. And I think one thing I need to applaud Kutrrh for is actually the good stories that you're telling us of what you guys do. So on that note, she's also a director, by the way, a movie director. She's directing a very nice play. I don't know when it's coming out. I've been waiting for it for very long. On the journey of a mother. I hear it's a very sad story for those who have insider information. And hopefully when it comes out, we'll have tickets to the front seats. Cindy? Yeah. Please, I know we're about to finish, but as she comes along, tusimame, because we need to stretch kidogo. Just stretch. Quench your thirst kidogo. Yeah. If you have water, just take a sip. Stretch, 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 stretch. As Dr. Todi stretches her legs towards the podium. And give her a round of applause.
Thank you, Dr. Salim. Thank you very much. Raise your hand if you've ever had a mammogram. Actually, raise your hand if you have breasts and you have never had a mammogram. Raise your hand very, very high if you have never had a mammogram. I really want Dr. Abeid to see that we have this amazing comprehensive breast center and we have people who have never had a mammogram. Okay, raise your hand. Perhaps I'm talking to Gen Zs. Are you over raise your hand if you're over 35 years and above. We're not judging your age and you've never had a mammogram. For the males, raise your hand if your wife is over 35 years and has never had a mammogram. You can raise your hand on her behalf. Because my presentation will also have, this presentation as much as talking about maternal and child, there's a lot of male involvement. I remember I told you that I'm talking to you as a community, right? Ama niongee lugha mtaa ndio mnipate. Najaribu kusema Mamorio, nyinyi wenyewe pia mjue pia nyinyi ni pati ya hii riba. Mnangam. Mnangam. Mnaninauo. Translation means that even all you men must be a part of this community conversation. So I am last, not least, because I really want us to live with this conversation. Who knows what MPDSR stands for? M for? P? D? S? R? Great. I think you're going to have a great time. So now that we understand what maternal and perinatal death, surveillance and response means, it is the ability to look at why women are dying, the number of women who are dying, so that's the audit, the number of neonates who are dying, that is the death part, and then surveillance, why they are dying. And the response, surveillance and response is also what we are going to do so that they don't die, okay? And then the things we said we are going to do, we assess and track and see whether that is happening. How many were in the conference here yesterday when our CS Duale was here? Alirusema ewene marangapi? 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 Mambo malikuwa mangapi? Alirudia ewene mara 3. And for every time nilikuwa nasikia ewene, I was shaking in my seat. Because this is primarily our docket. But I want you to know that this is not an obstetrics and gynecology department mandate alone. It is not also Dr. Priscilla, who I can see you. Thank you so much. Nico department alone. It belongs to all of you, starting from the watchman from the gate into the hospital, third delay, and even long after they leave. Remember what Dr. Salim said? The babies after 3-4 days at home, they die. So this is a whole of society approach, a continuum of care. Because when people come to give birth, it should be a rewarding experience. For somebody who is pregnant, squeeze mnasikianga, there's clinic, sijui mpaka kuangalia gender, there's even gender reveal parties. Mtu anajifungua anapata push gift. True? Mimi sikupata push gift. Nani alipata push gift hapa? Nani alipeana push gift? Makofi kwa Dr. Ndave. His work. Be like him. So people got push gifts, but you can understand that the elements of childbirth are a rewarding experience. It is such a joyous occasion. When a woman comes to the hospital, it's just one. By the time people come for visiting hours, just look around. But they, even as I continue, Sister Dr. Nangweso, right? Please come. You're part of us. Your study was all about us, so come. At the end of the day, it is a rewarding experience. But not every time is a happy time. We always aim for a happy mother, healthy mother, healthy newborn outcome. But it doesn't always occur like that. Sometimes a mother can die. Sometimes a neonate can die. Sometimes both can die. Think about yourselves in KUTRH as a level 6 facility, the apex of healthcare. By the time a woman who comes to us is coming, ako hali mbaya ama yuko hali mbaya? The country is represented by these people. There is Kakamega, there is Wajir, there was Moyale, Marsabit, there is Mama Lucy, one of the very busiest Nairobi counties. Sindio? And even all of you guys, you can imagine the counties you come from. So as a country, we are fully represented in this discussion. 30 to 35% of mothers are dying due to hemorrhage. They bleed to death. They just bleed to death. How many of you here have ever donated blood? Raise your hand. Okay, how many have never donated blood? Leo nakwambia naanika. Haya, sawa. Then, high blood pressure, about 15 to 20%. 1 in 5 women can die because of complications of high blood pressure. 10 to 15% because of obstructed labor. You've had people who are coming from the arid and semi-arid counties. The greatest counties in land mass, very wide. Distance from one hospital to another, 700 kilometers, 800 kilometers. And ambulance. Is that ambulance an ACLS ambulance or not? Na tunasema ambulance ambayo si ACLS ni mata? Ambia mtu ambulance bila ACLS ni matatu. Tell your neighbor. Na sio nganya. Na sio nganya. Ni matatu na sio nganya. So, you get obstructed labor, you get uterine rupture and sepsis and all the complications. That woman really doesn't have a fighting chance. Complications following unsafe abortion. We've heard about the teenagers. 1 in 6, 1 in 5. Chances are not all of them decide to deliver. You can hear they're depressed, they're anxious, they're uncertain. Not everybody is a married teenager. By the way, kwa wale wababa wote ambao wanalala na watoto, ebu ambieni shindwe. Shindwe. Hizo ni mapepo. Shindwe. Because not only do you impregnate a child and then you leave that child, chances are they're likely to try and imagine having an abortion. And then they get complications from abortion and then they die. So first of all, you made the child a mother and then that child died. And that baby also died. And this is our society, our country today. Leo tuambiane ukweli. And then some of them also do get venous thromboembolism. And we also know their babies can also die to complications of preterm birth. If a woman is in trouble, chances are their baby is too, right? We've heard of sepsis, we've heard of preterm births, we've heard of birth asphyxia, we've heard of sepsis and congenital anomalies. The Kenya maternal mortality ratio stands at 355 per 100,000 births. As Dr. Salim said, let's break this down. Every single month. Wangapi washaenda na ndege? Who's flown? Boeing. Boeing. Sawa? If you take like a Boeing 787 or whichever Boeing that fits around 300 full capacity, including pilot na first officer, every month that plane crashes and all the mothers in it die. For context. Up, down. Up, down. That is what that statistic says. And for the neonates, Dr. Miongea, we are having 24 per 1,000 births. We keep saying that we want to have 2030 vision. Si tulikuwa tumesema launch of vision 2030. We only have 4 years to 2030. And they are aiming that we are going to have a maternal mortality ratio of 70. We are already 5 times above where we are supposed to be. And for the neonates, it's twice. Mumesikia 100 cots per day. A baby every 4 minutes. It is depressing. We have to be depressed together because that's how we'll create change. And our president, I'll give you this story. When he went to the UN General Assembly, he said it. It's himself. It's a true story. Alienda United Nations General Assembly in New York. Akasema vile Kenya tuko sawa, mambo iko sawa, iko sawa? Iko sawa. Akaulizwa, mko sawa na kuko na areas in your own country where the maternal mortality ratio is higher or equal to Afghanistan? Let that sink in for a minute. Na hatuna vita. Sisi tu ni watu wa vibes na bado tuko na maternal mortality rate that is higher than Afghanistan. He came back and he said, no. There has been efforts. We said we have beautiful policy papers. But he said, no. We're going to whip these things out and we're going to try and accelerate all the efforts we've already said we are going to do. And now in 6 months, we're supposed to accelerate those plans for Ewene. That's why unasikia jina Ewene inarudiwa tu. Because that is where we are, okay? So those are the strategies that are meant to be done. And this, like we said, requires a whole of society approach, which is why I'm talking to you, not just as healthcare workers here in KU. I'm also talking to you kama mbogi ya ground, kama community. We need a whole of society approach to ensure all these efforts at community, facility, county and national levels is there. And KU, chora hivi ngazi. Chora hivi ngazi juu. You are the apex. You can really, really, really save these women. We stand at the apex. But what are we able to do? I broke down the big 5 for you so you don't have to keep on remembering much else. But you just want to imagine that at technical level, you know, when you're given a policy and then it's broken down, we need to be able to ensure the delivery units are done in our facility. Daktari talked about them. Just repeat 1990, 80, 80. 1990, 80, 80. So the 1990, 80, 80 was required to say that we have got 90% people should come more than 4 antenatals, right? The other 90% should deliver by a skilled birth attendant in a hospital. The other 80% should be sure that they have postpartum reviews within 48 hours. And the other 80% is to ensure all your counties, kule kote mmetoka, hospitali zenyu ziko equipped. Hata sita wauliza ushago yenyu ni gani. We're supposed to ring fence the last mile fund to ensure, you see there we are struggling with commodities. But for maternal and newborn health, things to be ring fenced so that we don't have stockouts, okay? Then the other thing is to encourage and embed a readiness and drill culture for high-risk events. All the way from the watchman, like we said, from A&D to NICU or to the wards. There needs to be a culture where we do drills and we know everybody is sorted out. We never forget the babies. That's why the P is loud. We ensure that for premature babies, we still have got interventions for them. Give them DEXA in the ward. Give them MagSaf, delayed cord clamping, breastfeed early, do kangaroo mother care. And then all this data that we collect, we have condensed it into one big live dashboard, countrywide. Kama county yenyu inachoma, munaonekana. Kama mko sawa, munaonekana. And it's live. It's in real time. So here I just done a comparison of our staffing between KNH, MTRH, Kutrrh. I'll just say that KNH was founded in 1901 and then made a parastatal in 1963. MTRH 1917, but then made a parastatal in 1998. KUTRH we are at October 2021. So we are the almost newest kid on the block. Kutrrh was also put, but it existed before. So we are fairly young. It means we have potential and opportunities. Sindio? So currently we only have got, this is the capacity. We have one mat theater. We wish to expand it. When we did the comparative analysis, and this is the importance, if we deliver less babies and if we have less live births, when we get one referral for one death, it looks like we have a high maternal mortality ratio. So you might find other people, we are trying to be at 355. Who knows the facility maternal mortality ratio for KU? Niwambie? It is 2,000. You see now when you look at it as a ratio, it looks like, we, uko wa mama wanakuja wanakufa. And that's not it. It's just that we've got a low denominator. So even when we get one referral that results in a death, it brings the ratio to look very high. That's what that interpretation meant. And also now it means that even as we continue with our trends, we try to stay stable. But even as you look at these numbers, as low as they may look, remember sisi hatupati regular women. We're getting some serious near-miss women. All these women we've managed to save would ideally have been mortalities. Okay? So we're able to save them because of what Dr. Frida presented and what Dr. Abeid presented. The multidisciplinary approach. The fact that we have everything we need to save these lives, okay? So we talked of the maternal mortalities and maternal near misses. Those have already been talked about, so we don't have to repeat. And what are the challenges that surround us, especially in KU? Late referrals. So if Daktari will need to send me a patient from Mama Lucy, before the referral office coordinates, before aingishwe kwa ambulance ama matatu. Ambulance ama matatu. Tuambiane ukweli. Ambulance ama nasinga. Haya. Then we arrive here. Then we find third delays. We don't have blood. We don't have reagents. We don't have all these things. All these things are going to give us, we have no fighting chance sometimes, all right? Different turnaround time. We talked of delayed procurement and medication stockouts of the essential drugs. So, how are we going to try to do this? Even in above and trying to ensure that the hospital building blocks are there. We would wish to be able to find a criteria which has already been adopted by the board of how we are going to admit women who really need help in this facility. Otherwise, we are going to, if we don't do this, we're going to be called Kenyatta University Mama Lucy Kibaki Teaching, Research and Referral Hospital. People will self-discharge and show up here. So we do need a specialized criteria for admissions of patients who genuinely need. Do you think a patient with breast cancer and pregnancy deserves to be in KU? 4 previous scars, placenta previa for 3 pregnancies. A woman who just feels like coming to KU. You get? So there is that criteria and it is somewhere. How many of you know, in fact, this is a question. Do we accept SHA, comprehensive SHA in KU? Raise your hand if the answer is yes. If the answer is yes, raise your hand. Do we accept SHA, kuingia kutoka? Haya, do we accept SHA kuingia kutoka? No. Inua mkono no. Okay, do we accept SHA kuingia kutoka? Sijui. Sijui. The answer to that is yes. Okay? We started to accept comprehensive SHA kuingia kutoka. But we are piloting it slowly so that, as we said, tusikwe Kenyatta University Mama Lucy Research and Referral Facility. Now, for the neonates as well, that is also their comparative analysis. And also we keep on zigzagging. Sometimes depends on also the same issues. Sawa sawa. So we still spoke about, if we even have a single digit, that causes massive spikes because also all of our denominator. Sawa sawa. So again, the same things that surround perinatal mortality, the neonate. Care in transit. Kama unabebwa na matatu, na sio ambulance. Do you think their baby is warm? Do you think the care in transit is optimized? So finally they arrive, but what? Si tu bora mtoto, but mtoto bora. Sindio? So that they can stand a chance. Again, also those are the things. Our NICU capacity is also not big, 15, top 20. If we get a bug, there we are. We're in trouble. We are not able to assist. So the action plans we said is to try and expand these spaces, get a direct hotline to mitigate the third delay so that any hospital can just call us directly and we come in. Then to embed our MPDSR committee members in areas like blood, the areas where we struggle, we make sure even our voice is heard. Then as far as the ensure the antenatal clinic coverage, joint MDTs, which we do, even with healthcare financing, as much as we're saying comprehensive SHA, ikizidi, we have to also give feedback to the management as well as the SHA people and tell them, your pesa haitoshi, changamkeni. And then also interact with the government programs. For the then also to continue with continuous training, do joint CMEs, support supervision of all these referring facilities. This didn't go well, so that we're able to work together and make sure that all this input is being taken up and down the referral system chains. For perinatal, the same, to ensure that you learn about neonatal resuscitation through drills and trainings. We ensure that we have got neonatal resuscitation equipment in delivery areas. The golden minute here changes the game. Ensure early identification and timely referral of high-risk pregnancies, even from clinic level. So if you have a neighbor, nashai kupasuliwa mara tatu, alafu nakwambia naendanga dispensary, you here, I'm sending you to that community and tell them apana. Uko apana. Kuja wapi? KU. Then ensure that there is functional resuscitation equipment in labor ward as well. Then to ensure that we are going to expand the NICU and NBU capacity even as we continue with SHA. We ensure proper communication, standardized documentation, and also proper protocol management. And as well, we make sure that we are there. This take-home message, I really want us to read, all of us. All of us. Sawa sawa. All of us. I really, really just want us, and I want you to say very loudly. In fact, stand up. That is if you're pledging, if you truly pledge. Do you remember the way we had said our hand, the way I told the dudes to put their hand on their heart? Everyone here has a heart with a heartbeat. We want this heartbeat for all these people. So please repeat after me. Every woman, every newborn, everywhere. Okoa mama, okoa mtoto, okoa wote. Tunajua, tunaweza, tunarekebisha. Clap for yourselves.
Asante sana daktari wa mtaa. Nimeambiwa nifanye kitu which siwezi nikajiaibisha hapa. Ati sijui mnasema na ngaji? Kumibwekse. Yeah. Abed, you see what you're setting me up for. Yeah. Thank you so much, daktari. There is a suggestion that there was a session just before lunch. I know we're at 2 o'clock. The session had a few speakers, but 2 of them are not available, so we basically just have one speaker. We have the speaker speak to us, then we take the Q&A for all of us. Is that okay? Yeah, because if we do Q&A now, we'll drag, and then we have the speaker, then we go for lunch. Yeah? Okay. So next up, we'll have Dr. Solomon, who is the head of accident and emergency at Kenyatta University Teaching, Research and Referral Hospital. Referral and Research. Nitajua tu, don't worry. Uko Mama Lucy, si mambo sasa mnakuwa KUTRH na MLKH soon. Tutajua when we are conjoined. Daktari, karibu sana.
Good afternoon. Sorry, I'm the one standing between you and the lunch. So I'll make it quick so that we can break for lunch. It is hard speaking after those speakers, and they have given us more clinical. They have given us more clinical perspective. Us as the emergency beat, our adrenaline is always on the rise. So I think I only have like 13 slides. 8 of them are photos. And then which one? Oh. Which one? It's also hungry. So my topic is about disaster response. We are living in very difficult times where it is disaster after disaster. Very recently, we just had somebody spoke about the Strait of Hormuz. So it can be anywhere. Today, Uganda can just become angry at Kenya, and then we close borders and we start fighting. We have other issues. COVID-19 was a disaster that made the world to be locked, and we had so many deaths as a result. We have Ebola, we have Mpox, we have Marburg. Those are biological. Then we have accidents around recently. So let's start with the photos. Lockdown was about what? COVID-19, okay? That was a disaster. Then this was, who can guess what that was? That was bomb blast. How about that one? This was a recent accident that happened around Kisumu. A whole family that hired a bus went for a funeral, and they did not make it back home. How about that one? This is Dusit, very recently. How about that one? The mudslide where? Around Maimayu, very recently. How about that one? The recent floods in Nairobi. Okay. How about that one? The same, Nairobi. So all those photos should speak to us that we are very close to disasters. Anywhere, any day, anytime. So for the many stories, I would just want to capture my last slide so that disaster, we all know what disasters are. We don't waste time on the literature or on the slide. So Sorry, I'm getting it wrong. It was the last slide here. So I just want to read about this, the World Disaster Report 2022. This was by the International Federation of Red Cross and Crescent. They did a report after COVID had gone quiet, and now this was like a post-mortem. And the communication was that COVID-19 pandemic has been the biggest disaster in living memory on almost any measure. I was surprised that we lost 6.5 million people to COVID. So more than 6.5 million people are confirmed to have died in less than 3 years. And the pandemic's indirect impacts have touched lives of virtually every community on the planet. So the World Disaster Report 2022 focuses on the coronavirus pandemic and preparedness, both the ways preparedness ahead of COVID-19 was inadequate and how the world can prepare more effectively for future public health emergencies. So preparedness encompasses preventing, that's where I want us to pay attention, responding to and recovering from an emergency or disaster. Being truly prepared, therefore, means being ready to respond, to recover, and to learn lessons for the next time. In other words, preparedness is an ongoing continuous process. We can save lives just by being prepared. The next pandemic would just be around the corner. Let us lay emphasis on that. And even as we stay in our country, we have political undercurrents. We are blowing hot and cold. So as an institution, are we prepared to respond to, say, emergency, mass casualty situations? Thank you very much.
Asante sana Daktari for being very brief and to the point. Disasters are just a minute away from you. Just reminds me quickly as he was presenting. I heard about there was a conference about emergency response or something like that. And then they invited a minister or something like that. And then during the conference, they actually did a drill. And the minister was running away. And then he was called back and he was told, Waziri, this is how unprepared your country is for disasters, you know. So I'm just imagining if you guys did that, Jana. Yeah. But I hope you guys are doing drills. With that, I think we'll open up for the question and answer. Dr. Bate, please come on stage. Can we limit to a question if possible each? We are there for interaction, but don't ask me. Yeah? I just presented data. Yeah? But you're open to ask questions. Who is taking down the mics? Please state your name and your profession and who the question is directed to.
Thank you. My name is Peter Musheru. I think I should also be seated there because my interest is also in that group. I'm a speech language pathologist, so after this, I think my presentation is coming. I wanted to ask, we've talked about the mother, about the child in the hospital. What happens to them immediately they leave the ward? That will be the question.
The mother or the child? So
both,
that we know
the mother and the child.
Okay,
we've given them a lot of therapy, medication, we've given them cancer treatment immediately after they leave. All the children, we've talked about children, about post-hospital care. That's where we come in. And in the whole, we didn't see where we are coming in as the rehab team.
I don't know if you mean in the context of how ideally it should happen or how it happens in KUTRRH. But ideally, as it should happen, is basically stipulated in the 90% of the Ewene target, that they should all make sure that a baby is seen within 2 days. A mother should have postnatal care where she's seen also for another 2 or 3 days, depending on the mode of delivery. And then she's given instructions that are even in her antenatal booklet of how to go home and what to do, and in case of danger signs and what to look out for her to come back before the next stipulated postnatal visit of 2 weeks. That is what is ideal. And yet it also does happen here in KUTRH. This being again a level 6 facility, sometimes you can also ask them to go to the nearest facility that is near them for the 2-week postnatal visit, but stratified by risk. But then as we are highlighting the gaps as well, one of the things that when we get our own reproductive health suite, we'll be able to even ensure that that is further streamlined, such that even our women who we saw here for high-risk emergencies are followed through a very long period of time for them, and also their babies. Even the babies also have issues, can also be followed up here even up to 1,000 days. But then we still need, first of all, to get the numbers up and running. Yeah.
Hello.
Reproductive health suite. Yes.
I'm Dr. Florence Wanjiru, a general surgery co-sexa resident here at KUTRH. My question is to the gynecologist. Maybe they give us a bit of insight about egg cryotherapy for our cancer patients who are coming at childbearing age, and also considering the population where we are having a trend of women getting children much later. So maybe that is something we should talk about.
Thank you for your question. So I know you're asking in the context of delayed fertility, what someone can do to preserve their fertility potential, maybe because they are going through a cancer treatment, or maybe because they are going through school, or they're not just ready yet. So we are having a lot of emerging, we're having existing fertility centers, and we're also having a lot of our gynecologists developing interest in that area. And egg freezing services are available. However, they are not funded by the government, so it has to be out of pocket. But yes, they are available, and for anyone who is needing them for whatever reason, it is possible.
Just to add to that, there's a small grant I've acquired of $3,000. I'm going to investigate the same for about 30 women. But now we are not doing cryopreservation. We are using something which is not the standard, what we call goserelin. So we are going to be giving them goserelin to see if they are going to preserve their ovarian reserve. So this is something we are going to do here in KU in a short bit, so it can guide us in a country like, should we be recommending it to women? Should we make it like the standard? So because cryopreservation is not readily available.
Thank you. Any other question? So Daktari, you see Daktari and be part of that study. Yeah.
All right, thank you to our speakers for the wonderful discussions. So mine, sometimes back I did a study on decision to delivery interval of the emergency cesarean sections, and the findings were quite interesting because we find that in Kenya we are not able to meet the recommended target. So my question is to the Ewene program. So is there like a tracking system whereby once these mothers delivered, you're tracking them and the newborn, and then like you're giving us that feedback? Thank you.
Thank you. That's a really great question, and which is why it really explains to the gaps. And this is not why we are even having a conversation about care without gaps. Care without gaps means that the first thing we need to do is identify the gaps. The decision to delivery interval would ideally want it to be 30 minutes or less. But then you find that in a scenario such as here, we've got maybe 6 theaters that are being shared across all the other issues. So as far as the building block of health, the issue to do with infrastructure needs to be looked into, and it's a conversation that is already still ongoing in KUTRH. Even using the other programs that are coming in, and I'd put it in the slide, where we have even governmental collaborations like the NESP program, to try as much as possible to also equip other spaces within maternity to have even more than 2 theaters at least to begin with that run on a 24-hour basis. If you go to our unit, actually, if that happens, the decision to delivery is going to really fall within the framework that is intended, because we're on the same floor. We literally will just have a barrier separating us. But then, of course, it's not just only the infrastructure alone. We'll need also government to empower us with HRH and also the equipment, commodities. Nothing is going to happen on its own. You know, our house has 6 pillars, And if we do not have two pillars standing or one pillar standing, it will be lopsided. It will not happen, and it affects the indicator that you're asking about. Thanks.
Good afternoon. I hope you can hear me. My name is Priscilla Nganga. I'm a pediatrician and a neonatologist. Thank you to the panel and all the speakers. You guys have highlighted thematic areas and all updates, and your data is well presented. We are really grateful. Dr. Salim, thank you so much. So just maybe a point of addition, as you have highlighted some of the important areas in terms of family-centered care, which is what we are heading towards, but mainly an aspect of child survival. I think we are moving even a step further towards beyond child survival. Now we are also talking about thriving children, so that we are prioritizing their, we are optimizing and prioritizing their thriving even in society. For the presenter who presented from, I believe from Marsabit, maybe you can just highlight some of the, I don't know, it's my first time hearing about the calibrated goals count commodity that you are using. Is it readily available? And then second, among some of the, one of your exclusion criteria, you talked about excluding preterms, moms who delivered preterms who are less than 28 weeks. I'm not sure why, and yet in your results, I saw that the teenage girl, as we know, she's usually at higher risk of getting preterm deliveries. Dr. Abed, your presentation was great. Just to give you a follow-up, some of the triplets that we delivered, the mom who had non-Hodgkin's, babies were premature but doing great. So that's a good feedback. And the lady who also unfortunately succumbed from CA breast also delivered a preterm, baby is doing great. And here is a very tall pediatrician. Thank you.
So thank you for the question. The first question about the calibrated drips was more of the PPH study that was done in Wajir. But if I can just answer it still, the PPH drips are readily available. Actually, in most of the Nairobi County hospitals, they're still being used. I'm not sure about KUTT. Yeah, KEMSA is actually supplying it. We have the disposable and the reusable ones that can be reused up to 3 times. About the second question, the exclusion criteria of 28 weeks of gestation, we excluded the viability. We used the viability cutoff for that was being used in Kenya, but the preterm deliveries were still being captured. So not 28 weeks, but less than 36 weeks to 28 to 36 weeks of gestation. Thank you.
Okay, thank you. Mine is short to Abed. You said that chemo is safe after the first trimester. My question is about staff working in oncology, both at oncology pharmacy mixing chemo and oncology nurses administering chemo. I think here the standard has been, if you're planning to get pregnant or you're pregnant, then you cannot work in oncology. So maybe you can highlight that and talk to your staff at oncology.
Thank you very much, Dr. Maina. Dr. Maina, actually, she's the head of pharmacy. So that unit of oncology pharmacy, it is, I'm the head of oncology, but still we are managing it together. I think he's the best person to answer that question to himself. Because he already knows the answer, but he just wants to boil my blood. Thank you so much, Dr. Priscilla. So mnaona ile data yangu haikuwa jaba. So mmeona my data. Dr. Priscilla amesema nini? They are doing well. We have even had preterms. So that's why I told you, nimerush hiyo kitu yangu. I didn't have enough time to put everything together. But she's just showing us the power of multidisciplinary team. With the oncologists, we give the chemo. Of course, it's a big team. We gave, then after that, they went to surgery to the obs-gyn team. Then after that, our neonatologist was involved. So it is a multidisciplinary team. So usually, we don't recommend like these pregnant women to be in the chemo part and everything, but it is generally safe, especially after the first trimester. It just applies the same like it applies to pregnant women. We don't want them to be exposed in case of any accident. However, our chemo mixing room, our chemo administration area, I think it is one of the best in the country. They have negative pressure, so they can take away any toxicities available and exposure air and everything in the oncology pharmacy and also in the chemo giving room. So it is generally safe, but we don't recommend anyone who is pregnant to be working in the oncology area, especially the chemo part in the first trimester. So it still applies. Thank you.
So good afternoon. So thank you very much. My name is Robert. I'm a nutritionist. I have a comment, not a question. I feel the role of nutritionist has been left out, and I'm a bit jealous. Yes, because poor maternal nutrition during pregnancy will have a negative effect on the neonate and also on the mother. Do we have lactational experts? Because I know mother can attest, when they give birth, they have challenges even breastfeeding. Sometimes even attaching this baby to the breast becomes a problem. So nutrition is very important. I know you have achieved better breastfeeding rates. According to KDHS, the last one was in 2022. The breastfeeding rate was at 61. But again, this is still low. So we should emphasize on breastfeeding. And again, we have lactation experts in Ewene, yeah, so that they can follow up mothers. We have issues of cracked nipples, yeah. Mothers are not able to breastfeed. Are these mothers feeding adequately? So yes, it's a good thing, and I have enjoyed the session, but I feel the role of nutrition has been left out. Thank you.
Thank you. Before they answer, in my presentation, what anijitete, nutritionist was there. Maybe tea break was a bit heavy. But, you know, in as much as we, Dr. Todi ametumulika in the other spotlight, Mama Lucy is actually becoming, or has probably become, one of the centers of excellence in management of malnutrition. And this is regional WHO recognized. And I'm championing that, and one of the closest people I'm working with is the nutritionists. Now, over to you is that the urge should come from both sides. One of the things, and Dr. Priscilla will agree with this, is we are struggling most of the times with postnatal babies due to lactation. And you can actually name, you know, how many conditions are attributed to lack of breastfeeding. So we have not left you out, maybe in the presentation, but in practice, you are an extremely vital member for us. Sasa wacha wajiteteo.
Thank you very much for highlighting the role of nutritionists. I know we understand the role of nutritionists. Maybe it has been not very well captured in the presentations, but I'd like to reiterate that especially in our Department of Obstetrics and Gynecology, we work a lot with nutritionists. And we would also want to throw the ball back at you, so that for you nutritionists, you also need to be proactive. You can also be visiting our postnatal wards, offer the health talks to the mothers, breastfeeding support. Like in my former station, we used to have a nutritionist do a ward round every morning to the postnatal women, so that she's able to capture who is not breastfeeding, who is dehydrated, who is what, you know, the initiative from the nutritionist side. We'd also like to encourage you to visit our antenatal clinics, and maybe during the waiting time, you can offer health talks, encourage the mothers on what to eat and how to nourish themselves during the critical times of pregnancy. I'd also like to highlight that, like for the oncologists, they work very closely with nutrition, because of the high nutritional demands for their specific patients. And one of their stops is once they receive a patient has to be seen by the nutritionist before the treatment progresses.
Good afternoon. My name is Masikaiga. I work in NICU department. Thank you everyone for the presentation. It was such a lovely time being here. My question goes to Dr. Abed. The last patient, okay, a patient we received, I was just wondering, could termination of the pregnancy would have been considered early before when the mother came in with a breast lump? Will it have saved the mother because we ended up losing the mother? And well, very well knowing breast cancer is a very progressive cancer, especially when you're pregnant.
Thank you so much. That's a double-edged sword. I don't even know if I'm supposed to respond or not. Frankly speaking, usually what matters to any doctor is to ensure you don't want to lose the life you're already having, because you don't know about the other side. Like the baby is already inside there, you don't know whether they have to come. But preference is usually given to the mother at any instance, because this is already a life you don't want to lose. So there's no one size fits all. So each patient is treated unique. And we know that like breast cancer is not one disease, a group of disease. I think this was one of the most difficult patients, which I've never forgiven myself, because this patient did not have a particular diagnosis. Even biopsy had not been done when presented to us, but we can see it's breast cancer. He came in a way already having some breathing difficulties. So it was very difficult for me asking myself. I was ready to give chemo and I was ready to take it. But in the MDT, I was told, no, stop it. So I could have done it as an individual doctor, but usually multidisciplinary decision take precedent when it comes to this decision, because if anything goes wrong, I'm on my own. So sometimes we have to agree with the team, because we want to protect ourselves, we want to protect even the mother and the child. So everything must be discussed multidisciplinary. For this particular patient, MDT, I was told not to give treatment. And this is the outcome, because by guidelines, we are not supposed to treat any cancer, any patient, or label any patient has cancer without a confirmation diagnosis. This is the international guidelines. So I think this is what happened to this patient.
Thank you very much. I think we'll close the questions from here. I don't want next time you guys see my name on the program, say, will make us not have lunch. Very quickly, 30 seconds parting shots to all our speakers and presenters. Please, we can start with Sister Mukai.
Thank you very much for the opportunity once again. Just a short one. Let's always prioritize mothers. Thank you.
Thank you as well. My parting shot is let's be champions of advocating for decreasing teenage pregnancies and averting them.
Thank you all. And my departing shot is that we should really use these objective blood loss measuring drips, because it's going to really help us prevent PPH. And as we have noted in all the presentation today which were given, maternal mortality, highest cause of maternal mortality was PPH. And one of the best way we can prevent is using those objective drips. And if you want to know how to use them perfectly, is just go and read something called the Emotive Bundle, which were also found, which were our pioneers in that is Professor Kutrrh, Professor Osoti, and Dr. Gwako. They worked on that. And once you read that, you will know exactly how to use it. And it has proved that it's reducing PPH by 60%. So it's a proved thing. So kindly let's use that.
Thank you for being with us today. And my parting shot is that a pregnant woman is a responsibility for all of us at community level, even at our workplaces, even at family level, everywhere. When you see a pregnant woman, ask yourself how you can support her better. Sometimes just striking a conversation and encouraging them to come to KU and they will get good care. And also when you see them along the corridors, ask them if they've been helped. Help them to reach us early without the bureaucracies. And we will have healthy babies and healthy mothers. Thank you.
Mimi nitasema na Jeng, kama wewe ni mwanaume na uko kwa hii base, hiyo mambo ya kuwekelea ball ni kama umekelea keki kwa oven alafu unapotea miezi 9. unaonekana siku ya mwisho, siku ya kutetea bili ya SHA. Muache. Mkuje clinic, mlete mademu wenyu, mabibi zenyu, ambia bwanako alete sistako kwa hospitali. Achangamke 8 antenatal visits akayapo bumper, aulize maswali, ndio pia dakika ya mwisho pia mwenye kwa birth plan yuko. Si inafika saa ya CS alafu mzee anasema mimi nimekataa. Jumamangu Homa Bay amekataa. Nafanya kazi yetu inakuwa ngumu. Kwa hivyo mkam clinic ndio to make decisions pamoja. Wazi.
Sasa mimi sijui Sheng, nitaongea kwa Kiswahili. Mimi langu ni kuambia kwamba kansa inatibika wakati una mwanamke ana mimba. Tafadhali msitoe mimba. Waacheni wanawake zenu washike mimba wakiwa na kansa na watatibika tu. Asanteni.
Thank you. I would just still reiterate that disasters happen every second. Let's be prepared. Thank you.
Sema conference tunayo hatuna. Okay. The advantage of having the mic is I can give 10 parting shots. Yeah. Mtadu, si lunch mi ndio nawazuia. No, mine is simply just two things. One is that let's stop dividing mothers or separating mothers from babies. I'm saying this with all sincerity in the sense that not to blame anyone, but if you are a facility that is delivering a mother and you don't know how to take care of the newborn, you have no business operating that facility. Please talk to your village elders, your CCs, whoever it is. Every facility that is delivering should be prepared for any outcome. And lastly, children, babies, adolescents are dying, not because of the health systems or because of the medical care, it's because we have not made a conscious decision that every child counts. Thank you. It's been an honor being your co-chair for this session. Enjoy your lunch.
Thank you so much. A group photo for our speakers. So from here, we are going to go for our lunch. Is 30 minutes enough? 30 minutes. Tuko sawa nayo? Aya. When we're coming back, we are going to break out like into two groups. One group will come back here, the other group, the room immediately when you are going for lunch on your right. So look at the session which you want to attend. We are going to break out. We are going to put a few sessions from yesterday and a few today. Then we complete our conference. We'll come back at the end here to close because you guys had amazing abstracts. We want to see who was the best based on your judgment. Asanteni.
Good afternoon. Good afternoon, ladies and gentlemen. I propose we settle down. We start the afternoon session. I'm hoping people are coming soon. Ama iko sawa? We need more. Dr. Harish wants his presentation to be heard by more. If somebody can call those who are outside kindly so that we start. I would like to call the meeting to order. I think we have a good quorum. We can start. Good afternoon, everyone. My name's Dr. Anthony Kamau. I'm the Director of Clinical Services. I'm also a passionate advocate of AI and digital health. So I would like to welcome you for the afternoon session. I know we are combining these two sessions so that initially there were to be breakout sessions. So we have integrated healthcare, which is holistic approach across specialties, innovation and AI as the other session. So I'll be working with my co-facilitators on this, chairing these sessions. That is Ian Chanzu. Please stand up. Say hi. Dr. Edward Maina. Thank you. Kosa. Yes, Mr. Bernard Kutrrh, thank you. So without further ado, we would like to start with the first presentation, and that is from Dr. Harish Nagaraj. Unfortunately, because of time, we didn't get the bios. I would have loved to read Daktari's bio. He's one of the leaders in this institution, very devoted and very committed. So Daktari, your presentation is implementing lutetium-177 PSMA radioligand therapy in a resource-limited setting. Challenges and early clinical experience from Kenya. Karibu sana, Daktari. You have 10 minutes. We'll stick to time. Thank you.
Thank you, DCS, and good afternoon all. I think I don't know whether you are fully loaded with glucose. I'm going to take this opportunity to present a bit technical, but not so technical. I've prepared slides in such a way that it caters the mixed audience. So mostly it will be pictures, and I think you will appreciate that. And thanks again for the introduction. Okay, so why is this important? That is lutetium therapy. Because as we all know, prostate cancer is a leading cause of cancer, especially when it comes to men. And then many patients of late present with the advanced stage, that is stage 4. And also access to advanced therapy remains limited in certain geography. And lutetium therapy, of course, the science says that it improves survival and definitely quality of life. So before going there, just a brief milestone on nuclear medicine, how it has been spanned over last 6 years. If you look at 2019, Kenya had just 1 cyclotron and 1 PET. And fast forward 2025, we see 3 cyclotrons and 7 PET scanners. So there's a huge leap in when it comes to nuclear medicine in the region. So we also have some really advanced tracers, and that is also part of why many patients don't go, be it India, South Africa, or any other place for this kind of diagnostic services. Again, when you look at this picture, it reminds us the historic day which we had in January 2022. It marked the first PET scans which was done in the country. In fact, the first in the region for public hospitals. And the same with SPECT. SPECT actually we started a few months earlier, and that was Honorable His Excellency President Uhuru, who had come during the time of installation and then inauguration. So today's topic, why I wanted to bring it here is, people need to know both, we can do 2 things with one target. That is having diagnosis as well as therapeutic approach, and PSA stands out in that. So if you look at this part, the way the diagnosis is, we use a PSMA tracer here, and with the same what we image, we target, we link the radioactive lutetium. So basically the principle is, we are actually targeting the PSMA, that is the receptors on the cancer cells, which gets deposited. What we see is the PSMA, and what we don't see is the lutetium, which just goes, deposits and start destroying the cells. So just a brief for someone to know what is lutetium PSM and how it works. I was explaining in the previous study, this is what happens. You can look at the PSMA receptors, and that is where the both the ligand which goes and get deposited and starts destroying the cells. So that's the main principle. And lutetium, as we all know, it was approved in March 2022, and the indication is very clear. We don't use this lutetium for every other prostate cancer. We use it specifically for patients who have actually progressed with this kind of what we call ARPI. Most of you guys must have heard the drugs as abiraterone and enzalutamide. So people who actually progress on this, and those are the ideal candidates for us to do it. And also sometimes, patients before coming to lutetium, they must have already gotten the chemotherapy that is taxane based. However, the recent research says that there is an advantage of having lutetium before even taxane, for that matter. The usual protocol what we follow at KUTRH is that we give around almost 200 millicuries, and we repeat every 6 weeks. And the limitation, we don't have any limitation, but however the global guideline says that we can go up to 6 doses until it's completely progressing or it has come into remission. So how do we select the patient? As I already mentioned, that histology definitely has to be a metastatic castrate-resistant prostate cancer. Then PSMA positive, that is because the darker areas you see, that means the receptors are there. So that is where now the patient selection criteria comes into play. Then also the marrow function and renal function is very important, because whatever the doses we give, it has to be also flushed out. If the kidneys are not working well, that means the radiation is going to remain within the body and then start destroying the normal cells. So these are the main questions patients ask to me when they come. What will happen to me after therapy, and am I going to be cured forever? So the answer is there is no complete cure, but definitely there is survival benefit and also the quality of life. So this is one of our patient, our own patient here, and that's what happens during the day of procedure. We usually talk to the patient and the family, because radiation safety also is a key factor here, because once we give the dosage, the patient goes to their homes, respective home, and we have to make sure that the other individuals are not radiated unnecessarily. So how do we go about this business? Is we are going to start with the intravenous infusion of saline, and as the dose was mentioned earlier, we are going to give almost 200 millicuries of lutetium, and the patient is only discharged after reaching a safe level of radiation, that is less than 25 microsieverts per hour at a distance of 1 meter. So usually this takes about 4 hours from the time of injecting lutetium. So what we tell the patients is, patient need to avoid very close contact, especially when it comes to children and pregnant women. It is a complete no. At least for other adults, when they're nearby, they can be at the space of 1 meter, and the cutoff value we give is almost 6 hours. They can be they can spend the time together with 6 hours, but again, no close contact. So for the lutetium to be very successful, we need multiple things. That is now to have a framework done properly. That could be it regulatory approvals such as Kutrrh, NCI, and KMPDC. And we need infrastructure basically, because we deal with radiation. So we have to make sure that what we are doing is safe for the patient, relatives, public, and also our staff. So that is very important. And also for radiopharmacy, quality is very important, because whatever we are injecting, actually it is now, we have to make sure it is completely sterile, and also it is free of any impurities. And training is very important key part, because this is something that not many institutions do. And when you are dealing with such a high level precision treatment, you have to make sure that your staffs are well trained. And then, of course, patient selection, which I was mentioning earlier, we have to know how to select the patient. And definitely,
when it comes to patient selection here, the MDT, the multidisciplinary team, plays a huge role, and we do discuss most of the cases, because take an example of our pilot project which we did with IAEA. We had almost about 26 applicants for the project, and only 2 qualified. So that is how it was. It was very kind of sophisticated, as well as we made sure that the patient who receives the treatment actually has scored the highest points for when it comes to eligibility criteria. So what are the current challenges we face as a country and the region? That's mainly when it comes to funding, because one lutetium dose itself will cost almost up to 1.1 million. That is not affordable for many people. And radioisotopes logistics, because these are actually produced overseas and has to be shipped to our country. So that's also a big challenge, because we depend solely on those companies which produce the radiopharmaceuticals. And infrastructure, which I already talked, workforce training as well, and patient affordability. Because if you look at most of our oncology service, SHA covers the complete diagnostic PET CT for our integrated molecular imaging center. Whereas when it comes to therapy, radioligand therapy, so far we have not gotten any support, and that is why we encourage, like, if at least government gives us a bit of support in this in journey, especially for the stage 4 cancer patients, this would go a long way. So just the roadmap, this is one of the important slides you need to just memorize, how it starts and how it actually goes. So once we have an oncology referral to nuclear medicine department, we confirm the eligibility. And once we are okay with the patients have agreed to the treatment now, the dose delivery happens within 2 weeks. It has to be shipped. Fast dosage has been given. Once we give the dose, we also make sure that patient is doing well. We do some baseline test and also follow-up blood workup. If the patient is doing very well, then we space it at 6 weeks, then we give the second dose. Now after six weeks of second dose is when now we have to repeat a PSMA PET CT, just to make sure that the disease part has disappeared, or there's some new findings, or the patient is just stable. So depending on these findings is when now the next course of treatment happens. So I would like to just share the local experience what we had. This is one of our patient who was given consent and who was part of the project. When he presented, he could barely move, and his PSA was almost around 400 plus, and literally he had given up his hopes, because the disease was quite extensive, especially when it comes to the pelvic metastatic burden, and the patient was severely affected in terms of the morbidity. So looking at, I know most of you can't read this, so whatever I can give a hint. So whatever you're seeing, the blackish thing here is the disease basically. So this was the staging time, and on the topmost area we could see some bone uptake. That is why we staged it as stage 4 bone metastasis. When it comes to, we did actually another PET scan, and it had shown some disease burden. So whatever you are seeing in the chest area had disappeared completely. Whereas if you compare these two, the disease had increased in the pelvic region. Okay? And then fast forward this year in March, after second cycle, we could see that there's complete disappearance of any disease, which we can see. So we actually confirmed that there was no PSMA with disease. And same here, it can be seen again. Just because of the matter of time, like I just wanted to show the key finding here. Even the bone metastasis, what we had seen earlier, had actually reduced in intensity. And if you look at the last scan, it had completely changed. So that means the patient had gone into remission completely. So we also believe in seeing as well as the lab report. Lab report can say that from the PSA of 400 plus, it jumped to 20 something, and then finally it went to 3. That is almost 0. So this is my second last slide. I just wanted to show that the patient who could barely walk that time, now he started walking, and the smile was back. So I think the take-home message here is that lutetium should not be just a treatment for the rich nations. It can also be implemented successfully in lower middle income countries. And planning, partnership and training are the key here. And then early Kenyan experience demonstrate feasibility. Thank you so much.
Thank you, Dr. Harish. I think that's a walking miracle, if you ask me. Modern day miracles do still happen. And thank you, Dr. Harish, for pursuing that line. I think it has benefited this gentleman, but also potential to to benefit more Kenyans going forward. He may not have mentioned the cost. There's a cost to it, but I think you can see him, you may attend. So the next presentation is by Dr. Kimondo. Dr. Kimondo, karibu. Dr. Kimondo's presentation was supposed to have been done yesterday. So he's talking about the quality of biopsies and the histological tissue for cancer diagnosis. Doctor, you have 10 minutes. Thank you, karibu.
Thank you, Dr. Kamau. Thank you. So I'll just take you briefly through one of the quality issues when dealing with lab biopsies, and in keeping with our theme of care without gaps. So I titled this presentation as our pathology consult. So why do we do biopsies consultations? There are a couple of reasons, but most of the time it's to confirm a suspected diagnosis, to start treatment for oncology cases, infectious diseases, targeted therapy, immunohistochemistry, so that we can give and also give the surgeons and the oncologists and radio oncologists surgical margins clearance. So in the lab, we have three main processes. We have the pre-analytical processes, the analytical processes, and the post-analytical processes. So for the purpose of this discussion, we'll tackle the pre-analytical processes, which impact the quality of the sample and the quality of your results as well. The analytical is just the processes that happen in the lab. So the processing of the tissue up to the slide and reporting. And the post-analytical is now posting the results and sharing and communicating the results to the clinician. So pre-analytical processes are very critical, and I'm glad to see surgical residents. Request form, correct labeling of the sample, the tissue type, the procedure that was conducted, the correct fixative, which we normally use is 10% buffered formalin, and the correct containers. I'll show up an image of what we require for these specimens. So the request form, very critical. This helps to identify the patient and the sample. And this will help in avoiding giving the wrong report to the wrong patient, which can lead to wrong treatment. The type of specimen and procedure is very critical. It helps us in analysis and in coming up with a diagnosis. Comprehensive clinical and radiological history. This is a major challenge for diagnostics. I'm sure even radiology have the same challenge, where we just get a request form with brain biopsy, no history, no, so maybe the patient could have had a cervical squamous cell carcinoma with Mets, but no one has given that history. So we end up wasting so much time on a particular case. The hospital number, the serial number, the contacts and signature of the clinician we contact the clinicians when we are stuck with a case, and so it's important for that to be in the request form. And then any previous histopathology tests that have been performed on the patient to help us maybe correlate with the previous reports. So the fixatives, we have quite a number of fixatives, but the one that is most used and has been studied and is less toxic is 10% buffered formalin. It's not conc, it has to be buffered and it should be 10%. We have other fixatives, you have Zenka, Canoe, and 4% commercial paraformaldehyde, which is usually used for renal biopsies in electron microscopy. These other ones, Zenka and Boeing, some have mercury and so are toxic, so we no longer use them, but they're very important for testicular biopsies, getting a diagnosis of the diseases in the testis, because formalin affects the morphology of the testis. So containers, this is a big challenge in our setup, where people put biopsies in these epinephrine, containers, the epinephrine containers or medication containers, which is not recommended because the tissue has to be put in an open container with the fixative, and the specimen should be well fixed, so it should be surrounded by the fixative. When it's floating, the sample is floating, it should be covered with gauze, and if it's a heavy specimen, it should have gauze at the base to allow formalin percolation to the tissue. So this is one of the challenges that we face, where we get samples put in this jerry can, I think for soap, and so someone decides to cut it and put a specimen inside. This is not acceptable because you can see the sample is already will not be fixed. It will configure to the orientation of this hard container. So we recommend this well labeled and labeled even in terms of the volume. Remember, we said a specimen should have 10 times the volume of the tissue should be the formalin or the fixative that is going to be used. So this is what we recommend, and this is what we have in KU. So we avoid this. This also can cause leakages, which formalin is toxic. So any leak to the staff in the lab or even in the hospital can be dangerous. So we need to have these nice fixed, fitted containers. Surgical handling. Again, use of forceps. You need any manipulation of the tissue affects the quality of the slide, the quality of the morphology, and so it's very important that we take care of use of electrocautery because it causes a lot of artifacts in interpretation, especially in the prostate chips and all those other procedures that we use cautery. Cervical biopsies as well, which affect how we interpret and looking out for pre-malignant lesions. A very important one is cold ischemic time. So most of what happens in surgery is that the surgeon removes the sample and it's supposed to put the sample into a container with the fixative. But most of the times we find the sample is left until the end of all the surgeries that have been conducted, and then we get autolysis or tissue death happening, which affects interpretation of the disease process and also can affect immunohistochemistry and genomic analysis. So we recommend that this cold ischemic time, which is the time the tissue is out of the normal 37-degree Celsius body, directly into into a fixative should be less than 1 hour. And then for the large specimen like the breast, it should be sliced so that formalin can easily percolate the sample. So these are some of the Kutrrh artifacts. This is one. The tissue was damaged because of the forceps. Too much manipulation of the tissue, which again affects, this is a cervical biopsy, so it affects how you interpret, could there be a premalignant lesion here? This is, again, use of Kutrrh, electrocutrrh. These are called Kutrrh artifacts. You can see there is streaming of the nuclei into one direction. Now this can be very difficult to interpret. Is there a high-grade squamous epithelial lesion here, or an adenoma because of these artifacts? So here is in the lower photos here, you can see this is a breast tissue, and you can see that there are areas that are purple and there are some areas that are pale. So these pale areas are tissue that is already, or tumor that is already autolyzed. And so when it comes to immunohistochemistry, it becomes a challenge to interpret this, which we'll show you in the next slide. So this is immunohistochemistry. This is estrogen receptor immunohistochemistry. And you can see that the area that was autolyzed has very poor uptake of the antibody. And so you can call this a false negative. You can call this a false negative. And so you need to make sure, which can affect interpretation and treatment of the patient. So the remedy is to handle the patient, the sample very well, and to make sure that you use the right fixative. The pitfalls: incomplete biodata, incomplete clinical history and imaging. This is very, very critical for diagnosis. We waste a lot of resources, even for patients' resources, trying to figure out the primary of a disease, yet history by itself could have sorted out that. Another issue that we face is splitting of samples. So we find patients, our clinicians splitting a sample into two and sending to different labs. That is not allowed. What we advocate for is, in need of a second opinion, we can give the blocks for the patient, and they can be sent to another lab so that you have a direct correlation. Otherwise, you can have split sample where one is benign and the other one has tumor. So we really, really advocate for that. Another challenge is core biopsies of lymph nodes. We need to be careful with core biopsies of the thyroid, of the lymph node, because some of the times we're not able to make a diagnosis without the capsule of the thyroid and also of the lymph node. So that is my take home, that we need to fill the request form, and the containers should be the right ones with the correct fixative, correct specimen type, and correct specimen handling. Thank you.
Thank you, Dr. Kimondo. Dr. Kimondo is the HOD, actually the pioneer HOD in the lab, KUTRRH. When I reported to the hospital, we reported with him just about the same time. So really does a good job. Thank you, Doc. The third presentation this afternoon will be from Dr. David Wanje. Dr. Wanje, I thought I saw you. Oh yes, there you are. Please come up. You'll be talking about, it's a long topic. I'll allow you to tell us the topic as you make your presentation, but again, we really appreciate the work that the IMIC team, or the Integrated Molecular Imaging Center, is doing. Dr. Wanje is a radiopharmacist, deals with radiopharmaceuticals. I believe he was the first radiopharmacist in Kenya. Is that correct, Daktari? Yes. Karibu sana. Thank you.
Habari zenu. My name is Dr. David Wanje. I am a radio pharmacist at IMIC. I am currently heading the radio pharmacy. So the topic is very long, but the idea is very short. Okay, and this is very nice for us because the impact is very big. It's very significant. Okay. Okay, can you see very well? Okay, because I'm having challenges seeing. Okay, we know cancer is a big deal, so everybody has said that already. And the most common tracer is FDG for diagnosing cancer. And at the IMIC, we are doing manufacturing for FDG and PSME. So, but today is about FDG. So right there, you can see images is the process of manufacturing FDG. So we are not talking so much about it. That's just for your information now. And when you're manufacturing, there's something called product yield. Product yield is very important because what is product yield? It's a ratio or a percent of what you started with. Okay, what you got in the end divided by what you started with. Okay, so if your manufacturing is very good, you want to get high yields. Okay, what does it mean high yields? You can serve more people, and it means you can give services to probably all the people that need the service that day. This is the importance of the yield. So, okay. Nice. So we have had a problem since installation of the equipment, and the problem was about low yield. The specification is that we should be getting a yield of above 78%, but we have always been getting much less. Like this is a report for 2023, and the yield you can see is 58%. This is a big problem for us. So the yields can come from many places, for sure. But you know, as you have seen from the first image, there's a link between the cyclotron and the synthesizer. If you remember the image. Now that link is of a tube. The tube is made of plastic. So it is very important we see what is the significance of that plastic tube to the yield. So it was a problem that we didn't think about until now. We sat as a team and we mapped out the entire production process and thought about where possibly could we be getting the impurities. And one of us suggested that how about we look at the chemistry of the tubes. Then the explanation or the hypothesis was if you look at the tubes made of plastic, and the plastic is PTFE, that is Teflon. Teflon has a lot of fluoride, and when we make FDG, the F is fluoride. So what comes from the cyclotron is fluorine, but it's passing through a tube which has a lot of fluorine on the surface. So could that be the source of impurity that is causing us a low yield? So how does the Teflon generate impurities? So it generates impurities when that bond, the carbon-fluorine bond, is hit by radiation. That bond can break. If it can break, then the fluorine is free, and it is in the form of fluoride. You can see. Then the red F is the one from the cyclotron, so it's radioactive. But then on the tube, there's the black F. It means it's the F which is not radioactive. So we have the hot F from the cyclotron mixing with the cold F from the tube, and all of them are going to the reaction mixture. But you see, our reaction cannot distinguish between the cold F and the hot F. So all of them will compete for the precursor to form FDG. Okay, so what is the solution then? One, we used to replace the tubes every month. And if you go online, you can check what is the cost of a tube. The cost of the tube is 1,500 USD. Now, so that is very high. But if we just clean that tube every day before production, how long can we take before we replace the tube? That is 6 months. And what are we using to clean the tube? 2 ml of water for injections. So that was the proposition that was made. So we said, what are we going to do? We are going to test it. We are not going just to implement it. We're going to test it first. So we tested it. And it's a very good thing because it just takes only 5 minutes additional production time. And it is easy to integrate into routine production because you can see this is the production protocol. And you can see it can easily be integrated in the steps in the production so that you don't need to take physically to go to the equipment and do something extra from the protocol. So what did we find after we tested it? Initially, our yields were 60%, 61%, but after implementing that very easy step, we are getting average of 83%. Now you give a machine 7 Kutrrh, and you have a 20% increase in the yield. What does that mean? That is 1.4 Kutrrh extra. Now, what can you do with 1.4 Kutrrh? So, and initially when we were implementing, there was a bit of inconsistency. That's why you can see the graph is like that. But right now it's a bit consistent. So what is the impact? Increased capacity for sure, reduced waste, and now initially we could only serve 30 patients at our site and 1 extra facility we are selling to. But now we are serving between, we are serving between 45 and 50 patients. Apart from that, we are selling to 4 additional facilities. This is a simple thing, but with a very huge impact. That's why I think it's important to talk about it. Okay. So is my time up? That's it. That's probably the last slide. This is our team. You see, we usually go out on some occasions just to take pizza after a very good day at work. Then this is where we work. And thank you, all of you.
I think you have to agree with me that after such hard math topics, you need such a break. These are some of the most brilliant people that we've had in this country, we have in this country. So typically they tend to be the top of the class to go and do radiopharmaceuticals. So thank you, Daktari, and the good work that you're doing, even for this institution. We'll change gears a bit to artificial intelligence. So I would like to welcome Engineer Anne Githaiga. She's one of our biomedical engineers in this hospital. She's talking about advancing health system strengthening through artificial intelligence, digital health, innovation, and the role of biomedical engineering. Thank you and karibu.
Good evening. As you've heard, Anne Githaiga, I'm a biomedical engineer. And my topic today is about advancing health system through the strengthening of AI.
And the problem statement, though it's not in the slides, it's because we find like in KUTRH as a case study, our booking time and waiting time for our patient is very, very long. And I have friends, family who can book a clinic, and they will wait for maybe 2 months, come see the doctor, and that consultation again, they will be told come after 2 months and come now with the images. So the waiting time before treatment, it's close to 6 months. So, sorry. So why this matters? It's because we'll have better patient outcomes. And all these are kind of interrelated because reduced waiting time also will definitely make the patients be treated efficiently, and we'll have better patient outcome, and also will strengthen the universal health coverage and better utilization of medical resources. So global achievement with the AI and digital health, the WHO strategy between the year 2020 and 2025, they have really promoted the interoperability of the medical devices, data governance, and equitable access to digital health technology. And examples are Mayo Clinic, they have AI-assisted radiology and predictive analytics. Then in UK, they have the AI for cancer screening and digital patient records. European Union have a cross-border digital health records and digital health certification framework. Regionally in Rwanda, they have really excelled in one of the items that they have really outshone so many countries. They use drone for rapid delivery of blood and medical supplies for the remote facilities. And in South Africa, they have AI-supported TB and radiology screening, telemedicine services, and digital pathology initiatives. So in Kenya, our ecosystem for the AI and digital health, some of the wins that we have managed to get, we have EMR, HMIS, RIS, and PACS, telemedicine, AI, IoT, and specifically Internet of Medical Things and mobile health, AI-assisted diagnostics, smart ICU, wearable devices, and LIS, big data analytics, and medical devices, smart medical devices. So now in various hospitals, out of that ecosystem, some of the hospitals that have managed to get that, starting with KUTRH, we've managed to get digital imaging, I would say a bit of telemedicine, then EMR integration and the doctor's mobile app. KNH the same system, PACS, RIS, and telemedicine. MTRH the same. County hospitals are coming up very well, actually, some are using the EMR and Taifa Care that was recently launched. Muranga County are doing very, very well in telemedicine. They have a platform where the specialists connect with the patient easily in the remote areas. Then Penda Health, they use an AI tool called AI Consult for clinical decision support. It's a support tool. Then Aga Khan, they have an AI tool as well called Afya Njema from the Swahili word Afya Njema. As well, it's an AI tool that helps doctors to quickly make decisions. And it also has it's in English and Swahili, so it's very easy for doctors to use to get their management. Avenue Hospital and some of the public hospital like Jaramogi, they use proximity telemedicine. This is majorly used in theaters. They have cameras in theater, and all the multidisciplinary surgeons, they connect easily with this proximity, and the intelligence of these cameras cannot allow you to see the patient. It actually blurs the patient's image. So it only connects the surgeons and also helps with the training of the junior doctors and also the students. And Gertrude Hospital, they use Dr. Smart. This is where a nurse in a remote area can connect a patient on a tool they use, and the doctors and the specialists are able to hear and see real time. Then some of other AI tools we have, and I'm sure most of you even have in your phone, especially my Dawa is very popular. We have Afya AI, Sasa Doctor, Zuri Health, and Access Africa. So where this AI can be applied in healthcare, it can be majorly it's in radiology. That's the common one we know for MR, CT, mammo, and X-ray interpretation. And this is very good because a patient does not need to be taken an image and be told to go home, then wait for a report. These are real time. They can just go home with their reports. And the good thing is most of these are machine learning, where the systems are fed with the patterns. So the accuracy is high compared to the normal AI we have like ChatGPT, where the ChatGPT, I'm not saying it's not okay, but the machine learning is better because it gets the algorithm and you get the patterns. So the report you'll get is close to what a human being can give. Then the critical care also, they have AI tools that get the early sepsis prediction, the deterioration of patients in ICU. They can give alerts or predict. And they have also patient monitors that get that for the cardiac patients. And theater optimization, like that Proximi telemedicine also, it's the same. And stroke detection and others. Also in lab, they can get the digital pathology and AI-assisted microscopy, and this is not limited to these. There are lots. Then in administration, we can get patient scheduling, resource allocation, appointment management, chat box, especially maternal, and voice documentation. So biomedical engineering plays a role in all this, definitely in collaboration with ICT and clinicians to achieve this. And some of the roles are the medical equipment integration and networking, preventive maintenance, and smart CCMs. These are systems that are used. We don't have them here at KUTRH, but these are systems that can even predict an equipment will break down and alert when the service is due. Then other roles are clinical technology management and managing equipment life cycle, medical device interoperability, clinical engineering, cybersecurity support, and I'm happy ICT recently held this training on cybersecurity, and also procurement of technology and others. So the challenges that we face, and maybe the reason why we've not managed to achieve all that and we've not caught up with technology like others, is the high cost of implementation, cybersecurity threats, a lack of interoperability, skills shortage, because even in our curriculum, it's not so much, and we are learning on job and doing short courses. Then we have aging medical equipment, and we are happy that in our hospital we have very modern equipment, so most of them we are able to connect them, and limited AI governance, data privacy. Those are some of the future opportunities that we can have. If the management support us, we can achieve all this. We can have remote ICU monitoring. We can have predictive maintenance on the system. And we can also have a hospital with in cloud. Recommendation, it's almost the same. we can have, definitely I'll start with ourselves expanding and strengthening biomedical engineering workforce, and also improve cybersecurity for medical devices in collaboration with ICT, and also foster clinician engineering collaboration. Conclusion, KUTRRH, we've done very well. We are now, most of things we are paperless, and we are priding ourselves in that, but we are still not yet there. We can get more and achieve more. And also biomedical engineering is not only limited to repairing equipment. We are also able to do all that technology and achieve a wonderful world. Thank you.
Thank you, Engineer, for that insightful presentation on AI. And as we proceed on, I would want us to congratulate my co-chair, Dr. Kamau, who is joining another meeting. So let's put up a clap for Director. Thank you so much. Our next presenter is Rorin. She will be taking us through impact of strategic partnerships on healthcare policy, implementation, and reform. As she comes, Eric Otieno in the house. Yes, you will come after Rorin, and after Eric, we'll have Jackson. Yes, so we'll come in that order. Thank you. And please keep time, 10 minutes.
Thank you. Good afternoon. My name is Lorraine Birir, and today I am in partnerships, linkages, and resource mobilization, that is at KUTRRH, but also I am a PhD student. And today I'm going to present an empirical study on impact of strategic partnerships on healthcare policy implementation and reforms. Sorry, kindly give me the pointer. Sorry, it's here. So, all of us know that healthcare systems face increasing challenges in terms of financing, service delivery, governance, and equitable access. So strategic partnerships come in to support this. And these collaborations bring together the government sector, the private sector, the development partners, people in academia, and also our communities. And as much as these partnerships improve our healthcare service delivery, there is contradicting evidence. Some people say partnerships are good, some people say partnerships are not so good. So in this study, I was able to do 26 studies, and I was able to do 7 studies globally, 8 studies in the African region, and 11 Kenyan studies. So I was concentrating more on the Kenyan studies because I wanted to understand our local context so that we see what are these that affect the local partnerships and how can we use the studies that have been done to then be able to solve the gaps that have been identified by these studies. On global evidence, there is actually evidence that our partnerships have been able to improve service delivery in terms of improving access. There is strengthening of healthcare financing. There is better stakeholder collaboration and enhanced service delivery. So like when you look, I was able to look at studies from the UK, from China, from India, and United States. And most of them actually show that there is actually evidence that there is improvement in service delivery where collaborations happen. And when you look at the Africa evidence. I was able to look at studies from Uganda, Rwanda, Ghana, South Africa, Ethiopia, Tanzania, Nigeria, and Zambia. And all of them show actually that there is improved service delivery. There is more resources that are mobilized through partnerships, hence improved financing in the healthcare sector. There is more collaboration among partners, and there is policy and system strengthening because partners come in to improve and actually contribute to policies, but also challenges remain. We have challenges in Africa on sustainability and continuity of funding, where by the time a partner exits, the project exits because there were no sustainability measures put in place. So as we start a project, but then the project ends midway, or once that project cycle ends, there is no continuity of service because the partner has pulled out. In the African context, also there was improved service delivery. So there was, and also improved resource mobilization, and there was stakeholder collaboration, and there was influence in terms of policy and system strengthening. But the challenges, most of the scholars have cited sustainability of funding being one of the challenges, but one of the things that stood out for the Kenyan context is bureaucracy in terms of onboarding partnerships. There is a lot of bureaucracy, and it stalls partnerships, and a lot of interests that that make partnerships less effective. So that is just synthesis of findings. So key outcomes: there was improved access to healthcare, increased resource mobilization, enhanced multi-sector collaboration, support for policy implementation, but challenges persist in sustainability, consistent funding, and government coordination. And what are some of the key enablers for success? One is strong governance. Governance came out very strongly. Of all the studies that I looked at, governance kept coming up. That where there is good governance, there is likely to be greater partnerships and greater impact. And then there is need for clear role, trust, and mutual collaboration. There is need for data-driven decision-making and monitoring, community engagement, and sustainable financing and resource alignment, so that a partner is not coming in to do that which you have not prioritized, but they are doing that which is their priority. So then there is need for partner alignment. Then there are also so much contradiction in the literature, but I'm not going to go through that, but I'll just cite a few. Like most of the African studies actually showed that there was PPPs improve resources, but some say that PPPs may increase long-term fiscal obligations and reduce sustainability. So there is contradicting evidence, there is contradicting results among the scholars who have done researches in partnerships. And in terms of policy implementation, actually some scholars find that partnerships strengthen policy. But then some report that partnerships sometimes create parallel systems that fragment policy implementation. And some say that there was reported inadequate stakeholder engagement, like in the Linda Mama program. The Wamalwa and Atela did a study on the Linda Mama program, and they found that there was very minimal stakeholder engagement. So it means that the collaborators are the ones that did more than the stakeholders that were supposed to be implementing the Linda Mama program. So what are some of the research gaps and future priorities? So one of the things is there is need for longitudinal studies. Most of the studies were short-term studies. None of them showed impact. So there is very little that has been done in terms of longitudinal studies. And then also there is need to do the influence of effective governance on partnerships. And then there is need to do, and then also there is need to explore the influence of AI. I realize that most of the studies that have been done in partnerships has not incorporated AI and the impact of the digital space on partnerships. So those are the things that need to be done in terms of the researches that need to be done as far as partnerships is concerned. So what is the implication of this and the way forward? There is need for evidence-based policy making, such that as we are bringing in collaborators, as we are bringing in partners, there is need for evidence even before policy implementation is done. And then there is need to strengthen partnership governance. Because when I looked at most of the studies, places where they have strong governance that support partnerships, partnerships thrived. Places where there was a lot of bureaucracy and weak governance, there were weaker collaborations. And then there is need to mobilize and align resources so that when a partner is coming in, they are feeding into the strategic plan that you already have and not starting a separate program from what you intended to do, so that there is alignment and there is no fragmentation in terms of implementation. And then there is need to leverage on digital and AI information and AI innovation, especially for information sharing. But also, as much as it is important to share information, there is also need to take note of the data protection policies and frameworks that exist, so that we are not sharing information without due process. And then there is need to promote equity and community engagement. And those are my references, and that is the end of my presentation. Thank you so much.
Thank you for trying to keep time. So if you have for questions, just note them down, and then we'll do one session for all the presenters. Next is Eric Otieno Kapis is going to present on design and validation of a deep learning gun for predicting lutetium dose. The rest utatuambia ni nini?
Thank you very much. My name is Kapis Otieno. I'm a medical physicist. How many medical physicists are in this house? Oh, thank you very much. I thought I was the only one around. So today we are going to talk about research that we did recently. So this is about dosimetry in nuclear medicine. I know the topic is a bit jagged with words, but in simple terms, what we are trying to do here is that we came up with a new dosimetry approach, which we are using deep learning. Now, the deep learning architecture that we are using is the generative adversarial network, or we call it GAN. Okay, thank you so much. So essentially, in nuclear medicine, we have what we call both diagnostic and therapeutic nuclear medicine. So this is the use of radiopharmaceuticals. I'm not quite sure if you're able to see the image that we are having here. Okay, it's not lighting. So essentially, I'm talking about the radioligand, that is lutetium-177. I know Dr. Haris has already talked about this. This is one of the new drugs, radiopharmaceutical, that is going to be a huge topic in the future, not only in Kenya, but worldwide. So here I'm talking about the two lutetium ligands that are already approved by the US FDA. So we have lutetium-177.30. Now this one is being used in the treatment of gastroenteropancreatic tumors, or what sometimes we call the neuroendocrine tumors, and is based on what we call PRRT. Then we also have the lutetium PSMA. This has already been talked about by Dr. Harish. This one we use for metastatic castration-resistant prostate cancers. And we are going to see an example. Then for lutetium PSMA, in the year 2025, I think somewhere last year, the US FDA added another approval for it. I'm not able to see. For some more patients, maybe I can be able to read from here. For some more patients that have already been treated with androgen receptor pathway inhibitors, not just the metastatic castration-resistant prostate cancer patient. So this is the radiopharmaceutical. So what we have the radionuclide, which is lutetium-177. It is linked to a targeting molecule, or what you call the tracers. This tracer is targeting the expression in the cancer cell, which in this case we call the target molecule. And we call it somatostatin receptor. Now, when the patient is injected with the lutetium-177, dotatate, then this one goes through the bloodstream, and the radiopharmaceutical will find itself in the cancer cells, and it has a very good response, just the same way Dr. Harish had shown as the one for PSMA 617. So these are just more examples of the ligands based on lutetium-177 that are still on trial. The first two are already approved, as you have already said, but we still have so many more that are undergoing trial. That is why I was saying there's going to be a huge talk. There's going to be a huge advantages of lutetium using various tracers. Now, if you look at the image on the right, you have the A. So that is the image of the patient. That is a diagnostic image of a patient that is based on gallium-68. You can see there is a lot of metastases, and this is advanced case of prostate cancer. There's a lot, the dark areas that you see. Now, after giving the patient the medication that is lutetium-177 labeled with PSMA 617, then after a period of about 1 year, you can see the images we have on the right. Patient ni kama ameoshwa. Ameoshwa hajaoshwa. Anakaa kuosha. You can see there's literally no metastasis that you can see from after the treatment of the patient using lutetium-177 PSMA 617. So it means this drug is going to be very useful, especially in cases where there's no response with other drugs. Okay. So essentially, the reason why I'm here is not to talk about the clinical part of this drug, but is to talk about medical physics. We as medical physicists, we are the most forgotten in the clinical journey, but this is our interest when it comes to the treatment of a patient. We are interested in essentially knowing, quantifying. For example, when you give your patient a given medication, we are the people to quantify what exactly is the dose that the patient is receiving. Because I believe you have the experience of knowing that if you give two patients the same drug, their uptake or the response of the drug will always not be the same. And therefore, it is important to actually quantify what amount of dose this patient is receiving for the various parts of the body. So when you give a patient or when you do a radiation treatment, there's also what we call toxicity. So toxicity is a very important topic because it will determine whether you continue with the treatment or at what point you should stop. So you need a medical physicist to be able to quantify for you, for example, what dose is going to the tumor that you are trying to treat. At the same time, what dose is the organs that trace is receiving. And this is what we do. So we have a formula here, which we call the MIRD formalism. So MIRD stands for medical internal radiation dose. This is a formalism that was created sometimes back in the 60s. It only has two important parts. The first part is the A, which is cumulative activity, which you multiplied by what you call the S value, or a dose factor, the S. Now, the problem is the MIRD formalism is fairly simple formula for determining the dose in a patient. However, we would be more interested in getting more information about the dose of the patient. For example, you just don't need the mean dose. The medical physicists in this house would understand me more, better. You need to get what you call spatial detail in terms of dose. For example, you'd want to know what is the minimum dose, what is the mean dose, what is the maximum. You'd want to see the dose distribution in a space, in a 3D space. Therefore, the simple MIRD formalism is not able to give us what you call the spatial detail. There are other formulations. For example, you can run Monte Carlo simulations. This is extremely accurate, is the best way to do it, but it will take you like a day, maybe a whole week when you are still running Monte Carlo simulations. And therefore, this one cannot be used in clinical settings. So where do we go? Now, currently, there are artificial intelligence. People talk about deep learning. People talk about things to do with AI. So there is opportunity in artificial intelligence, and in this case, we can use deep learning to come up with what you call dose kernels. And here, I want to mention three of them. We have dose voxel kernel DVK, dose point kernel, and we also have local energy deposition. Now, the reason for this study is to collect the information from the MIRD, the simple formalism, combine with the Monte Carlo methods, and come up with something that is also accurate, but can be achieved within a very short time. And that is the whole basis of this study. So what we did is simply to come up with, we designed actually the generative adversarial network. This one we were able to train, so what you have here is the full feature map. This is something that we built ground up. We did use already trained models, but we trained it ourselves. So what you see rotating down here is the end result of the whole of this. So once we create a model, the model is able to predict our three-dimensional dose voxel kernels. This which you see down here. What you see on the right is essentially the training time lapse. So we trained it for quite a number of epochs. And essentially, this work was published somewhere last week. So this is the summary of what we have done. As I said, the Monte Carlo simulation is the best, is the most accurate, is the gold standard. But we said it takes long for you to accomplish the dosimetry. Now, what we are doing here is comparing the two. That is the deep learning that we created and designed. We are comparing the dose calculation, whereby we have our dose kernel that we convolve with time integrated activity. These are the spec CT. I'm just about to finish. Then we compare with the Monte Carlo simulations, and what you get is the three-dimensional dose distribution. So these are the results, if you are able to read. So this is a result that is testing three methods. That is our method, the GAN method compared with the Monte Carlo simulation method, and also compared with the mirrored formalism that we had already seen. So these three methods you can see from the mean doses. The GAN, the new method that we have come up with is actually comparable with the non-accurate methods. So again, this is just comparing the profiles. This is comparing the Monte Carlo simulation using the gate and our new method. And you can see the dose distribution. If you compare the profiles, they are more or less the same. The differences are within acceptable ranges. Thank you very much. Now, I just want to mention that for us medical physicists, for us to be able to carry out this kind of an exercise, this is going to be important in terms of policy changes, because what we need is at least 4 SPECT CT scans so that we will be able to accumulate the dose. Otherwise, if you just give the patient the drug and then they go home and you don't take the SPECT CTs after giving the medication, then we are not going to be able to do this dosimetry, and you won't be able to, quantify how much dose the patient is getting to various parts of the body. Thank you.
Thank you so much. I think some of these sessions need to be in the morning. Kama uliona physics form 3 kwa Toroka. But thank you so much. You can see how much people are doing and we are not aware. Maybe you should share the publication you mentioned so that people can now go further and read and refer back to their physics books. Thank you so much. Then our next presenter is Jackson Kipchumba, also on AI, algorithm nudging for dietary behavior change. Karibu sana.
Asante sana. Good morning, good evening, everyone. I'm Jackson Kipchumba. I'm a master student at Kenyatta University, Department of Food Nutrition and Dietetics, and I have interest in the side of nutrition. Just to clarify, food nutrition and dietetics has two major specialties. You can be dietitian, where you wait for patient at the hospital and then you intervene. Or you can be a nutritionist, where you prevent before the patient goes to the hospital. And I have interest in the nutrition part. And for the background, I specifically selected statistic for 2 mortality rates. For one is for infectious disease and another is for non-communicable disease, where food risk factors is found. And the reason why I did this is that the way the government communicate about risk related to infectious disease is different from the way it communicate on risk related to non-infectious disease. If you all remember, for example, during COVID-19, you could hear daily communication by the Ministry of Health about the prevalence, the new cases, and all that. But if you see the mortality rate in for example, in 2020, when you compare the annual death rates from non-communicable diseases where food is a risk factor, it exceeds the annual mortality from infectious diseases. Now, if, for example, if we have 11 million deaths in a year from non-communicable diseases, and that the same year when we had COVID, we had approximately 8 million deaths. But you saw the kind of investment the government made. the kind of communication they were making. And the reason where, and that which I am proposing a technology to address the gap is that suppose, for example, we all know that when you eat fatty foods like mandasi, for example, it is a risk factor for many, like obesity and other non-communicable diseases. But how will the government communicate that you don't need to eat mandasi, and everyone here like mandasi? It is sweet. It is because the cumulative risk time for food is around 10 to 20 years. You eat today, you don't know what impact it has done to you, and you tend to discount, to do what is called, you discount the risk because you cannot see the risk at that time. Now, what if we try to bring the risk closer so that before you purchase mandasi or anything related to which has been categorized as risk factors, what if you can see the risk at that point before you make the decision? And that's why I'm proposing, I will be jumping some of these because I've explained most of them. And that's why I'm proposing, again, before I say the proposal, when we are communicating risk related to food, we don't have to communicate like the way we are communicating risk related to infectious disease. The infectious disease risks are direct, and we tend to make better protective decision when we can see direct risk. Example, let me clarify about behavior. In my topic, it is about dietary behavior. There are two types of behaviors. There is involuntary behavior and there is voluntary behavior. Voluntary behavior is conscious. Involuntary, you don't have to think. Like if you approach a fire is a risk. You don't have to ask yourself, is this a risk? You just pull your hand, or you get yourself away from the fire. But we are having a risk called dietary risk. So this risk, you take food today, it is sweet, it gives you good moods, and me as nutritionist will tell you that is a risk. What action will you take? You are likely to discount me, or you are likely to take, if I tell you it is a risk, you will take avoidance behavior. You avoid, because our brain is wired to mostly adopt the status quo. And the status quo is something that is easy for brain to process. If you threaten the brain, in biology, if you threaten the brain, it will flight or fight. So if you give a threat to a brain about food, if you give a threat we have to nudge. The topic was algorithmic nudging. When we are communicating the risk about the food, we nudge the brain. We try to tell, we nudge the person. We try to tell him, try to do this because of this. You express the risk in a certain proportion with the action the person has to make. And so now, how can we bring the long-term risk closer to the person so that at the point of purchase, we are very interested with according to this theory, time is very important. If you communicate the risk when the person has already made the behavior, you will not be achieving anything. So, and we have to communicate the risk at the point of purchase. So, how can we now bring the long-term risk closer and within the shortest time, because when we are making a purchase of a certain food, for example, we take 50 to 60 seconds to decide. Like when we are going out, if we were to go and take a tea, you make this, you are asked to choose between this and this. You make within around 60 seconds. So how do we bring those risks closer? And then how do we now, because we don't want to tell person the risk only, we also want to tell why it is risk and what are the alternatives. That is what AR, which is augmented reality, comes in. Augmented reality. Augmented reality is a technical term where you can bring long-term risk, you can visualize long-term risk within the shortest time possible. And I know almost all of us have interacted with it. Like you are all consumers of TikTok. Sometimes you see a person, for example, he is seated, and then he or she stands up. He jumps into a plane, and you see traveling in a plane. So that is not possible. It is what is called augmented reality. So in this proposal, there is a way we can bring that experience from the time the person take a certain food. You tell him, if you take this food for a certain time, this will happen within very short time. So the proposal, this proposal will be implemented through TikTok. TikTok has two ways of creating videos. One way is where you just take your TikTok and you record what you are doing. Another way is what is called Effect House. Effect House, you create a template, and then you release the template to the community, to the TikTok users, and that template is now what this proposal is all about. You create a template, and that before someone uses that template, the time is out. And I will try to come next time with the actual prototype to show you how the technology works. Thank you.
Okay, thank you so much, Mr. Jackson. The presentation was very interesting about food, but unfortunately most of us are satisfied, right? We are from lunch, most of us are satisfied. So our next presenter will be Mr. Joseph Abuga Ayeni. I don't know if he's around. Mr. Joseph? Oh, unfortunately, Mr. Joseph is not around. Or he is asleep somewhere. Can you touch your neighbor? Look if your neighbor is still breathing. This afternoon talk, sometimes they can send you to sleep. Okay, if Mr. Joseph is not around, then let's have Mr. Peter Mucheru. Mr. Peter? Fantastic. Mr. Peter was awake. So Mr. Peter Mucheru will be presenting on care without gaps, integrating communication health into universal health coverage in Kenya.
So, thank you. Is it evening or good evening? Turn to your neighbor and tell them to wake up. It's an important time. You've been listening since yesterday, right? Have you heard anything since yesterday? Yeah, we've been listening since yesterday. Just you're seated next to someone, turn to them. Just turn to someone. We are talking about communication. We are now communicating. Turn to someone. And then you do what I say. Now, I want you, don't tell them anything, but I want you to let them know your name, what you took for lunch, and where you live without speaking. So ask your neighbor if they know your name, what you took for lunch, and what was the last question? Yes, so that's very important. There is a break in communication, isn't it? So that's why we need to think about integrating communication health into health coverage in Kenya. When we talk of communication health, we mean, I hope this, did you show me how to use it? The center? Good. Why communication? I know we all have children. In the morning we were asked if we have children, we have parents, we have teens, we have youth. We've talked about people since morning. Now, for success of such a conference, we need people to communicate. We've been communicating since yesterday. And when we talk of communication, this is the way we pass information, the way we receive information, the way we deal with what we have, decode it in the mind, and later give a feedback. So this is about speech, this is about language, this is about feeding, this is about swallowing, social interaction, and communications that we call pragmatics. So in many cases, you've heard about speech therapists in Kenya. Have you ever heard about speech therapists? Have you looked for one? If you've heard about them, say, ah. The us have it. So communication health is not a reality to many. The reason is, since yesterday we've had doctors talk to us. Ask them how many of these doctors knows of any speech language therapist within their locality. So that's why we decided to come, so that we can be able to talk to each other. So we've said our work will entail speech. That's how you communicate. Language, what you understand and what you communicate. Then feeding, very young children to adult. We've already come from lunch. And finally, about how safe do you swallow. Activity. In silence, I want you to gather enough saliva in your mouth. Swallow it. If you have water, you can take a sip. Take a sip of water. It's very practical. Nothing theory. Don't swallow. Keep it. Keep it in the mouth. Keep your water in the mouth. Then with that water in the mouth, hold your nose. Then you swallow it. And this one I'm doing a disclaimer at your own risk. How easy was that? It's never easy. So you realize that today or tomorrow you could lose your ability to swallow. You could lose the ability to swallow due to other challenges like stroke, like abuse of your voice. Every day we are screaming if you are preachers and such. So that's why we need to think about communication health. Communication health cuts across board. We start from children who are infant. You can see the infancy. We want to teach people how to talk. So communication health is not about children. It starts from very young children to the very old. So everybody needs communication, right? And in children, you realize that communication health will help in feeding, swallowing, hearing, and also something like communication. So it is very important to know that when we are talking or when we have communication health, it cuts across. Talk about speech, talk about language. We are parents. Are our children hitting the milestones? How many have young children below 3 years in this place? I'm one of them. Anyone with a child below 3 years? Oh, sisi yote ni wale wa huko mbele kabisa. So any child below 3 years that we are exposing too much on screens, cartoons, cocomelons, they are at risk of developing a communication disorder. So it is important for us to come and have a discussion together that communication disorder cuts across, and we need to take care of it at every level. So the whole of this, yesterday and today, we've heard much about curative treatment, but there is a gap when it comes to rehabilitative, because curative treatment, they'll really focus on medical stability. You hear the ambulance, right? When there is an emergency, we hear ambulances. But when that patient is leaving the hospital, do we hear the ambulance again? Do we ask where that patient is going after they have stabilized? So that's the beginning of rehabilitative service, where they come and check and ensure that this patient who has been treated by the curative doctor will end up into an educational facility, into employment, and into a social life like we are in today. With that, having said that, I did 2 comparisons of 2 patients. One, I saw them today in the morning. The other one, I was with them yesterday, the adult. We are talking about when we come and do the early diagnosis of communication disorders. For instance, at the point of birth, 0 to 3 months, we need to do the hearing screening. And after 3 months, if there is any condition, it needs to be diagnosed. And by 6 months, we need to start intervention, so that by the end of the day, a child with hearing loss, nowadays we say, oh, the deaf children can hear and talk. No child should go to a deaf school because they didn't have the ability to hear and speak. So we do our intervention early enough. And what is the prognosis? The prognosis is that all children who we do very early intervention, they are able to speak back and acquire communication just like any other typically developing child. This adult that I'm talking about here is a doctor in one of the major schools around, universities around. She suffered stroke 2 years ago. Then we started intervention. As I heard her yesterday, she was booked in for an interview, a promotional interview. Remember, when stroke comes, it hits communication, it hits the ability to speak, it hits the ability to even retrieve your own name. One of the first things that she did in my office was to cry because she could not call her own children. Imagine, you cannot call your own children. But as yesterday, we talked, and she's going for a verbal interview. She will be speaking with the interviewers for her promotion. So that is the power of communication rehabilitation. We did to find out what is the gap between the health system and the communication. So we know that one of the gaps that we have is accessibility. Like speech and language therapists are not accessible. I can see we are most on our phones. You can Google ASLTK, Association of Speech Language Therapists Kenya. Then you find out how many speech language therapists are there in the country, so that by the end of the day, you'll be able to know who is that speech therapy around you. So the workforce and training is a big challenge, and also care coordination, other than the cultural and linguistic diversity. For instance, I will ask, what were you told was the cause of that speech language delay? When I talked to the doctors in Kutrrh, they told me the mothers told them that the mother ate a lot of boiled eggs. That's why the child was delayed to speak. Is that true or true? Do you have such myths in your cultures? Yes. What is the cause of the delay? We are in the world where there is a lot of autism spectrum disorder. There are so many myths and theories around that. True or true? Very true. So we want to develop such a pillar, care pillar with all these things, those stuff. And one of the key ones that I like most is early identification and screening, so that we can ensure all children and adults, if it is an adult with communication disorders, maybe due to traumatic brain injury, stroke, we need to attend to those patients between 0 and 5 years post the accident, so that we can get best results. If it is a child who is below, just a young baby, anything between 0 and 3 years, that is the best thing. So we want to have such a pillar of care for these patients. And one of the most coming out, our sister has talked about teletherapy and digital health. That is very important. Because of the numbers that we have in the country, we can use that one to reach as many patients as possible. For instance, there are children like the one I've said, the one we are attending there with hearing loss. I've never met that patient in person. We've done that one on teletherapy. And as we speak, the child is integrated in school, in a normal school, and they are able to continue with their learning. To present to you a model of what we are talking about, we want to bridge the gap between the service and where the community where the children are coming from. So I'm presenting the Tower Kids model, that is Tower Valley School, and Kids Speak Therapy Clinic. That is my model that I'm trying to sell out. At Tower Valley School and Kids Speak Therapy, we have the services under the same roof. So parents and children don't need to go out. They just need to send their children to school, and then they receive all the services there. So we want to go where the children are instead of going where making them to come to hospital every day. In 1 minute, we are not short of policies. We have enough policies to make that one happen. And our recommendation is only the 3. Strengthen the workforce, establish referral pathways from medical doctors who are seated here since yesterday to us, and also invest on multidisciplinary team. Thank you very much. Because of the constraint of time, next time, go saying that there is a speech language therapist, and we are here. So if you want to find us where we are, you write down Association of Speech Language Therapists Kenya. You'll start getting where these people are. Thank you very much.
Thank you so much, Mr. Peter Musheru. Just the way Mr. Kapi said that medical physicists are normally forgotten in the clinical area. I know most of you have already forgotten Mr. Kapi's title, but whatever he presented. And also most of you have already forgotten the association of Peter Musheru for the speech therapy. Isn't it so? Nani anataka kukumbushwa? Okay, sawa sawa. So our next session will be for the Q&A. So I'll just call all the presenters that have presented this afternoon to come forward. We have seats in front here so that the audience can ask them questions. You can see Mr. Kapis, welcome. Engineer Ann, kuja. Mr. Peter, our only speech therapist in KU. Ishafika. KU ashasikia. Okay, so the topic this afternoon, it has been all about innovation in AI and integrated healthcare, that is holistic approach across specialties. So I can maybe give something small on the AI. As far as the AI is being implemented in the clinical setup, we should be very, very careful on how we are using it. At no point should we leave maybe the AI to run itself or to automate itself, because there's a scenario that has been trending on X about there's a certain company that it rehired like 300 employees after the AI backfired. I don't know if you guys have seen such a thing. Yeah, so just imagine such a thing happening in a clinical setup. You know, our life, we don't have any reverse gear of life, okay? So when such a thing happens, it will be something crazy. It will be also a disaster that I don't know if Dr. Solomon will want to handle. Okay, thank you. So our presenters are here. You can pose questions to them. You can just raise up your hand and the microphone will come directly to you. No questions? What does it mean? The topics were so hard. or it was afternoon after taking a heavy lunch. So when the audiences normally don't have any questions for the presenters, it's normally two things. Yeah, it's either you understood or you did not understand anything. So where do you fall? Okay, I can't see anyone. Maybe 30 seconds for maybe someone who is thinking of a question. Or you have one, you can take the microphone over there. Who?
Mine is for do I call it Mr. Peter? Because hapa leo tumesikia ni
Peter.
Ni DR doctor or engineer. So my name is Odna. For those ones who don't know me or have heard of me or are seeing me for the first time. So mine is for the Mr. Peter Musheru. Okay, personally I'm also hearing of the association for the first time, because we have these challenges even at the level 4 hospital outside cities. So in terms of the association, is there any deliberate effort to expand your services or your footprints to facilities that are ushago kama sisi? Like for me, I'm in Taveta, so you can imagine trying to translate Kimasai in sign language or Kiswahili in sign language, trying to say saratani in sign language. You are at the border. So maybe as an association, do you have any delivery effort to expand so that even guys on the ground, they can also know that there are people like you and they are very valuable in our service delivery? Because some of our colleagues, especially occupational therapists, some community health assistants were trained in basic sign language, but once the training was over, I think very few of them can remember anything. So maybe you need to apart from KU, you need also to do better in terms of expanding your coverage. And then for the other one, in the issue of partnership, although I was not there, but nitauliza in absentia. If it was covered, well and good. But I'm hoping that KU as these are good events that you've organized, but as facilities in the counties, with those good things that you've told us and shown us about here, what can we do to tap into these resources that you have? Because for example, for us in the outskirts, we have very big challenges in terms of referrals. We make a lot of calls to Wote, Mombasa, Wapi, trying to get where specialists are. And yet KU, from what I've learned, you nearly have everything, but not anything. So maybe in terms of partnership, how can leave alone the counties, hospital to hospital, what can we do to actually tap into these resources? We have OBS gains on the ground. They come across these cases. We have oncologists that are on the ground. They may not be aware of some of these services that you offer. So maybe if we can do a better job in partnership and linkages, our patients can have better outcomes. Thank you.
So thank you. You've asked what we are doing about so that we can go out. Exactly, this is the first thing that we are doing. I'm a few months in the office, and one of the first things that we are doing is outreach. Just you people, you know that we exist, because many people don't know that speech language therapists exist in Kenya. For many years, many speech language therapist association has been dominated by expatriates. I know even KU, where we are today, they don't have one. As far as my knowledge, we only have 2 institutions, public institutions, that is KU, KNH, and Nyeri PGH, now the referral hospital, who have the privilege of having a speech language therapist. It's not that we are not there, but majority of us are practicing privately. Why? Because there are modalities by the government and everyone else. I was talking to a colleague and I'm telling them, As we stand, we do not have a scheme of work, so we cannot even be employed by the government itself because we are working to get those things going. So we are on a good trajectory. In the association currently, we have like 30 who are fully registered. We are regulated by KHPOA, Kenya Health Professional Oversight Authority, and the regulation started just last year, I think. We've been in freelance, but it's a good start. So we are hoping that as time goes by, from where I sit is that we have quite a good number of students who also are coming up. We only had Kenyatta University, and I happen to be privileged to be the pioneer speech language therapist trained in Kenya. So I'm the pioneer and 2 more who are trained and graduated in 2021. So, but as we stand, we have like 3 more institutions training from diploma level, which diploma will become an assistant, maybe the occupational therapist that you're talking about, they can be facilitated to become that. Kenyatta University and University of Nairobi. So we know in the next 5 years, this history and story of lack of access will be addressed in one way or another. However, the number still remains low because it's 32, around 32 against 50 million Kenyans. The number is still too low.
So I would like to respond to the question on partnerships. So as KUTRRH, we are a national referral hospital, meaning that we are open to receiving referrals from all over the country, including Taveta, and we have a clear referral pathway. Actually, KUTRRH has a toll-free number that allows you to call in, and it's a very simple number. It's 1558, so you are able to call, and we have a referral number available on our website, and we receive patients irrespective of their geographical location. So Taita Taveta can actually refer patients to us. And as far as the other partnerships are concerned, as KUTRRH, we have a lot of hospitals coming to benchmark with us. So we are not just about having the premier service, but we are also about expanding and also setting up our other centers that can be the same as KUTRRH through mentorship. And now when people come to benchmark with us, it enables them to set up similar services where they are. And Taita Taveta can also take advantage of the services that we have by maybe requesting KUTRRH if they need mentorship in terms of upskilling their staff, and also making their services better. We are open to those collaborations because as a referral hospital, I think we are not just, we are a referral and research hospital, and we are here to make services better, not just for the people who live around KUTRRH, but for every citizen of this country. So yes, we are ready to partner with Taita Taveta to make the services for that Kenyan in Taveta, that citizen in Samburu, that citizen wherever, irrespective of their geographical location. Thank you.
I hope your question has been answered. You can take the microphone over there. Be thinking of those questions. These presenters are here because of you.
Good evening, everyone, and thank you so much for the presenters. My name is Jacqueline Tindi, Deputy Director, Nursing Services at KU Referral. My question goes to our engineer, Anne. I've seen you presented the various modalities of AI, which is very nice, very interesting. And with the advanced technology that we do have, I wanted to request if we can dive deeper on the practical part in the clinical areas, especially the critical care areas, when we receive the new machines and the pumps that we expect with the new models that are going to come with AI, how it can be very practical and support the teams on the clinical area and the bedside in terms of drug management and even feeding management, because that is where the technology is going to. So probably if we can be able to partner in the clinical areas so that we can be able to support the team, even if it's a project, to see how we are able to utilize it to make the work of the clinical team at the bedside to be much easier. Yeah, thank you.
Thank you, Director, and I'm happy that it's coming from you because you are part of management and you are going to support us on this. Yes, true, we need AI because that's where the technology is going and that's where we are. And we keep saying that we are looking forward to future and already future is here with us. So among the AIs that we can start off are the radiology AI tools. They are already existing and some hospitals are using them. So in KUTRH also what we need more is the telemedicine bit where our patient can be seen because they travel far and wide. They can be seen and they'll save the cost and the time for traveling to come to see the consultants. And also these specialists are rare. So this will help us see more patients. And if we implement the AI tools, it will even make it more easier and efficient to see our patient. And just to mention, in today's Nation newspaper, there's one of the researcher by the name Dr. Samuel, who works in ILRI, and he has been given a grant by the Gates Foundation. And the research that they will be doing is they want to get an AI for a public health tool, and it will help them to detect, the tool will help to detect diseases, and also it will help them even track the resistance of the drug resistance, and they will be using the wastewater. And so I'm happy that also the nation is embracing this, and that's the direction we are going. And at KUTRH, we are ready to work on that given the resources. Thank you.
Cool. Any other more? One question. Okay, as you are thinking, maybe I can ask Engineer Anne one question. Maybe do you have any collaborations in mind between maybe the biomedical engineers and doctors and clinical scientists? Maybe to ensure that these AI solutions, they are clinically relevant rather than just technological innovations.
Let me say these can be the starting points. I'm happy with this conference, and with this conference, it can be our first step to start collaborations with the clinicians, and I believe we will achieve more and more as time goes by.
Thank you. Having no other question, I think we can have a group photo with the presenters. Then we'll have to end our session. Then we'll hand it over to Dr. Shem to take us through our next final session. So maybe you can stand up. The camera guy, you can take a photo of us. Doctor, come. Oh, even the camera guy left. Okay, thank you so much. Let me hand over to my fellow co-chair since Shem is not around. Maybe you'll be able to take us through the next session. Thank you.
Thank you so much. At this juncture, I'll ask our director, Dr. Kutrrh, can come and close for us.
Good evening, everybody. Oh, you're all looking tired, not excited. What's happening? I hope we've had a wonderful 2 days of engagement. For me, I thought Abed was going to do the closing remarks, so I'm trying to tidy up my speech. But for me, I'm truly grateful and honored for all of you who responded to our call, who submitted their abstract, our students who submitted their posters and have been here the whole 2 days. Thank you very much for that. I know this conference was rushed. It's only, I think, around April we realized that we had a bit of money in the budget. So we decided not to give it back to the government. We use it for this conference because it's what it was intended for. So we only started planning for this, I think, just over a month or about a month for us to put this together. So when I say I'm happy that at least we had this kind of a turnout, we are truly happy. So thank you, everybody, and I hope you've had a wonderful time of engaging. You have learned a thing of two. You have forged collaborations. We have new innovative ideas. We are inspired. For those who did not present, I have gotten very many messages and talks out there. Oh, I wish I knew. We have so many things we would have presented. We have so many things. So it's a fast one, and it's been wonderful. So I'd like to start by thanking the scientific committee, which was led by Dr. Abed. We started off as two committees. There was the scientific committee and the organizing committee. But being the first time we were doing this, we found ourselves working together. So I'd like to thank the scientific committee, the organizing committee, everybody who has played a role to ensure that this conference was successful. I thank you all. It's been a rushed 2 weeks, but we have made it and we've done a good job. So thank you very much. I'd also like to thank our sponsors who came through under such short notice. We had AstraZeneca, we had Roche, we have FNS Scientific, we had Square Pharmaceuticals. We also had sponsors who took up our exhibition spaces. We have Generics Africa, amongst others. Thank you so much for coming through under such short notice, and we hope that when we reach out to you for next year, you will be here as well. I'd also like to thank our management and our CEO, who has been very supportive when we needed. Remember, we were nearing the end of our financial year on June 30th. So they've been really supportive to ensure that we did our procurement. Everything was approved in good time, and we have received tremendous support from them. Our partners who have come, NCI, the other partners we had yesterday for the hearing, clinic, everybody who has come, everybody who's here. If I don't mention your name, we truly appreciate the support and working with us through this journey, holding our hand. We have learned a lot from what our partners are doing in this space, and we hope you'll continue to work with us through this journey. I'd also like to thank God, because truly it came a point where I was wondering whether this would come through. I'm sitting there and my team is working very hard, and we are all working very hard. I fell sick last week, so I was wondering, will this thing come through? Will we have participants? Sometimes you can do all this and then there's nobody sitting here. But he has been faithful. We thank him for his mercy and for his grace and wisdom that he has given us through this planning. Everybody, asanteni sana. I don't know what else to say, but what I can promise you as KTRH management, this is not the end. Next year we are coming back bigger and better. We are starting our planning in October. We are hoping, I don't have the actual date, but we are looking at earlier dates in the year, around March, April, because we don't want elections to catch up with us. But this will be something what we have agreed. It's going to be an annual event. So please start planning, start writing. Let's grow our research as a hospital. I know we have started. The research directorate is sending out calls to all our staff members. If you see something that you'd like to work on, AI space, there's a call out actually. Those who are in the AI space, please come and see us. We are trying to form a team. So let's grow our research, let's grow our innovations with the goal of improving our health systems and giving better care to our patients. So thank you for that. I think we had something else. I will hand over. Asanteni sana. And to our super MC, you know the MC claps for all of us and we never clap for him. Can we clap for our super MC? We have to give him his best clap. Let me tell you his best clap. He told us in his village, I don't know whether he has succeeded at that space, that when you marry a girl, you have to clap a certain type of a clap. I don't know whether he told you, so that the girl doesn't disappear. Then there's another story to it, but that's what I remember. So we are going to clap for him, his favorite clap. I'll show you. Hold for me the mic. So we are going to clap. 1, 2, 3. Then you say, Ke Mamio. 1, 2, 3. Ke Mamio. 1, 2, 3. Ke Mamio. 1, 2, 3. Ke Mamio. So thank you very much, our super MC. He's talented and he should, I think maybe I should move him to another department, but I'll keep him. So thank you so much. Asanteni.
Thank you, Azam. Thank you, Doc. As I'm welcoming the MC, maybe just a reminder. I had forgotten to tell you something. First of all, I know most of you have forgotten my name. My name is Chanzo Ian, a medical physicist in Kutrrh. And just the way Kapi said, we normally forget ourselves, just the way madaktari mnatusahau in the clinical setup. So allow me to take this chance to inform you about our upcoming conference. The Association of Medical Physics Kenya is having a conference on November. And right now there's a poster going in all our social media pages for calling for abstracts. So we are inviting everyone. At least you submit an abstract so that you can meet in November for an interesting session with the medical physicist of Kenya. Thank you. Dr. Shem, welcome.
Thank you so much. All protocols observed. I would like us to recognize and appreciate our giver of the vote of thanks. That is also the other person who's forgotten. So to our director, Dr. Caroline, let's appreciate her in a special way. Now, the second part of the story that she didn't give you is that when you marry that lady and her cheek happens to hit the hand of the husband accidentally, then she may go back home. And if that happens, we bring her back with a clap known as the Skonyo clap. So you clap and you dance. You clap and you dance. So let's all be upstanding. DJ, give me the first song. Leopard. We want to appreciate her for being the leopard that she has been. The leopards almost beat our colonizers yesterday. Eh? So we want to recognize her for that. So DJ, nipatie hiyo. So we'll start with the Kimamyo, then we move to the Skonyo. Are you ready? So let's go Kimamyo. 1, 2, 3, Kimamyo, 1, 2, 3, Kimamyo. Last one, 1, 2, 3, Kimamyo. Then Skonyo, you clap right, left, right, as you say Skonyo, 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 chini, juu, chini, juu. Wonderful. DJ, sijui amepotelea wapi. Anasema ngoja kidogo. Please have your seats. We'd like to recognize our sponsors again in a special way. And if they are here, please be upstanding. AstraZeneca, are you there? One clap for them. Wonderful. Are you there? Roche, Mpo, and clap for them. F&S Scientific, they gave their talk. They are there. They are still in the tent there. Cameraman, waonyeshe, waonekane vizuri. Wonderful. Clap for them. Beacon Pharmaceuticals, wanajiita Generics Africa. Beacon Pharmaceuticals. And lastly, unajua ule mtu come through wakati yani uko na kashida, uko like uko na dhao mbili urgently. Sijui everyone has mtu wake wa dhao mbili urgently. Actually I think if somebody was to start a circle inaitwa dhao mbili urgently, ingeenda mbele sana, si ndio? Because everyone has everyone. I think we should just all contribute 2,000 somewhere na ifike, si ndio? So for Square Pharmaceuticals, where are you? Square Pharmaceuticals. Mpo wapatiwe yao moja, they came through na hiyo dhao mbili urgently. Thank you. So DJ nipatie hiyo. Let's all be upstanding. We appreciate all of us for coming, for being the leopards that you've been. So I want us to do the skonyo clap as we do that song. DJ niongezee tu kidogo. So we go skonyo, 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 skonyo. So the direction I point is the one you clap as you dance. Aya, twende skonyo. Skonyo, skonyo, skonyo. DJ ndiye ananiangusha. Aya. Ndio hiyo. DJ nipea juu Okay, let's go left, right. Tell your neighbor, thank you for coming for this conference. We hope to see you next year. Next year it will be bigger, better, and more learning will happen. Wonderful. So let's go skonyo. Let's go. Skonyo. 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 Alafu clap ya mwisho. Nataka tu clap hapo mbele alafu usiachilie. Alafu sasa kiuno kidogo. Tufanye practice. Piga hapo mbele. Aya, end around. End around. End around. Hey, thank you for coming. Thank you for being here. You are the best, Wonderful. So we thank you all for coming. I'll ask that we remain upstanding for the closing prayer. We'll have the closing prayer in Ekegusi by a volunteer.
Okay. I won't pray in Ekegusi, but let's pray and let's bow our heads. Our Heavenly Father, thank you, Lord, for this day. Thank you for leading us from the beginning of this conference yesterday. We ask for your leading and we appreciate all who have participated in one way or another, from the presenters to all who supported, our sponsors, the committee, the leadership of the institution, and all who supported this venture. We thank you and we honor you, Lord. Thank you, Father, as we have come to the end of it. We live here challenged to go and give better care for our patients, and more so that we can be able to give them the highest attainable standard of care. Thank you, Father. We pray that you may grant us the wisdom, the energy, the strength, the wisdom to do all this. Thank you, Father. We living here, we are parting ways. Some have come from far. Grant them safe journeying mercies as they go back to their homes and residences. Thank you, Father. May you be with us till again when we shall meet according to your will. It's our prayer in Jesus' name. Amen. Thank you.
Thank you, ladies and gentlemen. Make sure you pick a business card or two. As we say, wherever you are, continue doing what you're doing. Tuendelee na kazi safi.
DJ Shinsky.
So tunasema tuendelee ama tusiendelee? Tunasema tuendelee na kazi safi. Make sure you pick a phone number or two. We have NCI in the house. Make sure you get their phone number, their email address. Wako na pesa. Muliambiwa wako na pesa. Tunasema tuendelee na kazi safi. Research iendelee. Wonderful.
Kaningekuwa msanii wa sanaa ya silaha, ningekuwa na jamii ya masadam kawa saba na mabunduki na makofia kabila.